we will have our participants who are thronging into this venue. Let us start the first session on fever with the blessings of Almighty God and the cooperation of the organizing committee headed by our able chairman, Dr. Sukumar ji, and organizing secretary, Dr. Satish Kumar, and finance secretary, Dr. Narsimhan, and scientific chairman, myself. It's a pleasure to welcome you again. As a days proceeds on, you will feel the pinch of the scientific knowledge you are going to acquire. The scientific knowledge, technical skill, and human understanding, it is all, we are embodiment of all this thing. As healthcare provider to the needy people, we are elected to update our knowledge, inculcating in our daily practice. Let us start the first session on fever. Francis Buibody, who is a renowned French physician, told, if something is there like famine, fever, war, fever is the worst one to be afraid of. So let us start with this. I call upon Dr. G. Ilangovan to be on the stage, to be honored by the API Vellore District Branch, the great TAPICON 2025. I request our chairperson, as a token of gesture, to to put this salve on the first speaker, none other than senior physician Kadalur. I think the volunteers can take care of the proceedings. You can introduce the speaker. I request Manigandan and Balamurugan to be on the stage, please. Venkatraman Su.
May I request our chairpersons to kindly present a memento to Dr. G. Ilangovan as a token of appreciation. May I now invite our esteemed chairpersons for the first onto the stage, Dr. V.G. Arun from Salem, Dr. G. Manigandan from Valaja, and Dr. Soumya from Vellore to chair the session on fever. A warm welcome to all of you.
Good morning to everyone. At the outset, I would like to thank the organizing committee for giving the opportunity to chair this session. I would like to introduce Professor G. Ilangovan, MD. He is MBBS and MBBS from Tanjavur Medical College and postgraduate from Madras Medical College. I invite you to speak on fever, sir.
Thank you very much. நடுவர்கள் உள்ளிட்ட உங்கள் அனைவருக்கும் எனது அன்பான வணக்கம். My sincere thanks to the organizing committee headed by our senior physician Dr. Sukumar, scientific committee chairman Dr. Vetrivel, Satish Kumar, organizing committee chairman, and other co-committee members, and the chairpersons for giving me this opportunity to stand before you in this prestigious auditorium. I am very much humbled with your kind words and blessings on this dais. It will be a lifetime memory for me to carry on this impression in my mind. So I am very much blessed and humbled. Being the first session, I would like to quote the gospel words of Subramania Bharati. எண்ணிய முடிதல் வேண்டும், நல்லவை எண்ணல் வேண்டும், திண்ணிய நெஞ்சம் வேண்டும், தெளிந்த நல் அறிவு வேண்டும், பண்ணிய பாவமெல்லாம் பரிதிமுன் பணியைப் போல நன்னிய நின்முன் இங்கு நசித்திடல் வேண்டுமன்னார். ஐயன் வள்ளுவர் தொட்டனை தூறும் மணற்கேணி மாந்தர்க்கு கட்டணை தூறும் அறிவு என்ற வாசகத்தின் அடிப்படையிலே வாய்மொழியின் வழியிலே இந்த கருத்தரங்கம் நான் துவங்கி வைக்கப்பட்டிருக்கிறது. I start my presentation. Pyrexia of unknown origin. To reveal the unrevealed facts of pyrexia of unknown origin. As already pointed out by the scientific committee chairman, fever, famine, and war, as per Williams Sir Osler quotes, fever is the first priority against the human scourge. So fever is sometimes, it gives a lot of embarrassing circumstances in our clinical practice. So I take up on the subject, pyrexia of unknown origin. Yes. Give me present it. Laptop. Peter Staff and Beeson in 1961, they have coined the terminology, pyrexia of unknown origin. Now, you can see the objectives of PEO. Before going to the PEO proper, we should know what is fever, and genesis of fever, and clinical types of fever, and causes of fever, what is PEO, and types of PEO, approach to find out the unknown origin of fever, course of PEO, and newly emerged fever and research of fever. Next slide, please. So let us define fever. It's a centrally mediated elevation of body temperature in response to an insult or stress. So 1/3 of the sickness exhibit fever as symptoms. Homeothermic are human beings, mammals, birds, and temperature doesn't vary with the environment. Poikilothermic are reptiles and other insects. They change the body temperature as the environmental changes, also called as temperature conformers. Fever occurs in conjunction with an increase in hypothalamic thermostat set point, similar to home thermostat in our bedroom. Fever is a clinical response, natural reaction to infection, injury, inflammation, immune mediation as a protective mechanism in warm-blooded and livings. Central nervous system hypothalamus orchestrating the fever response through neurological, endocrine, immunological, and behavioral mechanism, often accompanied by sickness with the metabolic changes. The genesis of fever, the integration of the visceral mechanism that controls the heat loss and somatic mechanism that governs the heat production. Posture, shivering are controlled by hypothalamus. A local sensory mechanism also exists which maintains the temperature of blood. The integration, next. Fever is mediated through interleukin-1/6, monocyte and macrophages stimulated, results in cytokine release. The pyrogenic cytokines which elevates set point of hypothalamus that cause fever, sweating that dissipate fever. Sweat secretion in immature in a newborn and starts in infant at 6 months of life, mature at the 1 year of life. Preterm babies born before 32 weeks cannot sweat. Children with the familial dysautonomia, Relay Day syndrome that cause hyperthermia primarily reflects the abnormality of hypothalamic receptors or of the peripheral cutaneous nervous system as it modulates blood flow. Body temperature is increased normally in the postprandial state in adult, and menstruating woman, morning temperature is lower in the first 2 weeks before ovulation and then rises by 0.6 degrees Celsius in the luteal phase. Non-shivering thermogenesis occurs in hormonal disorders, adrenaline and thyroid hormone. Next. Pyrogens are substances that produce fever of, it may be exogenous or endogenous origins. The exogenous pyrogens are from microorganisms, bacterial cell wall, exotoxins, lipotrophic acid, peptidoglycan, enterotoxins of gram-positive organisms, and endotoxins are from the liposaccharides of gram-negative organism. The endogenous pyrogens produced by host in response to infection, inflammation, immune reaction. The endogenous pyrogens are induced by formation of polypeptides by stimulation of the host cells, monocyte and macrophages of the endocrine system. Pyrogenic cytokines are interleukin 1, 2, 6, and 9, 11F, and TNF, and BTNF, and so on. Cytokines acts on the endothelial cells of the hypothalamus to release prostaglandin E2, which act on the vasomotor center of the thermostat to change the set point to produce fever. So, fever in inflammation is due to mobilization of the endogenous pyrogens from the site of inflammation. Additionally, decrease in albumin, transferrin, and dehydration can precipitate fever. Pyrogens are released from the infection, toxin, cell injury, inflammation, cell destruction, and immune mutation. Metabolic causes of pyrogens are hormonal and malignancy. Malignancy fever mediated by the interleukin, immunomodulators, and cytokines. Pyrogens are released. Next. The hypothalamic fever due to the impaired thermoregulation. Due to trauma, tumor, brainstem fountain bleeding, and cell point is raised in which fever is central origin that do not respond to antipyretics except to external cooling measures. Hyperpyrexia occurs in severe infection and bleeding from the central nervous system. Next. Immune-mediated illness, cytokine-related fever due to fever in sickle cell disease, hemolysis, autoimmune disorders, inflammatory bowel disease, due to endogenous pyrogens released from the leukocytes of reticuloendothelial system. Although fever presents patterns tend to be non-specific, they may sometimes provide potential diagnostic clues. There are 3 classical types of fever. As you know well, continuous fever, no fluctuation more than above 1 degree Celsius, and remittent fever when the daily fluctuation exceeds 2 degrees Celsius, and intermittent fever, and fever present only for several hours during the day. When paroxysm by intermittent fever occurs daily, it is called quotidian. When on alternate days, it is called tertian. When 2 days intervene between the consecutive attack, it is called quartan. And relapsing fever occurs daily, 3 to 6 days, a fever-free interval of 1 week duration, then fever supervenes. Next. The types of PO. In 1991, Durack and Steed arbitrarily modified and classified PO. Classic PO, nosocomial PO, neutropenic PO, and HIV virus-associated PO. The name itself is self-informative. Classic PO, nosocomial, and neutropenic, HIV virus-associated PO. Next. The nosocomial fever temperature is 38.0 degrees Celsius on several occasions in hospitalization in whom no fever at least 24 hours at the time of admission, and infection was considered in the incubated period. Common conditions are Clostridium difficile enterocolitis, drugs, pulmonary embolism, septic thrombophlebitis, and sinusitis in IMC intubated patients. Next. Neutropenic PO, WBC is less than 500 cells per microliter. Common conditions, invasive aspergillosis, candidiasis, and opportunistic infections. Next. HIV-associated fever, fever of more than 4 weeks duration, commonly occurs in cytomegalovirus, pneumocystis jirovecii, mycobacterium avium, Kaposi sarcoma, lymphoma, salmonellosis, cryptococcus, toxoplasmosis, and histoplasmosis. Next. The prevalent cause of PO. The infection constitutes 21 to 54% of the conditions of PO, and non-infective inflammatory causes 13 to 24, neoplasm 6 to 13%, immune-mediated 4 to 6%, and miscellaneous rest of the condition, including factitious fever and fever, sometimes fraudulent fever. Among the non-tuberculous conditions, brucellosis, rickettsia, malaria, infective endocarditis, collagen vascular disease, immune-mediated SLE, Still's disease, polymyalgia rheumatica, MCD, and polyarteritis nodosa are to be considered. Among the malignancy, the fever due to interleukin response release of immunomodulator and cytokines, commonly seen in lymphoma, renal cell carcinoma, leukemia, and other malignant disorders. And granulomatous disorders, apart from the TB granuloma, non-infectious sarcoidosis, granulomatous hepatitis, left atrial myxoma, and Crohn's disease, and Whipple's disease. The infective fungal granuloma, histoplasmosis,
1 more minute left.
sporotrichosis, and tularomycosis. No. Next. Fever presentation, fever with the low platelets, infectious, non-infectious conditions, bacterial, fungal, viral, and parasitic conditions, non-infectious hematological and non-hematological conditions. Next. Fever with the altered sensorium, infectious, non-infectious, bacterial, fungal, viral, and parasitic conditions, non-infectious, local, and systemic conditions. Next. Fever with jaundice, failure, liver cell failure due to infectious, non-infectious. Please wait. Fever with jaundice, infectious, non-infectious. Next. Drug fever, variety of antibodies and anti-cancer immunomodulators are common. Fevers resolves after stopping the drugs. Next. Laboratory investigation, apart from the routine investigation, matrix-assisted level desorption and ionization time is a recent one. A time of flight mass spectrometry. Revelation is rapid identification of microbes, bacteria, fungi, TB within 20 minutes. Magnetic resonance assay, it allows the direct testing of the blood, urine, assays of magnetic biosensor technology. Molecular methods, it involves amplifying the genetic materials of the pathogens, enabling the accurate identification of test quantification. Next. Common conditions causing PUO, scaraptitis, influenza, occult abscess, infected endocarditis, chikungunya, COVID, disseminated tuberculosis, autoimmune disorders, central nervous system tuberculosis, giant cell arteritis, malaria, Japanese encephalitis, biliary lymphangitis, Pilipsin fever and Hodgkin lymphoma, and multiple myeloma and leukemia. Next. A different diagnosis of fever. The important difference diagnosis is fever-like illness, that is hyperthermia. Fever is centrally mediated, hypothalamus mediated. Hypothermia not centrally mediated. Elevation of thermostat point occurs in fever. No elevation of thermostat point in hyperthermia.
Final minute.
Pyrogens are responsible for fever. Non-pyrogenic hypothermia, cytokine-mediated fever, non-cytokine-mediated. Variation temperature occurs in fever. No variation temperature in hypothermia. Exogenous pyrogens are mediated. There is genetic pharmacokinetic hyperthermia mediated. Antipyretics are useful in fever. Antipyretics are not useful in fever. Next. This diagnosis based upon the history, clinical examinations, and other joint unilateral headache, surgical history, prosthetic implant, prolonged immobility, and so on. Next. The emergence of new human pathogens, reseasonal fever like Zika virus, Crimean Congo hemorrhagic fever, yellow fever. Then next. Quezon forest, Nipah virus was seen in Kerala, Ebola virus, West Nile fever, Japanese encephalitis, and COVID-19 and its mutations. Next. Paradox of unknown origin treatment, the mortality rate of PU is less than 10%, with most deaths occurring as a result of malignancy. There are, however, several illnesses when suspected should be treated empirically until they can be confirmed or excluded. These include infected endocarditis, giant cell arteritis, and malaria, and central nervous and tuberculosis. The ultimate aim should be to look for the cause of fever and treat it accordingly. Fever is not always routine infection. Malignancy is not an uncommon cause of fever. 1/3 of fever cases do not teach human mind to reach a definite diagnosis, need to keep sustained search. Be guided by careful history with the potential clue and examination, confirm the clinical diagnosis with the laboratory. Next. Lost it. Next. A child can be identified when the father's identity is known. Likewise, the causative factor for the fever should be identified to know the correct etiology and clinical diagnosis of fever for proper, better treatment care. Next. Hippocrates is the father of medicine. Mahatma Gandhi is considered to be the father of our nation. Pandit Jawaharlal Nehru is considered to be the father of parliamentary democracy. Baba Sahib Ambedkar is father of Indian Constitution. Next. Who is father of fever? Anybody? Who is father of fever? Any answer? I will give a gift. Yes. Pyrogens are the father of fever. Pyrogens are the father of fever. Thank you for giving this opportunity. Thank you very much.
Thank you, sir.
Thank you, sir. We'll have the discussion at the last, sir, at the end of the session.
Thank you.
Now, we welcome Dr. Virgin Joanna from Madurai to talk about expanded dengue syndrome, the spectrum. Welcome, ma'am.
சார் நான் என்னோடது
I'd like to welcome Dr. Virgin Joanna from Madurai. Thank you, ma'am, for honoring us with your presence. And ma'am's CV has to come on, but ma'am will be speaking on expanded dengue syndrome, a very common problem that we all encounter in our various practices. And ma'am, I'll hand over the stage to you. They'll just put on your CV also, ma'am.
Thank you, ma'am. And at the outset, I thank the organizers for giving me this opportunity.
So as written here, ma'am is a professor and HOD of Velomal Medical College and Research Institute. Ma'am, please go ahead with your presentation.
Ma'am, you can just put next slide, and when you're changing, they will change. Match it now. I think that will be easier.
Okay. 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 At the outset, I thank the organizers for giving me this opportunity. Expanded dengue syndrome, as we all know, dengue infection is usually caused by the virus, dengue virus, by the vector, and we have an incubation period of 0 to 7 days. With the onset of the symptoms, there is a febrile phase which is lasting for 7 days, followed by a critical phase period which is about 1 to 2 days, followed by the recovery phase. Next slide. Next slide. And this critical phase is usually has features of shock and bleeding, and which is evidenced by an increasing hematocrit and falling of the platelet count, with the serology positivity initially by NS1 followed by IgM and IgG. Next slide. When we look into the timeline of dengue fever, the history starts around 265 when it was initially considered as water poison. Later the virus was identified around 1753 and later the vector was identified around 1906, and with the invention of all the other viruses, and we had the epidemics between 1990 to 2021. 2010, almost those 20 years were the period where we have revised our management on dengue fever, and now we are progressing towards the invention of the dengue vaccines. Next slide. So initially, the classification by WHO was going like this, which said that it was classic dengue fever, followed by grade 1, grade 2, and grade 3 and 4, where grade 3 and 4 included the symptoms of shock. But when we looked into the clinical features, the scenarios, it was not actually exactly the distinctions between hemorrhagic and shock, and it was the overlay. So around 2009, WHO, next slide, the WHO has revised the classification of dengue fever as dengue and severe dengue. Next slide. So this classification says that dengue fever with and without warning symptoms, and both of these phases can progress on to severe dengue, where the severe dengue features were included as severe plasma exchange, plasma leakage, severe bleeding, or severe organ involvement. The warning signs were described as abdominal pain, persistent vomiting, mucosal bleed, lethargy, and the liver enlargement. So having said this, next slide. There was always a battle between the bugs and the humans, and we were trying to win the battle always, and the bugs generally take a U-turn and produces a different scenario, and around the last 10 decades we were finding dengue with very different presentations. Next slide. This came to the nomenclature of expanded dengue syndrome. So WHO has again revised the classification at 2011, saying that there is almost another entity called an expanded dengue syndrome or isolated organopathy. When do you say expanded? Next slide. When do you say expanded dengue syndrome? Next slide. And unusual presentations of the patients with severe organ involvement. Either this can be associated with dengue fever or dengue hemorrhagic fever, usually associated with other co-infections and comorbidities. The organopathies were declared only when there is no other precipitating event or any other coexisting metabolic abnormalities. Next slide. Who are the patients are at risk? Pregnant women, infants, elderly, patients with coronary artery disease, hemoglobinopathies, and immunocompromised individuals. Next slide. So a case scenario. This is 23 years old female presenting with a high-grade fever, altered mental status, focal seizures, presenting to the ER. GCS was very low, hypotensive, hypoxemic, tachypneic, with low grade of fever. So the provisional diagnosis of sepsis was made, progressing on to an MODS. So a normal platelet count, but the serology for dengue was positive. Next slide. So coming back to the classification, next. Is this severe dengue with the features of impaired consciousness or otherwise called as dengue encephalopathy? Usually dengue encephalopathy, the MRI is normal, CSF is normal, the patients have an altered sensorium with all the other features of dengue. Next slide, we proceeded on with an MRI. The MRI has showed T2 weighted images with hyperintense, and this is a double donut sign, usually presenting with microhemorrhages. So here your CSF is also serology positive for dengue. So this is an entity called dengue encephalitis. So whenever patients presented with a neurological dengue fever presenting with a focal deficit, blurred vision, seizures, quadriparesis, frontal release signs, abnormal posturing, facial palsy, we always think in terms of expanded dengue syndrome. Next slide. This is another case, 68-year-old male presenting with fever, seizures, altered sensorium. MRI has showed an hyperintense signals on the occipital lobe. Usually this is a posterior reversible encephalopathy press. And this is reversible actually. On treatment of dengue, this is actually reversible, and the patient's vision improves after the treatment. Next slide. So usually the CNS manifestations, what all we have come across so far, it can be classified as central, peripheral, and post-infective immune-mediated and muscular presentations. In central, we have encephalopathy, encephalitis, dengue-associated stroke, PRES, and RILS. Peripheral, NMO, optic neuritis, maculopathy, macular edema. Muscular presentations can be like hypokalemic paralysis, chronic fatigue syndrome, rhabdomyolysis, post-infective GBS, ATN, and ADM. Next slide. This is a case that has been presented in our hospital who had a reversible lesion in the splenium of corpus callosum, which was actually reversed after the treatment. Next slide. Next. So the learning point is, whenever we are going to have an examination of CSF in febrile patients with altered sensorium, thinking in terms of CNS infection, always do it with caution when you have a serology positive for dengue fever. And always the presentation need not be very typical. You may not have thrombocytopenia, and fever also can be very subtle. Next point. So fever, the next system, you have a dengue fever with cardiac complications. Next slide. Next. Usually the cardiac injury is due to direct cytokine injury, direct invasion, or due to the lactic acidosis due to impaired circulation. Next. Next. It could be a presentation like acute MI, as in this case. Next. Could be an rapid ventricular tachycardia. Next. Could be an acute myocarditis like with all ST elevation. Next. Could be an atrioventricular dissociation. Next. So usually whenever you have a dengue fever with an ECG positivity, go for an cardiac markers, and if it is also abnormal, you think in the you need to take an echocardiography, and you have to think in terms of expanded dengue syndrome in such cases. Another scenario, when DSS is not responding to fluid therapy, you also have to think of it. Next slide. The dengue fever with pulmonary complications. Usually patients, when presenting with respiratory failure, think of ARDS or diffuse alveolar hemorrhage. Usually dengue fever with pulmonary complications usually have a co-infections like Nipah or hantavirus. Next. Next. Gastrointestinal manifestation. Usually the usual dengue fever has transaminitis or a calculus cholecystitis, or you can even have a non-obstructive intestinal obstruction, but rarely they can progress on to liver failure. Next slide.
5 more minutes.
So this is a dengue-related acute liver failure is also expected, usually in a pediatric age group. Whenever the patient presented with persistent nausea, vomiting with an elevated AST, ALT more than thousands, and you have a decreased platelet counts, think in terms of acute liver failure. The mortality is relatively high in these patients. Next slide. Renal complications, usually due to transient tubular dysfunction or due to the mismanagement of the IV fluids and the shock, you can have AKI, but as there are also reported cases of glomerulonephritis, nephrotic syndrome, and IgA nephropathy in these cases. Next slide. Some other rare complications that have been reported in the literature. Next slide. Next. Spontaneous splenic hematoma. Next. Splenic rupture. Next. Hemophagocytic lymphohistiocytosis. Next. And expanded dengue syndrome presenting as subacute thyroiditis. Next. And an eye manifestation like foveoitis or macular edema. Next. Jaw osteonecrosis. These are all some rare complications that have been explained with expanded dengue syndrome. Next. Next. So usually pathogenesis being expected like immune-mediated injury, or it could be a co-infection with malaria, chikungunya, Zika virus, plasma exchange leakage which has caused in these symptoms. It could be a hypoxic injury or in a neutropenic patient or due to a direct invasion of the virus in the other organs. Next.
Ma'am, 2 more minutes left.
To conclude, This is only a tip of the iceberg. Many are underreported and under-recognized. The updated knowledge and a high degree of suspicion in dengue fever during epidemics helps us to recognize more amount of expanded dengue syndrome. Thank you.
Thank you, ma'am. A very clear and I think very informative, and the timing was immaculate. So, ma'am, we request you to wait for the end of the session for the questions. Thank you again.
Thank you, ma'am. Next, we have Dr. S. Balamurugan from Vellore, who will be speaking on the topic Common Errors in Fever Management in General Medicine. Over to you, sir.
Welcome, Dr. Balamurugan, sir. Sir has completed MD General Medicine in Government Mohan Kumar Mangalam Medical College, Salem, and he's been practicing as a consult physician in Narayani Hospital. Over to you, sir. Interesting topic, Common Errors in Fever Management.
Dr. Bala. Good morning all. On behalf of organizing committee, I welcome you all for the academic feast TAPICON 2025. I'm going to talk about common errors in fever management. Fever is the most commonest symptom for which people will come to hospital. So we should know thorough about fever. It's a sign actually, it's a sign of ongoing inflammation. The inflammation may be acute or chronic or infective or non-infective. Proper management is essential to avoid over-treatment or misdiagnosis. While generally a beneficial process, improper management can lead to complications or prolonged discomfort to the patients. Here I am going to highlight frequent clinical errors and suggest some clinical evidence-based corrections, and also to understand the impact of errors in patient outcome. Let's start with the history taking. Here I want to highlight only the duration of fever and comorbidity symptoms, and overlooking travel or social history as well as medication history to miss out drug fever. During COVID itself, we have seen a lot of patients comes with acute febrile illness, but we have missed comorbidities, because comorbidities play an important role in for the deciding morbidity, mortality in COVID. So we should give more care with the comorbidities. Correction by taking comprehensive history in this area is crucial for accurate diagnosis and effective treatment. The history should start with the onset, location, duration, characteristics, aggravating factors, relieving factors, like what we are taking for other systems. Categories into acute, subacute, chronic fever, then we can evaluate accordingly. We cannot, by categorizing it, we may not overdiagnose or over-investigate in case of acute febrile illness. Severity, when we should give paracetamol or other things. Whenever the patient having distress or causing high-grade fever and temperature cross more than 100.5 degree, we can give paracetamol. But at the same time, we should know about fever mimic symptoms, fever mimic conditions like hyperthyroidism, dehydration, or other inflammatory conditions. Some patients may tell I have a feel of feverishness. In this situation, we can document the temperature. If the patient is having fever, then we can evaluate, because the patient will tell I have feeling of feverishness for 1 month, 2 months, or more than 3 months. In these situations, document the fever. If the patient is having fever, or if there is signs of inflammation or the presence of inflammation markers, we can evaluate further. Physical examinations, it's not very easy to examine a fever case. In a systemic case, we can focus on systems, but here what system involved. So we have to identify the clues as much as possible. Head to foot examination is mandatory, focusing mainly on rashes, lymph nodes, organomegalies, and any eschar in case of any scrub endemic or other focusing infections like abscess or other things. Inaccurate temperature measurement, this will decide whether a patient is having fever or not. This will easy for those who are having feverishness. we can document the fever, and also we can understand the pattern of fever, whether it's a continuous, intermittent, or remittent fever. Then we evaluate accordingly. Use a calibrated thermometer is it's a fine. The important one is ordering investigations. When we should order investigations. In case of acute febrile illness, when fever lasts more than 3 days, you can order simple CBC investigation. Complete bloodgram will say, tell about anemia, or leukocytosis, neutrophilic leukocytosis, or neutropenic leukocytosis, eosinophilia, monocytosis. What about a right to right shift, or immature granulocytes, thrombocytopenia? It will get a lot of clues regarding further evaluation. So simple CBC is enough. When fever crosses more than 5 days, you can order further investigations like cultures. But a lot of errors will happen with the blood culture and the urine culture. Whenever you order urine culture, ask the patient to take midstream urine, not from the beginning. Don't collect urine samples from catheters or urobag. If the patient has already catheterized, take suprapubic aspiration after clamping the catheter. In case of blood culture, you give a pre-requisition form regarding clinical data and what are the antibodies he is getting, how long he is having fever, other radiological investigation reports, then follow aseptic precautions. Try to give minimum 2 sets of culture, then only the yield will be more than 80%. In case of if the patient is getting antibiotics, it's better to withdraw blood before initiating antibiotics. If the patient is already on antibiotics, take sample before the next dose of antibiotic. Serological test interpretation, we should know the common things about the disease, because all the disease follow some clinical course of the disease. So when we should follow, when we should order blood culture, radiological investigations, and the serological investigation. For example, in case of dengue, if you order IgM in the initial first 5 days, it will be negative. But if you do PCR or NS1, it will be positive. But the same thing, if you order PCR after 5 days, it will be negative. So all the disease follow some natural course. We should take test according to that. The timing is crucial. If you plan to order IgM or IgG or any other serological investigations, better to order after 5 days, at least 6 to 7 days. And when contaminated sample, this is regarding wound swabs or drained fluid. This is for surgical things. Focusing solely on fever is not enough. We should check other accompanying symptoms like difficulty in breathing, severe headache or stiffness in neck, rashes, persistent vomiting, diarrhea, lethargy, extreme irritability, seizures. In dengue, if the patient develops breathing difficulty, means either patient would have developed ARDS or volume overload state. So just giving paracetamol and other antibiotic, what we should order, what we should give next dose, that will not be enough. We should check during every visit. We should check accompanying symptoms. Next slide. Combining alternating medications incorrectly. This will happen when soft tissue infections or cellulitis. The patient already on paracetamol, but if the patient tells fever, we will add NSAIDs. That will cause drug toxicity. Already the patient will be on altered liver enzymes or altered renal parameters. If you add a second drug or third drug with the same group, it will worsen the condition. So treat promptly according to the clinical situation. Next slide. Antipyretic therapy. It's not ideal to give paracetamol as a Q6 hourly or TID dosage, because we can identify the fever pattern. If the patient takes whenever he has fever, we can identify the pattern, then we can come to a conclusion. Patient is already originally is suffering from continuous fever or intermittent fever or remittent fever. Next slide. Before previous slide. When to start antibiotics? Theoretically says when the patient is having fever of more than 7 days, we can start antibiotics. But in clinical practice, we start antibiotics when the patient is having fever of more than 5 days. If the fever is more than 5 days means patient is suffering from some bacteriological infections, not you are dealing with viral infections. So it's better to start with the basic antibiotics. Before starting antibiotics, you should know about the endemicity of the infections and location of the infection or focus of the infections. If you plan to start empirical antibiotics, it's better to start with the antibiotic which covers all the three things. If you want to plan to start antibiotic in case of scrub endemicity or enteric fever or leptospirosis, start azithromycin rather than starting doxycycline alone, because doxy will not cover enteric fever. Which is better, oral antibiotics or IV antibiotics? Actually, bacteria are not affected by how the antibiotics reaches them. So when the patient is stable, is able to take food, there is no history of vomiting, it's better to start with oral antibiotic rather than just giving IV antibiotics. It will be easy. Oral is favored, they have good bioavailability and source control also. There is no difference between IV and oral antibiotics if the patient is stable. How long we should give antibiotics? 3 days, 7 days, 14 days. There is no dictum. In case of acute cystitis, antibiotics for 3 days is enough. In case of intra-abdominal sepsis, 4 days antibiotics is enough. In case of acute pneumonia, 5 days antibiotics is enough. The easy rule is still patient recovers. Short is always sweet. As much as possible, reduce the duration of antibiotics to prevent further antibiotic resistance emergence. Antimicrobial stewardship. If you plan to start empirical antibiotics, start with a single antibiotics which have a broad spectrum. It covers the 2 or 3 diseases. And we should start with if you identify the focus of infection, you can start. In case of URI, start with antibiotic which covers gram-positive. In case of you are dealing with lower respiratory tract infections, you start with the same. No need to start anaerobic infections. In case of GA or urinary tract infections, start with antibiotic which is having antibiotic gram-negative coverage. So based on location also you can prefer. If you know the focus or the culture report has come, it shows it is sensitive to basic antibiotics, you can de-escalate the antibiotics. Unnecessary antibiotics. In OPD practice, more than 80% of patients doesn't require antibiotic. This is a common thing. You no need to start antibiotic for upper respiratory tract infections or acute gastroenteritis or small wound or abrasions, presumed UTI, dog bites. Positive lab report, whenever you check blood viral test, it will be positive in low titer, 1:80 or 1:80. In this situation, patient usually ask whether it has to be treated or not. You can counsel them regarding no need for antibiotics if there is a symptom suggestive of enteric fever or there is a increasing titer of viral, you can start any antibiotics. If the patient is stable, no need to start any antibiotic in case of even in the early phase of enteric fever. Whenever you feel that it's not related to infection, stop antibiotics. Dietary recommendations. The common thing is patient think that when the patient is having fever, he has to take a lot of fluids. They have to restrict non-veg or protein diet or lipid. That's not a rule. Actually, they require more calories. So you can advise any home-cooked food is suitable as long as the patient does not experience nausea, vomiting, or discomfort. There are no restriction. Normal diet is encouraged. Hydration in all the conditions, especially in the early phase of any infection, hydration is must. We should not neglect, otherwise dehydration which can worsen the symptoms and lead to complications. Coming to the end of the discussion, misunderstanding the fever purpose. Patients think that fever is a harmful symptom that must be suppressed immediately, but that it's not true. Actually, it's a natural defense mechanism helping the body fight off infections by creating an unfavorable environment for the pathogens. So sometimes over-aggressive treatment, over-aggressive temperature reduction can sometimes hinder the body's natural healing process. This is Hippocrates' statement. Give me the power to produce fever, I will cure all the disease. During this period, fever means viral fever. There were no antibiotics, there were no prevalence of bacterial infections. In viral fever, fever is the first natural defense mechanism. With the fever alone, we will get cured from the viral fever. So fever, whether fever is a blessing or curse, these are the different quotes from different medical scientists in different period. They think that fever is always beneficial. Actually, fever is a blessing. By increasing the temperature, it inhibits growth of microorganisms, it stimulates immune system, and it enhances tissue repair by increasing blood flow and nutrient delivery to the affected tissue. And also, when you give drugs, by increasing blood circulation, it will increase the blood flow and the drug delivery to the infected tissue. So it's a blessing, but in the same time, it has other part of the kind. It will cause dehydration, metabolic abnormalities like acidosis, hypoglycemia, electrolyte imbalances, seizures, especially in children under the 5 years, organ damage such as brain, heart, liver. This can lead to permanent damage if not treated properly, death in rare situation. But these things will be managed by ourselves. So fever is blessing always. Thank you all.
Thank you, Balamanu sir, for the excellent presentation.
Thank you, sir. Our next speaker is Dr. K. Venkatakrishnan from Chennai to talk on the topic Simple Approach to Acute Febrile Illness. We welcome you, sir.
So with the next 12 minutes, good morning to the organizers, Professor Vetrivel sir, for giving me the opportunity. I will not take much time. So I will try to finish on time. This is a different topic. I put my own slides or my scenarios, what we see in practice. No theory aspects here. So all are case scenarios which have dealt in our practice. And I'll touch upon what is the simple approach to any acute fever. Why acute fever management is important for a physician. Can I move the slides from here? Yes. Yes. This is a very important slide. So any physician, I have had around 25 years of experience now, still we have difficulty in managing acute fever. We have to accept that. The changing scenario of all bugs, resistant bugs, because of various reasons, and the most important reason is irrational use of antibiotics. We need to have a early decision, precise treatment along with the precise lab investigations. It should be simple and gives a clue to early onset of sepsis or organ involvement. If you treat a proper acute fever, there will be less complications, morbidity is less. Definitely clinical experience will play a major role in any acute fever. We'll go to the scenario. So before the scenario, it was discussed with the previous speaker, what are the gaps in treating acute fever. You should have a detailed history and examination. That is the most important thing I put. Apart from that, you should select the labs, which is important, and the best empirical antibiotic therapy. That is the need of the hour. The scenario says a 35-year-old female presents with fever high grade for 5 days. Has a dry cough for 3 days. No other systemic complaints. Past history is insignificant. Family physician has advised azithromycin and paracetamol, but fever is still persisting. It's a very simple scenario, what we see in clinical practice. What is the clue for this patient? So on examination is important, history is there, and in this patient you can see a normal heart rate. So pointer is working. Normal heart rate, a temperature of 102 and respiratory mild tachypnea. Apart from that, system examination is normal. So what is the provisional diagnosis? So you may be wondering why I put malaria, enteric fever, dengue fever, pneumonia. It's a straightforward respiratory infection. That's what should be the fever with a cough. So that is the clinch. In this scenario, we will discuss after the labs what will be the clinical clues. Apart from the clinical clues, what the labs will give. So this is a lab where you can see a leukopenia, normal leukocytes, anemia, a mild thrombocytopenia. You can see a significant reduction in eosinophils. Sometimes it can be zero also. You can see some picture it is zero. So eosinopenia with a mild thrombocytopenia and a normal count along with a anemia. That is the picture. Renal is normal, MP is negative. Now, what should be thought of? Next, the next important investigation after CBC is LFT. So why I should do LFT in acute fever is liver involvement, transaminitis, we can see in specific infection. Then the transaminitis will give a clue whether it is PT more than OT. PT means is primary liver injury. OT more than PT could be a systemic involvement, dehydration or other infections which would have caused liver injury. So that is a clue. Apart from that, there is a mild increase in bilirubin, about 2 only, we call it jaundice. You can see 1.8 the bilirubin, 0.8 is the direct. Otherwise, other labs are normal. Mild transaminitis, mild thrombocytopenia, eosinopenia with a mild anemia. So what will be a diagnosis? So ultrasound showed a mild hepatomegaly, cultures awaited. So basic approach to fever, it is not that everybody should need a ultrasound. First 3 days we can always wait. That first 3 days you should have a clue that what you are treating. Whether the patient will go for early sepsis or you should have clues to whether the patient will go for a systemic involvement or sepsis. If you are clear about that, the first 3 days can always be a conservative approach, except in a few patients where it is immunocompromised, uncontrolled diabetes, you can have specific issues like sepsis and other infections. So I will touch upon the clinical pearls in this case before going to what is the diagnosis. You may be wondering why I am saying this. The most important thing is not all cough in any infection is primary respiratory. The first point, any bronchial inflammation due to other reasons can definitely cause a dry cough. If it is a dry cough, always it can be it is not primary respiratory. Sorry, the slide has moved. You should know what is viral, what is bacterial. By clinical science and experience, we can always say warning symptoms. Always look for warning symptoms or signs. As I told you, antibiotic use should be judicious. If you feel that it is primary respiratory, give azithro. If it is not as respiratory, better avoid an antibiotic which may worsen this scenario. So this could be a picture is anemia, mild thrombocytopenia, transaminitis. So first will be malaria because of the hemolysis. There is a mild elevated indirect hyperbilirubinemia. If it is enteric fever, again anemia is not noted. You can have mild degree of thrombocytopenia along with eosinopenia, very important. So if there is a eosinopenia, you should be very clear about you are treating a enteric fever or a fever which has affected the reticuloendothelial system. It could be scrub also. Next, you can see the clinical picture with 1 or 2 fever. The patient had a heart rate of 74. So patient had a bradycardia. That gives a clue that it is relative bradycardia. The most important bacterial infection is enteric. Apart from that, it could be some other viral illness where there is bradycardia. If it is bacterial sepsis, there will be definite tachycardia. SARS is pronounced. That's what we learned from this topic. I'm not going to what antibiotic, what all we know, what is to be done. The next slide says never use quinolones for enteric fever. Quinolones have become almost resistant to enteric fever. If you feel it is enteric fever, don't give quinolones. The drug of choice is ceftriaxone followed by macrolide, azithromycin. I think we have discussed in this scenario a simple fever with a respiratory symptom. So it is not primary respiratory, it can be other infection also. The next slide, next scenario is again a straightforward scenario. We see in practice a patient presented with a GI symptom. Right hypochondrial pain, vomiting, fever for 4 days. High grade fever, headache, body pain, all myalgia, usually seen in any clinical practice. No dysuria, cough or rigors, significance of history to find out any other system involvement and no significant past illness. So again the clinical, you can see eyes are congested, conjunctival congestion. Congenital congestion, I see if it is hemorrhage, it is different. Any congestion is not leptospirosis. So it should be specific hemorrhage. Any congenital congestion can be seen in most fevers. No neck stiffness, but what is important is dehydration, tachycardia, and a mild tachypnea. All other system examination is normal. Non-specific epigastric tenderness is reported. As per examination, we have mild epigastric tenderness. So what is the provisional diagnosis? So eye is congested with a high-grade fever, then no jaundice, tachycardia, mild tachypnea, and a dehydration. The patient definitely has a sepsis, some infection, which is going for a sepsis with a dehydration. So out of this, what fits? Definitely from the clues given history, we don't have a clear picture. So with the labs for this patient, labs are given a clue that is there is a leukocytosis, significant thrombocytopenia, and elevated RFT. Abundant creatinine is elevated. OT, PT, again you can see PT more than OT, primary liver injury. Alkaline phosphatase is specifically elevated. So I will come to that point with a direct bilirubin, which is elevated, and a coagulopathy. Liver is significantly involved. So this patient needs an aggressive early antibiotic treatment. Now the picture is clear. Leukocytosis, severe thrombocytopenia, renal involvement, along with a significant SAP elevation and transaminitis. It is lepto. So why it is lepto, and what is the other possible diagnosis? Whether it is viral hepatitis? No. SGOT, SGVT will be very, very high. So any other diagnosis possible? Definitely. If it is not leukocytosis, it could be scrub typhus. This SAP elevation, as I told you, in leptospirosis, because of periportal inflammation, alkaline phosphatase is specifically elevated. So that's what is the clue from the labs. So I'm not going to discuss what is antibiotic. We all know CP, doxy, and cept. If it is not available, ceftriaxone can be used. CP is not freely available sometimes. So what is the learning point from this? We see patients fever with GI symptoms. We should know what is the localization. If it is straightforward, it is always easy. But early warning signs, this patient had tachycardia. Tachycardia is always there, a significant dehydration. So you should aggressively give empirical antibiotic therapy. That is the learning point from this scenario. The last scenario is, anyway, the previous speaker is, what is the gap in any acute fever management? I just wanted to touch upon. It is also a short duration fever. This is a different scenario where a patient is a diabetic. So you should be very careful. If it is a diabetic patient, multi-system involvement, patients on steroids, immunosuppressed, any other patient, you should have a wider vision or treat aggressively these patients. Otherwise, the patient will go for sepsis and MOTS. So very difficult. Sometimes mortality is also seen. So this patient, as I told you, the picture is very clear. We have only 3 minutes. I will finish, don't worry. Dysuria and increased frequency, there's a specific definite UTI, a complicated UTI as per the history, uncontrolled diabetes. This patient has developed a respiratory symptom. So very classical. You should be doubly careful. The patient is going for a MOTS. So the clue is any pyelonephritis, upper UTI, definitely will have respiratory symptoms. The next common involvement is a respiratory. So you should have in mind, these patients need aggressive early antibiotic therapy. What is important? I should not start aggressive therapy first, then de-escalate. No. If it is required, you aggressively treat. It is not required, don't aggressively treat. That is what is important. Otherwise, we don't have antibiotic for the next generation. After all the colistin, polymyxin, we don't have any antibiotic. When we have sepsis after 10 years, no antibiotic will be available. So
3 more minutes left.
Yes. I'll come to, don't worry. I have very specific slides, don't worry. I will stick to time. So this patient was given levofloxacin. No improvement. The patient now has lung signs. You can see significant tachypnea and pulse rate of 110. Now, Is it UTI? Definitely pyelonephritis has gone for a respiratory sepsis. It is not primary pneumonia. The patient started as a primary UTI. So this patient was started with, so the labs are clear, leukocytosis, plenty of pus cells with a, you can see now, this is what, OT is more than PT. So definitely it is not a primary liver. There is a sepsis which is affecting the liver. Yes, which antibiotic, this what? What was given for this patient is, initially it was levofloxacin, then they tried ceftriaxone. Patient went into sepsis, ARDS. So this is the patient you should start with either BLI, initially itself, piptazo, or you start with a carbapenem. You can always de-escalate all this diabetic, uncontrolled, going for sepsis, if the patient has developed ARDS, he was put on ventilator support, 3 days of ventilator support, fourth day we weaned and the patient. So there was 12 days of hospitalization for this patient. So this is the learning point in this scenario is clinical presentation of UTI with a lung sign. Always sepsis, none, labs are clear. Choice of antibiotics should be very clear. Even if you start meropenem for this patient, I'm happy because you are saving the patient. Second day, third day, you can always de-escalate. That is very important. The last slide, revision of treatment plan is mandatory. Either escalate or de-escalate. Always think of false negative reports. Proper history and clinical science is important. Do not treat by the labs. There can be false positive. Thank you for the opportunity. We can have the questions.
Thank you, sir. Thank you for the masterclass on fever. I request all the other speakers to take the stage, please. Dr. G. Ilangovan, Dr. Virgin Jonah, and Dr. S. Balamurugan, sir. So after COVID, there's been abuse of azithromycin, I would say. There's been lots of azithromycin that we've been using nowadays. So that is one thing we need to avoid. Let me kickstart the question session to Dr. Virgin Jonah. So how about dengue card test? How far it is useful? Should we go for serology directly, IgM, IgG, and ELISA, or dengue card test?
We have seen more of false positives, and we generally go by serology, sir. My clinical experience only says that I don't believe more of card tests and I go by.
Should we use it or should we not use it?
Maybe not, sir.
This is a question to Dr. Jonia.
Yes.
What is your opinion about usage of vitamin D and pro and prebiotic in dengue in recovery of platelets?
Pro and prebiotics, maybe yes, sir. But vitamin D, I don't have any clinical experience, sir.
In our series, I think we could see more than 300 patients in 1 year. There is a drastic improvement in thrombocytopenia when you use periodically conventional pre and probiotic plus vitamin C and D. We have not used any other drugs like doxycycline or anything. See, nutraceuticals is helpful in checking the megakaryocyte depletion. So that is the basis. This has been followed in Chinese medicine. So definitely there is an important improvement by using conservative methods like using nutraceutical and fruit flavonoids, phytochemicals, etc.
So those, there is no scientific evidence, sir. So what could be the reasonable expansion is you should use a single strain of lactobacillus. So multi-strains may, the only thing they may benefit, doubtful benefit is to alter the immune system to has a immune pathogenesis which is there, which will be shunned by the probiotics, sir. But scientifically we don't have any papers on that. So clinically,
what you are telling,
yes,
this pro and prebiotic
yes,
has a very good impact on immunomodulation.
Yes, it is immunomodulation only, sir. Correct, sir.
Immunomodulation. They give a protection for the intestinal barrier,
Yes.
not to promote leaky gut syndrome. So that is definitely even though we are waiting for the scientific evidence, but experience-based medicine speaks volumes.
Yes, sir. As we used ivermectin in initial phase of COVID, it was an immunomodulator, not for COVID. Yes, next.
Thank you so much. I think the chairperson's work is reduced. I think there's conversation happening, and thank you for that. There's one, sir, please go ahead. Please introduce yourself. And
Madam, I'm Dr. Aditya. I'm a consultant physician in Chennai. So my question to you, madam, that recently, my question is just forward of the sir question. Recently, there is a Lancet article where they have told that early initiation of Montelukast in the case of the dengue, it can be effective. Is there in your practice? Have you seen any beneficial effect, madam? And second question is, when we were in GH, we used to give steroids when the patient had dengue with polycirrhosis with very low platelet count, which was less than 10,000. These two, in your experience?
Steroids definitely no, sir. But with judicious IV monitoring and the other systems, we are able to manage all the serositis and leakage symptoms effectively with the revised protocols, whatever guidelines they have set. Steroids we are not actually practicing now. Montelukast, really I don't have any clinical experience on it.
To answer Aditya's question, so dengue, 99% nothing will happen. 1%, maximum 0.1 to 1%, you can call it, they can go for a cytokine storm. Cytokine storm, only two options are there. You have a plasma exchange, cytoadhesion you do, or you try immunotherapies. So mast cell stabilization has been reported in Lancet, it's a publication, where it reduces inflammation. So if you feel the patient has significant inflammation, this is what you should have a clinical mind. The ferritin will give a clear clue. So early ferritin rise, it could be a secondary dengue. Those patients you should definitely target immunomodulator therapies.
thank you so much. I think we'll, thank you, Dr. Joanna. I think you got the hot seat right now, and your colleagues are also helping. And as I agree, dengue is always going to be a mixed bag of approaches, but personally, I do a more conservative approach. I'll just ask for any questions to the other speakers first before we can come back to one question. Ma'am, please go ahead.
Good morning. I'm Dr. Anusha from Meenakshi Mission, Madurai. Sir, Dr. Vankara Krishna, I have a question for you.
Yes.
So when there is a confirmed bacteremia, supposing the blood culture grew E. coli in this case, how many days of parenteral antibiotics should we give before we de-escalate?
That's a very important questions we have to discuss in this forum. Now, short duration therapy. Previously it was, even it is pyelo, you have to give 2 weeks of antibiotic, any parenteral antibiotic. If you have started, the patient is, you have started the antibiotic in early sepsis. So guidelines also, IDSA guidelines also say short duration specific directed antibiotic therapy. 1 week of ideal antibiotic therapy is ideal, followed by 2 weeks of oral if at all it is a recurrent sepsis, urosepsis or pyelo. That's what is the guideline, IDSA guideline.
Fever Foundation of India, Bangalore, they have presented the short dose chemotherapy is more ideal than not.
Thank you so much. We are running short of time, and
Yes.
since we are the first session,
I think first session.
I'd also like to thank all the speakers again for all their extra contributions, and obviously they're very good presentations, very informative. And I'll just say thank you again for all of you all.
You made it
Can you all please stay on a momento and okay, sure. Thank you so much. You all can please please proceed to your seats. And we'll be, thank you for this opportunity as chairpersons also.
Thank you very much for the excellent narration on fever symposium. I congratulate Dr. G. Ilangoban, Dr. Balamurugan, Dr. Jonia Madam, and Dr. Venkatesan. A wonderful speech on fever. And I profoundly thank Dr. G. Manigandan, Dr. V.G. Arun, Dr. Professor Samya Madam for chairing the session. We'll have our formalities along with the next session. Thank you very much. Now it's a time to call upon the super specialty, the TAPICON 2025 feels proud to introduce the gastroenterology super specialist speaker. In that, the first speaker will be Dr. N. Arun, a young budding gastroenterologist eminent gastroenterologist from main Apollo Hospital, Chennai, and followed by Dr. Vadivel Kumaran, another budding gastroenterologist, eminent intervention gastroenterologist from the famous Kaveri Hospital, Chennai. And another one is Dr. Ravindranath from the famous Narivi Hospital, is another gastroenterologist to be with the speaker list. And now I call upon Dr. Pawan Kumar Ervi from the leading gastroenterologist in Narayani Hospital, and Dr. S. Appanraj, our Joint Secretary of Tamil Nadu State Association of API from Melmarathur, is Professor and HOD of Medicine in Melmarathur Adipura Sakti College. And I will call upon my dearest friend, a senior physician from Krishnagiri, Dr. L. Raghupati, presenting you on gastroenterology.
We now welcome Dr. N. Arun from Chennai, who will be speaking on the topic Reflections on Reflux. We welcome you, sir.
Slide, please. What's the slides?
So good morning everyone. Dr. N. Arun, who is a pediatric gastroenterologist. He is a consultant gastroenterologist and hepatologist and interventional endoscopist from Apollo Main Hospital's Grims Road. So his field of interest is interventional endoscopy and liver transplantation. He has a lot of achievements to his page, and he has a lot of publications. Over to you, sir.
Thank you, sir. So just a minute, please, for the slide change. speaker this from Sorry for the bit time delay, and respected professors, senior consultants, and dear friends. It's really a great pleasure for me to be in this wonderful TAPICON event. And I would like to extend my warm gratitude to the team organizers for being here. And today we are here after the initial interesting discussion on fever. Now we are going to take into the mainstream of gastroenterology. And our routine daily practice will not get complete without seeing these routine common clinical manifestations of what's called as gastroesophageal reflux disease. And to talk about this gastroesophageal reflux, as we all know, any contents, if it is going to refluxate from your stomach into your esophagus, nothing but your gastroesophageal symptoms. And once the patient is going to take on called as gastroesophageal reflux disease. As we all know, there are various definitions for that. This is mainly being categorized by your Montreal's classification, and Montreal's definition being included in your GERD. Apart from that, as you all know, once the patient is going to land up with this kind of presentation, the commonest manifestations will be your heartburn as well as your chest pain. And there are various extraesophageal manifestations starting from your oral cavity to your complete GI tract. You'll be ending up your respiratory problems, your other coexisting complications may be recorded. And in gastroesophageal reflux, it might be a pathologic or non-organic. Apart from that, it might be a erosive or non-erosive reflux conditions. Among Indian scenario, most of the time we'll be coming across only with non-erosive reflux phenomena rather than erosive. Non-erosive, almost around 60 to 80% of the population will be lining up with evidence of non-erosive. What do you mean by non-erosive? Once you're going to look into your endoscopic picture, and if you're not going to diagnose, doesn't mean the patient is not going to have findings of reflux esophagitis. So you need to see through that whether the patient is having any other coexisting presentation. So that's what's very important. And apart from that, see, why still very few patients will seek the opinion of gastroenterologist, but still it's remaining the chip of iceberg, and most of the time, once the patient is having recurrent symptoms, worsening of symptoms, nocturnal symptoms, the patient not going present, not going to, see, always GERD is one difficult entity because this condition will be coexisting with most of the functional bowel disorders. Your functional dyspepsia, your irritable bowel syndrome, your peptic ulcer, your GERD, all the same conditions will be mimicking similar pathology. So how do you going to differentiate that? How are you going to assess that the patient is going to land up with evidence of there's a GERD or peptic ulcer or functional dyspepsia or other functional bowel disorders or any functional hypersensitivity conditions like reflux, heartburn, and other things. All these things is simple clinical entity. And clinical picture, clinical assessment is very important to take on the main role to diagnose a patient with GERD. And still it remains the tip of iceberg. And as we already discussed, the prevalence is almost around 10 to 20% in Europe. In India, also around 7.6% in urban area. It will be going around 16.2% of the population. And as I discussed, there are troublesome complications the patient will be having. Almost 40% of the population monthly and 20% of the population weekly basis, and more than 4 to 7% of the population daily basis in routine will be coming across with this kind of GERD-like problems. To talk on GERD, you should remember about what is the basic pathophysiological concept, and apart from how are you going to work up, is workup necessary for all the patients? Apart from once you're going to diagnose a patient GERD, how are you going to manage? Management is still a challenging issue, even for the best gastroenterologist. When you're going to tackle a patient, how are you going to address? How many days you are going to treat the patient? How are you going to assess the response, whether the patient clinical scenario is responding to the treatment or not? These are all the areas still very difficult to address, and so many innovations still happening in the field of gastroenterology to tackle a patient with gastroesophageal reflux. The major pathophysiological component, briefly I would like to show you, is your lower esophageal sphincter competence. If your TLACR is going to persist for more than 10 seconds, that means the patient is having worsening of your reflux. Apart from that, any esophageal mucus difference is going to impact your improper relaxation of your lower esophageal sphincter and your reduced restriction of your lower esophageal sphincter and your pyloric incompetence as well as your delayed gastric emptying. Starting from your proximal distal, if you have any pathophysiological concept, that will predispose the patient to land up with evidence of GERD. As you all know, the four major entities will be your LES competence. We'll be mentioning the 4 areas by your diaphragm, your intraabdominal portion, your angular flexus, your phrenoesophageal ligaments. Apart from that, if as I discussed, if the TLACR is going to get, that's why you are going to initiate the patient prokinetic support to manage the patient with this kind of GERD. And your swallow-induced relaxation, your hypotensive low esophageal sphincter, hypertension, as well, is grading of hiatus is there. So once the patient is going to land with this kind of presentation, the patient will be having evidence of GERD. And symptoms very characteristic: nocturnal disturbances, heartburn, chest pain, irritation, not going to respond to the medication's initial phase, and temporary response. Again, patient may have coexisting presentation, and sort of bitterness in the mouth. All those things will be there. And always this model classification for your esophageal as well as extraesophageal differentiation is very important, and see through that whether the patient is landing with organic problems or non-organic, and apart from that symptomatic, rule out the basic, to whom you are going to subject, how far this investigation is going to head, and whether the patient is going to subject. We are not going to subject the patient for investigations. Whoever is going to present the GERD, to whom you are going to refer from a plan for further management, aggressive line of treatment, then only you are going to subject for further investigation. So this kind of, to categorize that, we need to subdivide this patient with esophageal as well as extraesophageal syndromes. In extraesophageal, cough, laryngitis, your asthma, your dental complications, your pharyngitis and sinusitis, these are all the things on otitis media. And coexisting presentation we need to represent before we are going to tackle a patient with GERD. Basic investigations, very important. Barium swallow, very limited role. Once if you're going to suspect a patient with any dysmotility disorders, then we can go in for barium swallow. Apart from the no major contribution role in assessing a patient with GERD. Endoscopy definitely seems to be, once a patient is not going to respond with the initial phase of treatment, and if the patient land up with the evidence of alarming problems, and your pH metry, apart from your esophageal manometry to certain indications. Alarming problems in gastroenterology, always very simple. Whatever the complication, whatever the presentation, starting from head to foot, alarming problems will be always restricted. Significant weight loss, more than 10%, always be careful. Apart from dysphagia, any dysphagia to intervene at any point of time. In case of a GI bleed, even if it is mild, moderate, or severe, we need to categorize with the patient. If you suspect a mass, apart from if there is any evidence of stricturous presentation, and if the patient is having recurrent persistent vomiting, it might be because of anything else. It might be because of cyclical vomiting or any other complication. Once a patient presented to us in the background of recurrent vomit, always you need to analyze whether the patient is landing up with any alarming clues. So these are all the basic things we should not forget, because before category in the background of anemia and other complications. So alarming pointers in gastroenterology looks to be very simple, but to identify the patients is very, very important. That's to recognize the complications. And very characteristic, this simple definition, there are so many classifications are there to categorize a patient with erosive esophagitis, but very important classification, your Los Angeles, simply you can remember 4 stages, A, B, C, D, and D means the complete mucosa, more than 70%, 75% of the mucosa if it is going to get involved, which means the patient is going to line up with the evidence of severe esophagitis. Few days before, I came across a patient who had naproxen, and followed by he had naproxen for some other evidence of prolonged fever, and within a period of 1 month of time, the patient presented to us in the background of severe esophagitis, and I have initiated the patient on potassium competitive acid blockers like vonoprazole, recently we have been using, and that patient showed sustained response. So why we need to say, always we need to assess the differential diagnosis, very, very important. And it could be NSAID abuse, it could be erosive, so many other things you need to categorize whether the patient, what's the history taking is more important to land up to diagnose this kind of problem. And various youth investigations are there to identify. One is your pH metry, 24-hour impedance pH monitoring is one of the gold standard. And 2 major things you need to look into. One is your DMIS scoring, which means if your reflex criteria, once you're going to place a probe, if you're going to identify that, if your reflex index, if it is going to be more than 14, at that point, the patient. And apart from that, you need to look for your acid exposure time. If the acid exposure time, if it is going to be more than 6, that shows the evidence the patient is going to land up with the evidence of your gastroesophageal reflux. So your impedance pH metry you can use to identify whether the patient is having evidence of coexisting acidic or non-acidic, your diurnal other complications or reflux. Apart from that, this is the basic outline of your DMIS scoring system. That's what we are using, and various postural corrections along with your number of reflex episodes which is happening in a day, and categorizing that over a period of more than 14, that categorizes the patient is having evidence of reflex pathology. And also, as I already discussed, once a patient is going to land up with evidence of total acid exposure based upon your impedance metry, if it is going to be more than 6, that shows the patient is having significant reflux, and the reflux episodes, if it is going to be more than 80, that shows the evidence the patient is having significant reflux. And
Sir, 5 more minutes left.
multi-channel impedance, your Bravo capsule in which you are going to attach the capsule transnasally, and if it's going just to position above the scomacolumnar junction, you can use it out. And very important thing I would like to categorize for the last 5 minutes over here, the management guidelines. So ACG, your various guidelines, position statement, your Indian Society of Gastro, all these things we came across multiple. First, we have diet and lifestyle. Address the diet and lifestyle, starting from your antacids, your PPI, your prokinetics, along with various line of molecules, your sucralfate and other things, apart from the newer molecules like your potassium competitive acid blockers and your prokinetics. All those things you can consider in the management armamentarium to diagnose, to tackle a patient with GERD. But where do you going to place is still a questionable issue. So just like that, simply you should remember the brief outline about your GERD. Once a patient is having evidence of grade C and D severe esophagitis, ideally you need to start the patient on proton pump inhibitor for a duration of 8 weeks. And then because proton pump inhibitors will be having a significant potential role to improve the clinical scenario rather than H2 blockers. In H2 blockers, grade A and B esophagitis will be having more predominant role of response. But the role of alginates, your alginate preparation will not going to have a significant mucosal healing, but it will be having a rapid sustained response at a rate of around once if you're going to give your sodium alginate preparation. The other complications like alkali syndrome, other things, even though rarely been reported, but the mucosal healing will not be much categorized when you're going to use your alginates. So your diet, lifestyle, all those things when you're going to address, starting from your PPI, double dose of PPI, dual release PPI, now potassium competitive acid blockers like your vonoprazone, and still higher molecule like your fexaprozone. All these things are there to take on the management hormone guidelines to look for a patient with GERD, but still you need to address to whom you are going to use, how do you going to assess the response, that's very, very important. And see through the complication. The patient may have evidence of refractory GERD, the patient may have evidence of worsening of complications like your malignant changeover, your Barrett's, your Zollinger-Ellison, all those things you need to address if you are going to look into the problems of your tackling a presentation with GERD. So diet, lifestyle, basic medications, and see through the response. No response, categorize the patient as refractory. And once the patient is refractory, see through that whether the patient is having multiple other complications. What is the differential diagnosis? Whether the patient is adhering to that molecule, or whether the patient is landing up with any eosinophilic disorders, or whether the patient is having any radiation abuse or NSAID abuse. Differential diagnosis you need to consider. And basic things is, if your PPI, if it is going to increase at a day dose of almost around increased dose of PPI, the response to your GERD will be almost around 90 to 100%. That's significantly proven. And these are all the ULAs basically. So antacids, H2 receptors, and potassium competitive PPIs and prokinetics. Very importantly, as a physician, we should remember that PPI and potassium competitive acid blockers, still potassium competitive acid blocker will be having significant potential role when compared to your PPI in improving erosive esophagitis. But in compared to the adverse events as of now, the data what has been given, it's been significantly good with your vonoprazone rather than your PPI. But even then, we need more and more data. Recently in APA guidelines also, we have been addressed with that. So we need more and more data to prove that the adverse events like your fundic hyperplasia, your electrolyte disturbances, and other complications, bony changes, vitamin D changes, all these common adverse events, your renal injury, your hepatic injury, all those things, the common adverse, rarest of adverse events being reported with your PPI, you need to address with your vonoprazone too. So most of the adverse events, still there are papers to document to look for the adverse events with your vonoprazone along with your PPI. So we cannot label vonoprazone as more superior to your PPI. So addressing the patient as a whole and which patient we are going to use this molecule is very important to tackle this kind of presentation. Apart from that, there are newer innovations. Your prokinetics depends upon if the patient is having coexisting gastroparesis, you can use your prokinetic, various prokinetic. Among them, the best prokinetic as per my choice will be your ichopride. If you're going to use your 50 milligrams apart from that, and your domperidone and levosulfide, better most not to use in much of the scenarios because more of CNS events, sinitriptyline to some extent to be considered. And in case if the patient is having nocturnal acid breakthrough, it's more important to start the patient on vonoprazone. And the initial phase, they've been considering as high dose of H2 blockers, like your 300 milligrams of ranitidine, a high dose of H2 blockers will be having a significant potential role because your acid pockets will not be significantly inhibited with your PPI alone. So PPI, the nocturnal acid response, breakthrough response will be very, very low. That one strong pointer to go PPI alone will not be a good molecule to tackle a patient with your gastroesophageal reflux. And antidepressant, most of the patient will be having functional dyspepsia and other complications. So antidepressant is very
Sir,
important.
1 more minute
And
left.
apart from that, non-response beyond medical management. It's very important. Nowadays, endoscopy has gone so high. And apart from your laparoscopic interventions like your fundoplication, your nascent stupae and DOS, and your 360 degrees wrap and all those things, now your endoscopic intervention, briefly you should remember that there are so many endoscopic innovation being happening if the patient is non-responding, but is it necessary? How far the India has been developed in this area is still a questionable issue to get addressed. Apart from that, RFA, your transoral incision, fundoplication, your mucosal resection, that's nothing but your Harm's procedure. Muse means your Medigus chaplet device, apart from your Gerdex instrument device, in which you're going to sphincter it out, and strata, you're going to pass a radio frequency current to ablate the inflamed mucosa. All those things you can try for the endoscopic intervention, but post-endoscopy, we need to look for the complications and all those things. So gastroesophageal reflux disease starts with a simple thing, and the patient may go with a progressive major complication like stricture and other things. Always recognize the patient early, look for the complications, tackle the patient in an effective way, and then what is the best rate of medication we need to choose, and see through the patient whether it is responding to the treatment or not, and then only we can able to tackle this kind of clinical scenario reasonably well. Thank you very much. With this, I am resting presentation.
Very good presentation, sir.
Thank you, sir.
Two questions, sir. How do you approach to PPI non-respondent GRD patients, and when do you refer GRD patient for surgery?
So PPI non-responsive GERD. See, always the PPI non-responsive GERD, ideally if the patient is non-responding to 8 weeks of therapy to GERD, that's called PPI non-responsive. But this is what were the guidelines. But how frequently we are using? We are seeing in our routine practice, we are using PPI for years. And there are many, we have been using PPI for years, we have been used to that. But whether you're going to subject the patient as PPI non-responsive, once you're going to document the patient as PPI non-responsive, are we investigating the patient properly? Are we doing the routine subjecting the patient to your esophageal metry and other devices? And then only we need to inform that the patient is having PPI non-responsive. In Indian scenario, this itself remains very difficult. So to tackle PPI non-responsive only based upon the clinical assessment and response is still a questionable issue to address. But as per the statement, 8 weeks non-responsive, we can add on to other molecules. But surgical consideration, I'll be challenging. One important thing is, once the patient has severe symptoms, nocturnal worsening of symptoms, and the patient is landing up with the evidence of psychological traumas and other complications, at that point of time, the patient may have reference to surgical intervention. If the patient has grade 4 hiatus, that's the ideal indicator the patient is going for surgical intervention. But even post-surgery, we should be very cautious because we are seeing more patients, even post-surgical intervention, the patient is landing up with the evidence of worsening of presentation. So addressing as a whole is very important. Counseling the patient is very important. Diet, lifestyle, and all those things is very important before we are going to challenge on these areas. Sir.
Thank you.
Sir, role of time-restricted eating in GERD, sir?
Sir?
Time-restricted eating. Intermittent fasting.
So intermittent fasting, there are some papers to show the beneficial role, but personally, not much of benefit. Intermittent fasting over a period of almost 12 to 18 hours, if they're doing prolonged fasting, means it's having multiple other coexisting problems will be reported, sir. So ideally, to talk on intermittent fasting, there are some potential beneficial role being proven in GERD, but along only with intermittent fasting, no major guidelines to be documented.
Sir, in more nocturnal symptoms, what is your clinical experience on giving PPI in the daytime, H2 blocker in the night, high doses?
Clinical experience on giving PPI in the daytime, H2 blockers in the nighttime is very good, sir. Most of the patient will be having significant potential response rather than starting the patient on vonoprazole. But H2 blockers always is one of the best of molecules to consider because when you are using H2 blocker, most of the patient will now have worsening of irritable bowel. And we are coming across most of the patients with functional dyspepsia and irritable bowel will coexist together. And if the patient has irritable bowel, if you are going to use PPI, that will be having more of catastrophic event. The patient will have more worsening of symptoms. The patient will be spending most of the time in the toilet. And all these things will happen with your PPI along with in the background of IBS. So just like the labeling, if the patient in the background of obesity, diabetic, hypothyroid, other complications, the patient will be having multiple presentations. So you need to look into that. Not giving H2 blockers is always very superior, but only thing is if the patients have evidence of grade C and D esophagitis not to give H2 blockers. Nocturnal acid breakthrough, H2 blockers, significant potential response will be there.
So thank you, sir. The next speaker will be Dr. Vadivel Kumaran.
Thank you very much.
Thank you, sir. Please join me in welcoming Dr. Vadivel Kumaran from Chennai, who will present on Get Unstuck, an approach to constipation. We welcome you, sir.
Dr. Vadivel Kumaran, sir, he has completed MDDM, consultant gastroenterologist and interventional endoscopist from Kaveri Hospital, Chennai. And he has many national and international publications. Over to you, sir.
USB port.
Pointer. Pointer. Pointer.
Oh.
Pointer. Okay, it's working. Okay. So good morning, everybody. So at the outset, I would like to thank the organizers for this opportunity. So I'll be talking on common day-to-day scenario problem, what we are going to face as a practicing physician. Yeah. So there's one such common scenario what we encounter on your day-to-day practice, and so it's basically an approach to constipation. So what does this term constipation mean? It's basically, it's nothing but crowding together. So you can see that the stools crowd together at the outlet. And this can mean different things to different people. So that is why it's very difficult to diagnose this terminology constipation in each and every individual. And we need to clarify more in detail based on the history and clinical examination. So it can mean an infrequent stool, a hard stool, a difficult to pass stools, or at times even straining at stools, or an incomplete evacuation, or an abdominal discomfort. So what is the actual definition? So even though the patient can tell you a lot of things, this is what I'm perceiving as constipation. What does the term exactly mean? It means less than 3 bowel movements per week. Or it can be a painful defecation, or an incomplete defecation, or an excessive straining. So we can determine this particular scenario. So this is one of the common things what we need to have the Bristol stool chart, which can be easily interpreted by the patient as such. We can ask them to identify the form of stool. Not the color, it's a form. How does it look like? Is it like a pellet or a lumpy or sausage shape, or with cracks, or sausage shape with smooth contour, all these things. So 1 and 2 means constipation. 3 and 4, a common thing is going to be the normal one, and 5 is going to be the polyform stool, and 6 and 7 called it as diarrhea. So this is one such tool which can be had in our day-to-day practice on our table, and we can ask them to identify what is the form of stool what they pass, and based on this, we can get a clinical clue that, okay, this patient is definitely having a constipation, or the patient has got a misinterpretation of what they pass as a constipation. Or at times even a diarrhea can be misinterpreted by the patient as a constipation. Says that she is straining a lot to pass stools, but the form of stool is going to be type 6 and 7, which means it is a diarrhea, but we need to still rule out a pseudo-diarrhea in these cases. So what is the Rome 4 criteria? This is one criteria which we follow universally. So that should be at least two or more of these scenarios in a patient to be termed as constipation. There more than 25% of defecation they should strain, or pass hard stools more than 25%, or an incomplete evacuation of more than 25%, or anorectal obstruction or blockade for more than 25%, or using maneuvers like finger insertion to evacuate the stool from the rectum as such, and fewer than 3 spontaneous bowel movements per week. So as I said, the loose stools are rarely present without the use of laxatives, and they should have this symptom for at least 3 months in the past 6 months. So this is the basic worldwide accepted criteria for constipation. So how do you go about? A proper detailed history is very important to determine whether it's going to be a recent one or a chronic one. And what is their main complaint, whether it's going to be as reduced stool frequency, hard stools, or excessive straining. So we need to inquire about the bowel movements per week, or once in how many days does the patient pass stools. We can have a very well Bristol chart and then identify what kind of stool they pass. We need to inquire more about the water intake, whether it's going to be adequate for an individual or not, at least 2 to 3 liters of water per day, and about the fiber intake, and physical activity, or hoarseness of voice or cold intolerance in the form of systemic diseases like hypothyroidism, and other comorbidities and drugs. So these are common things what we need to extract from the history as such from a patient to decide upon what kind of constipation, what is causing this constipation in this individual. And after the history, as in any other case, we need to go for a general examination and a system examination of the abdomen basically. And apart from this routine system examination, we need to have a proper examination of the outlet part, that is the anal canal region. So we need to put them on the left lateral posture and ask them to go for an attempted defecation, look for any rectal prolapse or a perineal descent of more than meters, and look for any presence of fissures, fistulous openings, or a hemorrhoid in the anal region. Next comes the palpation of the anal region for presence of any pain that indicates the patient has got some kind of abscess or a fissure in that region. And then we put in a finger examination and then look for the anal sphincter tone. We need to look out for the external sphincter tone and the internal sphincter tone, and also the presence of a hardened feces or a fecal impaction, which can present paradoxically as fecal incontinence. So what are the alarm symptoms we need to be more concerned about is going to be the nuance of constipation, anemia, weight loss, rectal bleeding, positive stool occult blood test, abdominal masses, and rectal masses. So these patients should be directly sent for colonoscopy. You need not be managing these individuals with a conservative management or putting them on laxatives to relieve their symptom as such. So these are individuals who definitely require a immediate colonoscopy. No more waiting here. And how do, as a gastroenterologist, we analyze this? We analyze the type of transit, that is whether it's going to be normal transit constipation or a slow transit constipation. So the normal transit is going to be, for an average Indian, is going to be 36 to 60 hours. That means you can wait for at least 2 to 2.5 days at least. And based on that, we need to decide whether it's going to be a slow transit constipation or a normal transit constipation. Then we decide upon possibility of pelvic floor dysfunction in the form of a puberectal dyssynergia or an obstructed defecation, or normally when you start to strain, there should be an increase in your intra-abdominal pressure, thereby indirectly increasing your intrarectal pressure that forces the stool out of the rectum. And in turn, there should be a relaxation of the internal sphincter and the external anal sphincter. So this is a normal mechanism through which we have a normal physiology to pass stools. Whereas in these of examination. So how to open the pelvic floor? These are common exercises which we can tell our patients, ask them to blow the air. So thereby it partly increases the intra-abdominal pressure, thereby relaxation of the sphincter muscles also. So what are the effects of constipation? So these patients can have an associated loss of appetite because of this constipation, flatulence, abdominal, rectal pain, lethargy, depression. So as I said in the previous proper history taking, decrease in water and fiber in content can be one of the causes for constipation. So we need to address that part so that they can be relieved of the constipation. And difficulty in evacuation, like painful conditions like anal fissures and hemorrhoids and lack of muscular activity. So the most important thing next comes is going to be the drugs. So as you all know, calcium channel blockers, opiates, ganglion blockers, sulfate, barium, tricyclic antidepressants, ion exchange resins, and the common iron tablets also can cause constipation, apart from phenothiazines and aluminum hydroxide. One important test is going to be the fecal immunotest, which is specifically for a colonic pathology. So because it determines the human hemoglobin as such, it is unaffected by oxidizing agents found in some foods. So which can be a drawback in a routine stool occult blood test, okay, which is going to test the myeloperoxidase activity as such. So the hemoglobin that has not been broken down will be identified. This indicates there is going to be a colonic pathology. So these individuals should be subjected immediately for a colonoscopy. No more waiting. Even a small sample of stool can be tested for this FIT. There is another test which determines the whole entire amount of bowel content, which can detect the DNA itself, which has more specificity is more, but still that is very cumbersome to identify. Next comes the colon transit time. So this tells us about what is the type of colonic transit of this individual. So this is the basic and primary tool in the pathologic diagnosis. So it's generally shorter in Asian individuals because of the high fiber and water intake. So average Indian colon transit time is going to be 36 to 60 hours. The dietary difference make a big difference in the colon transit time. So this can be measured by movement of the radiopaque markers through the gut over a 3-day period. It is reliable and reproducible. That's the most important thing in this. So how do I do it is, so we ask them to swallow some 20 radioinec marker filled capsules on first day in the morning, the next capsule to be taken at the night, and the third capsule to be taken in the next morning. Then we get an X-ray on day 2 and day 3 by one specific time. So any delayed transit means more than 20% of retained markers, that is more than 12 markers. So this has been defined by one of the study from SGPGI by Uday Ghoshal. So this is the conventional way how I do it. So I just use the radiopaque mark strip, which is there in the Riles tube. I cut into small pieces, put in a small capsule, empty capsules, amoxicillin capsules predominantly, and then I ask the X-ray to be done. So at 36 hours, here you can see there will be markers which can be seen on an X-ray as such. Then at 60 hours, so you can see the markers to be there. So this simple test which can be done in our day-to-day routine. So patient can be categorized according to the pattern of markers. So transit in the right colon or left colon is delayed in patients with slow transit constipation, whereas in colonic ischemia it will be diffusely distributed. And markers progresses normally through the proximal colon but stagnate in the rectum. That means they have a outlet delay, dysfunction, or a dyssynergia. So next important thing is going to be the balloon expulsion test. So we just fill in some air or water in the balloon and then ask them to push it out. So normally you'll be able to push it out within a minute. Anything delay beyond 3 minutes is going to be the obstructive defecation. So it can be done in the left lateral posture. This determines the pelvic floor dysfunction, rectocele, rectal intersusception, or prolapse. So this is a simple latex balloon, what we use. You can just fill it with air or water here, and then ask them to expel it with 50 ml of air as such. Next comes the anorectal manometry. So as I said, the intra-abdominal pressure rises and the anal sphincter relaxes. This is a basic mechanism. In obstructive defecation, so there will be an increase in the anal pressure as such and determines the presence of rectoanal inhibitory reflex, megarectum, requiring large volumes to distend the rectum. So you will require larger and larger volumes in these individuals to fill the balloon in order to make them feel the sensation to pass stools. So this is one catheter which we use. We tend to use it to measure the intrarectal pressure, rectoanal inhibitory reflex pressures also here, internal anal sphincter pressure and external anal sphincter pressure. So this is one case where we have diagnosed that patient to have a dyssynergic defecation because there was a paradoxical increase in the internal anal sphincter as such pressures. So defecography, it is a little bit cumbersome. So we need to mimic a stool here. So it can be done in the form of either a MR as such. So thickened barium can be used to see the real-time passage of content of the barium as such. So which will determine the rectal limiting. It can also determine the anorectal angle during squeezing and straining as well as rectal limiting. So this is one such posture which can be used so that this patient can pass the stool in a comfortable position by straightening the anorectal angle. How to treat? You all know the basic lifestyle measures and exercise and avoid drugs and use of laxatives or purgatives. So the common scenario what we see is the bulk forming laxatives and the stool softeners what we commonly use in our day-to-day scenario. So these are the various onset of action of all these drugs which can be used. And the most important is going to be the polyethylene glycol. It's an isotonic solution. It is used predominantly for colonic lavage, which can also be used to treat the constipation. So use of whole bowel irrigation prior to colonoscopy or surgery, this is a common thing, but this can also be used in smaller quantities to relieve the constipation. The advantage is there is limited fluid electrolyte balance with this, less flatulence and cramps. Next comes the neuromuscular junction drugs. So one important thing is going to be the prochlorpride, which is a 5-HT4 agonist. So it increases peristalsis, thereby stimulates high amplitude proprioceptive contractions in the colon, so thereby relieving the constipation here. So short-term treatment is effective in even patients with IBS. Next comes the ileal bile acid transporter, inhibiting the reabsorption of bile acids in the ileum. It increases the fluid secretion and faster intestinal transit. So it also induces high amplitude propagatory contraction, also relieves bloating in these individuals. It has an additional advantage of lowering the lower LDL cholesterol as such, and it can also increase the GLP-1 levels, so which can be beneficial in patients with diabetes. So this is the basic summary, how to approach a constipation, the primary constipation. So have a proper history, physical examination, and examination of the rectum if possible, and then start using the bulk laxatives or a stool softeners. If they are not responding, then these are individuals who need further evaluation in the form of colon transit study or a colonic manometry, or other patients, the dysenergic defecation can be referred for biofeedback therapy. Thank you.
Very good summarization about constipation, sir. One question, sir. What is your drug of choice for constipation in pediatrics and in pregnancy?
So always try to use the bulk forming laxatives, which is very safe. Isabel husk and all these things. These are more physiological because it tends to increase the stool's volume as such, thereby stimulating the normal physiology, rather than putting them on a stimulant laxatives. It's better, always try better to avoid stimulant laxatives in these individuals.
Sir, what about prokinetic agent in children from domperidone?
So even in adults, we are not trying to use a lot of prokinetics as such. Okay, so the problem with addressing constipation is that we need to understand the exact mechanism what is causing this constipation. So a proper evaluation will help us to determine the drug of choice. If there is going to be, definitely there is going to be a slow transit constipation, that is where your prokinetic drugs will work. Unless there is a slow transit constipation, there is no point in putting these individuals on a prokinetic agents.
Even if it is indicated, children it is little contraindicated. Can we use it?
Not so, that's what I told. So even in adults, we are not going to use prokinetic drugs in every individual. It's based on the proper evaluation. So initially, if you're facing a patient with constipation, better to start them on with bulk forming laxatives or stool softeners. That's more than enough. Otherwise, further evaluation has to be done for each and every patient.
Dr. Vadivel Kumaran, it's a trivial thing, but still, what is the use of these squatting devices in this scenario?
So this is predominantly to address the defecatory disorders. That is the anorectal dyssynergia or pelvic floor dysfunction. So this is where this has a very big role. Even in my practice, I used to advise my patients who use the Western toilet, ask them to place a small stool in front of their commode, place their both foot over that, and then lean forward. That will partly straighten up the anorectal angle. And that it can also indirectly increase the intra-abdominal pressure so that we can make the sphincter to relax, both the internal sphincter as well as external sphincter. As you all know, external sphincter is voluntary. We need to have some deep breathing exercise to control it. Whereas the internal sphincter has to be forced to open by means of increase in the intrarectal pressure. That can be obtained by these maneuvers.
Because this, Indian toilets have become obsolete nowadays.
So that is why I put the picture of that small stool in front of commode and then leaning forward, so that will straighten the anorectal angle, help in patients with defecatory disorders.
Thank you, thank you.
Dr. Balamurugan, diabetologist from Coimbatore.
Yes, sir.
Nice presentation. And as a diabetologist, we see patients with diabetic autonomic neuropathy. It's one of the very common issues we feel difficult to manage, and mostly they have present with the constipation alternating with diarrhea also.
That's what.
What is your experience in managing such patients, and which do you think which drugs can help, apart from what all you have said, the diet, water, everything?
Yes. Yes, so the peculiar scenario about the diabetic autonomic neuropathy is that, as you said, that it can present either with constipation or with diarrhea, either of these, in a same individual itself. So it depends on the symptomatology. So we tend to select these individuals to be put on with drugs which has a better effect on the high amplitude propagatory contractions. So that is where the drug selection is. So if you're going to use this ileal bile acid transporter, which is my drug of choice in these individuals because it has got a beneficial effect on diabetes, it induces a high amplitude propagatory contractions, it also increases the colonic water content of the stools, making it softer enough to pass stools. So in patients with constipation, we tend to use a drug which has a better high amplitude propagatory contraction in the form of either a prochloropride or a ileal bile acid transporter.
We find there's a combination of diarrhea and constipation alternating.
Yes, that's what I told you. Yeah, definitely. It's a difficult scenario. So we need to educate our patients that if they're facing constipation, if they're not going to pass stools even after 3 days, we can ask these individuals to be put on a, as I said, the drug which increases the high amplitude propagatory contraction. Then if the patient is going to have a diarrhea, then we need to stop and then put them on antimotility agents if there is a need, after ruling out any GI pathology in the form of alarm symptoms, basically. That is the most important thing.
Thank you, Vadivel Kumaran. It is such a wonderful presentation. Now, we are proud to invite Dr. Rabindranath from Chennai for talk on role of interventional endoscopy in GE and overview. Over to you, sir.
Rabindranath sir has completed his MD General Medicine from PJ Chandigarh and DM Gastroenterology from Madras Medical College. Currently, he is working as a senior consultant gastroenterologist at Narvi Hospital, Vellore.
So, good morning, one and all. I am Dr. Rabindranath from Narvi Hospitals, consultant gastroenterology and interventional endoscopist. So, my talk is about interventional endoscopy. So, let me introduce to the world of interventional endoscopy. This is a fascinating world that can help in do multiple procedures without an incision. Okay, this reduces the surgical interventions and shorter recovery times. So let me start with a case. A 70-year-old female came to the emergency with multiple comorbidities, had a large 2.2 centimeter CBD stone with cholangitis, sepsis, hypotension. Initially, if you have a stone of more than 1.5 centimeter stone, it is a straightforward case for a biliary bile duct exploration surgery. But in this case, what we did, first we will explain what is cholangiography and cholangioscopy. Cholangiography is actually a giving under fluoroscopy study of the radiographic visualization of the bile duct. And the cholangioscopy, we entered the bile duct and visualize the bile duct itself. So straightforward, I have gone and did a cholangioscopy, and then I saw an impacted calculi in the mid CBD. And after that, I attempted laser lithotripsy. I broke the stone into pieces, and I retrieved all the pieces outside, and the whole procedure finished within 50 minutes. So after the procedure, you can see the bile duct is completely clear in this spyglass cholangioscopy. So what we have done here, a 70-year-old not fit for prolonged surgery with life-threatening cholangitis, sepsis, needing urgent intervention. With ERCP, we cleared the obstruction and placed a stent in under an hour, avoiding a major surgery. This is ERCP's transformative impact. So ERCP is introduced in the 1960s, evolved from a diagnostic tool into a cornerstone of therapeutic gastroenterology. ERCP allows us to visualize, diagnose, treat bile duct and pancreatic issues in one minimally invasive procedure. So ERCP indications are multiple. To be precise, I'll be saying few main indications: any block in the bile duct, any block in the pancreatic duct, any collection near the pancreas. These are the indications for your ERCP. The most common indications are the choledocholithiasis and the biliary stricture. And diagnostic purposes, it's absolute. We nowadays don't do ERCPs. So these are the things we use for the CBD stone clearance. We just enter the bile duct, we cut open the bile duct, we dilate the bile duct, and we take the stone out of the bile duct and place a stent for free flow of bile. And there are multiple causes for bile duct stricture. It could be post-operative, which is the most common cause, post-laparoscopic cholecystectomy, and PSC. There is even AIDS cholangiopathy is a cause for strictures. What we do, we go assess the stricture size, length, dilate the strictures, and put a stent and come back. So as I already said, what is cholangioscopy? With ERCP scope, we introduce a smaller scope. That is just 5 millimeter. We are entering into the bile duct per se. We enter into the bile duct. We see the bile duct, what is happening inside. We just, if we require, if there is a malignancy, we take biopsies. If we have a stone, we break the stone and we come back. So this is all recent advancement. So one important point for the endoscopic removal of ingested foreign bodies to the physicians. Because 2 days before, 2 weeks before, one of my friend's son has ingested a battery. So he went to a local physician and he has suggested him to take 4 bananas. The point is like it is an emergency. Actually, the batteries contains alkaline content that will erode. He called me after the next day. I said go for an endoscopy. But that time that already the battery has reached the small intestine. 2 days later, he had a perforation, that child, and needed a massive laparotomy surgery. So we have to know when to refer for removal of this foreign body. Foreign body ingestion is common in children in 80% and adults with esophageal pathology. And the flexible endoscopy, what we use is the first line of therapy with 95% successive rate and minimal complications, which is emergent, that is causing, that is having sharp objects, that is causing complete obstruction. So these are all the foreign bodies. So interestingly, during the COVID times, I personally have removed 4 nails from the children. I don't know what correlation, the psychological correlation was there. These are all the usual foreign bodies we remove. And even in elderly, we remove this dentures. They swallow the dentures. And elderly people also, they forget to remove this blister packs. They just swallow with the blister packs itself. These are actually emergencies we have to remove. So classification is either it is blunt or sharp, or whether it is poisonous, or even the food bolus itself get obstructed in the already narrowed esophagus. So indications, emergency indications, as I already said, those things that are sharp, those things that are poisonous, so those things that are erosive, like button battery. Non-emergent, that is less than 2 centimeter, rounded, blunt, small toys. If at all, if the patient is clinically stable, you can wait. So next comes the dilatation, stricture dilatation and stenting. So picture a 68-year-old male with a dysphagia from an esophageal stricture due to cancer. The patient has not taken any proper meal for the past 6 months. They came to us with endoscopic dilatation and stent placement. We restored his ability to eat comfortably in a single session. So relieving obstruction in any duct, esophagus, bile duct, small intestine, colon, to restore the function and improve their quality of life. It is a minimally invasive alternative to surgery for conditions like malignant stricture or benign stenosis or even post-operative complications. So this is one of the case we did in a colonic cancer. Patient is not able to pass stools. There is significant obstipation. Patient is not fit for surgery. We placed a colonic stent and patient is okay now. And there are cases where post-laparoscopically bile duct leak might be there. We place a fully covered SEMS in the bile duct, avoiding a repeat surgery. So cricopharyngeal web and Plummer-Vinson syndrome, one more request to the physicians. A cricopharyngeal web is a thin membrane of tissue that can form in the upper esophagus in the junction of cricopharyngeal region. The main presentation is not dysphagia. They come with anemia symptoms. So when we find this, actually, we can, with a simple dilatation, just 10 minutes procedure, patient will be having a normal diet, improved quality of life. So I humbly request you to ask for the history of dysphagia, difficulty swallowing in all your anemia patients. Just send them to an endoscopist if they have any sort of anemia. So endoscopic ultrasound, another superstar in this interventional endoscopy. Endoscopic ultrasonography is a combination of both endoscopy and ultrasonography with improved precision, with high resolution, with minimally invasive intervention. We can deal with pancreatic, biliary, and even mediastinal diseases. We can take biopsies from the mediastinal nodes. So the only difference between this and the CT and MRI is it can visualize and biopsy all at the same time. See, imagine if a patient is coming with biliary pancreatitis. We are suspecting biliary duct stone. We go, we see the stone, we just do the intervention side by side, put a stent over that, cholangitis, pancreatitis improves. So often changing the management on the spot with this US this thing. So it is also used in staging. That is whether the lesion is involving only the mucosa or submucosa, it is involving beyond that. We can stage with this endoscopic ultrasound that changes the picture of the management. So picture a 55-year-old with a pancreatic mass, uncertain on imaging. With US guided fine needle biopsy, we confirmed a benign cyst under an hour and sparing her surgery and lot of relief is inner tension. This is the power of this US. So endoscopic ultrasound is minimally invasive intervention than your traditional surgery, and it is both diagnostic and therapeutic, and we can precisely target which area to take biopsies using needles and other devices. So The first other part is important is the diagnostic US. As I already said, if the patient, 25-year-old female patient presented with symptoms of pancreatitis, ALP is elevated, you are confused what is the cause, that is non-ethanol related, put an endoscopic ultrasound, you can see a stone at the ampulla level that is causing both pancreatitis, that is causing increasing pancreatic ductal hypertension, and then remove the stone, the patient improves on the same day. And then if you have a mass at the pancreas, whether we don't know whether it is malignant or benign, even at the MRI or CT is confusing, do an EUS, see there, put a needle, take biopsy, with rapid on-site, same site pathological examination, you can get the diagnosis in 10 minutes. So common US guided interventions are, first and foremost is FNB and FNA. That is, you take sample from the nodes, those nodes that are not easily amenable, mediastinal nodes, peripancreatic nodes, periportal nodes. We take biopsies, even from the pancreas itself. We take biopsies and we do liver biopsies, and that will give us good idea of this thing. The second thing will be biliary drainage, pancreatic fluid pseudocyst drainage, pancreatic walled off pancreatic necrosis collection drainage, and vascular intervention like glue therapy and pain management. In chronic pancreatitis or a pancreatic malignancy patient, we can block the celiac plexus or you can neuralize the celiac plexus by US, thereby the pain will improve. So as I already said, this is one of the main vascular intervention that we usually do is the varices management. This is an alarming picture. This can bleed anytime. We'll visualize, see how much large it is, what is the feeder vessel, and eradicated the varices completely. Previously, we used to do conventional method. We are not sure whether we have removed or not. With US, we can conventionally remove completely. So this is the pseudocyst drainage. This is a large pseudocyst. Once we have seen a 30 centimeter pseudocyst, patient has significant symptoms. We have placed 2 stents, and within half an hour, patient has been symptomatically relieved. So the another thing is like US guided walled off pancreatic collection management. We have first placed a SIMS. This is lumen opposing metallic stent. We have created a pathway between the pancreatic collection and the stomach. We have dilated up to 15 centimeter. We have put a stent over there. We have put our original endoscope. We entered into the area of that necrosis. We removed the necrosis. Patient improved a lot. But so much easy to say, it takes at least 5 hours to do this. And then we can do GB drainage, what all we can explore. Now, the rapid thing that has been developing is like US guided gastrojejunostomy. Patient is inoperable, gastric outlet obstruction. Patient cannot go for surgery, unfit for surgery, and they don't want to undergo 3 hours of surgery. We go inside, put a stent between the stomach and the jejunum, everything within half an hour, patient starts to have normal feed. This is the magic of this endoscopic ultrasound guided interventions. So this picture, you can see, this is not looking good. Even endoscopists don't like to see this bleeders, spurters. Actually, this is not, encouraging. But after stopping this bleed, we get immense satisfaction. I assure you that. So imagine a case of 55-year-old male presenting with hematemesis, HB drop of 5 g/%, and from a bleeding gastric ulcer with endoscopic hemostasis using clips and epinephrine, we stabilized him within an hour. So it is an emergency. So this is a malarious tear. Whenever a patient has repeated retching with blood vomiting, send to us. We'll find a malarious tear. We'll just put a hemoclip over that. This thing will be stopped. Now everybody of you know this. What is an esophageal varices? How we do? We put a band over it. It causes mechanical obstruction, causes thrombosis and ischemic necrosis. And then as I discussed, this is fundal varices. In conventional method, we apply cyanoacryl glue and this thing. And you know what is gastric antral vascular ectasia? It is one of the bleeding sources of chronic anemia causes in connective tissue disorders, CKD. Not only CLD, even in CKD, CLD patients, we can see this. We use argan plasma coagulation, which is a procedure that uses ionized organ gas to cause the blood to clot to form scar tissue. And then bleeders, there is a new invention called hemospray. We apply this over the tumor. Even with a gastric malignancy, one of the patient was inoperable. We applied this. There was stopping bleeding for 48 hours. Patient underwent surgery and it was better. So this is hemoclips that is used to occlude the banding. These are the multiple methods we use for endoscopic hemostasis. And as achalasia cardia is ability to relax the lower esophageal sphincter. With high resolution manometry, we can diagnose it. How will we treat? We just dilate using the Rigiflex balloon catheter. And once again, there comes one more superstar like submucosal endoscopy. We enter the submucosa. We enter up to the level of lower esophageal sphincter. We cut open the circular muscle fibers, so the sphincter relaxes so that the patient can have normal feed from the same day. That is a magic the patient will feel. 90% of the cardia has this success rate, and everything without a single internal incision. You know, endoscopy, capsule endoscopy, it's a tablet actually. We can swallow this and it goes inside your stomach and your intestine, it takes picture. You know, small intestine is 5 to 7 meters. You cannot enter with your upper GI and a colonoscopy. So enteroscopy is another method of seeing a small intestine. 24-hour pH monitoring, Dr. Arun has already said. And then colonic polyps. So this picture says two philosophies of life. One, love can be found in unexpected places, number one. And number two is actually love can be dangerous. This is an adenoma that is going to become a malignancy later. We have to remove this. So as you know that polyps are the initial stage of the malignancies, it is always advisable to do a screening colonoscopy after the age of 60 years. Any alarming symptoms, we can remove it in an early stage so that you will be avoiding this precancerous. So this is the another thing. What is ESD, EMR? EMR is the third space endoscopy. We remove early gastric lesion that is like less than 2 centimeter in one sitting of endoscopy, and that is something called as endoscopic submucosal dissection. This we do a submucosal injection, lift, we do a circumferential incision and dissect the lesion completely. That is like we are removing the tumor entirely, which by preventing, we are preventing a esophagectomy, we are preventing a gastrectomy, we are preventing a colonectomy. You know, that is all a bigger thing to think of. So another thing is the feeding purposes. Feeding purposes is like in case of patients are very risk of the high risk of aspiration, delayed gastric emptying, hyperemesis cavitarum. What we are going to do is we are just going to keep the stomach empty and continue the enteral feeding by placing the feeding tube inside in the jejunum itself. The one more thing is like percutaneous endoscopic gastrostomy feeding. The tube insertion is placed on the stomach itself. This is in the large debilitating cases, stroke patients that are unable to swallow for a longer time. So similarly, something called as peg jejunostomy is there. During the inside the peg tube, we can place the jejunostomy. Then comes the bariatric endoscopy, which is a revolutionizing obesity management. It offers minimally invasive alternatives to the surgery that help patients to achieve significant weight loss and improve metabolic health. These procedures, from intragastric balloons to endoscopic sleeve gastroplasty, achieve 10 to 20% of total body weight loss with minimal surgical risk, no incision. Patient undergoes significant weight loss. The main funda is like restrictive the stomach capacity or by gastroplastic technique, and the newer thing is like malabsorptive endoscopic procedures. Each one of this topic requires 1 hour of explanation. So I'm just giving an introduction for everything. So once again, and the list continues. You can completely remove endoscopic full thickness resection for anti-reflux procedure, as Dr. Arun said, and there is endoscopic fistula. If there is a fistula or a leak, we can block it. There are newer things of robotic endoscopy and artificial intelligence in endoscopy. And thank you for your patient listening. My intention is to introduce to this new explorative marvel. Kindly utilize this field and help your patients live a better life. Thank you. Yeah.
Thank you, sir, for an excellent overview of all endoscopic interventions in 15 minutes. Any
My name is Dr. Aditya, sir. I'm a consultant physician. Just I wanted to ask only one question, sir. Recently, regarding the bariatric surgery, they were doing these endoscopic balloons they were using. Your view on that, sir?
Your bariatric endoscopic balloon therapy, that's a good question actually. In patients who have PCOS, if the patient is ready to undergo a hip replacement, knee replacement, because of the obesity, they have denied for the surgery. Now you need a transient loss, that is urgent, transient, then reversible loss. You place a balloon inside, patient reduces 15%, gets fit for the surgery, he undergoes the surgery, and after that with the routine exercise diet, he has to reduce. But we can take the balloon outside. So you're avoiding a major surgery, you're avoiding a major incision sutures, just placing the balloon, it restricts the feeding, they improve for the meantime, and after that they have to maintain that. After 6 months, 12 months, we are going to remove it. After that, they have to maintain that with their diet and exercise. Thank you.
Okay, sir. Thank you.
Yeah, thank you.
Thank you for the organizers for giving this an opportunity.
Thanks to the organizers for the wonderful arrangement and opportunity. We will conclude the session.
Thank you for the excellent session on gastroenterology. API Vellore District Branch hosts this TAPICON 2025, which profusely thank the chairperson, Dr. Pavan Kumar Irvi from Narayani Hospital, and Dr. Raghupati from Krishnagiri, and Dr. Appanraj from Melmarutur, and also thank profoundly the speakers, Dr. N. Arun, Dr. Vadivel Kumaran, and Dr. Rabindranath. We kindly ask all 6 of you sit in the gallery while we are performing some formalities to the first session speaker. I'll call upon Dr. Ilangovan and Jonia Madam and Bala Murugan and the other speaker, Venkatakrishnan, to be on the stage, please. And we request Dr. Manigandan and Dr. V.G. Arun and Madam Soumya to be on the stage, please. I request the chairperson, Dr. Manigandan, to present a memento to the first speaker, Dr. G. Ilangovan sir from Kadalur. He is a senior physician. Congratulations for the opening innings you have set in, sir. I request Dr. V.G. Arun to hand over a memento to our Dr. Jonia Madam from Madurai. She is the HOD of Velamal Medical College. We request Dr. Manigandan again to hand over a memento to Dr. Balamurugan, the senior physician from Narayani Hospital. Dr. Venkatakrishnan is here? Anyway, we will see. I request our eminent organizing chairperson, Dr. Chairman, Dr. Sukumar Ji, to hand over a memento to Dr. V.G. Arun. V.G. Arun, Mama. I request Dr. Jonia Madam from Madurai to hand over a memento to Dr. Manigandan from Valajapat. Thank you very much. Now I call upon the second session speakers on the stage and the chairperson too. Dr. Arun from Apollo Main Hospital. Dr. Arun is a versatile gastroenterologist who has spoken in our API already, and we feel proud to present this memento through our chairman, Dr. Sukumar sir. Sukumar sir? I request Dr. Raghupati to present a memento to Dr. Arun. Dr. Venkatakrishnan to be on the stage, please. We feel proud to honor Dr. Venkatakrishnan, our first session, from Dr. L. Raghupati, our senior physician from Krishnagiri, who is a very good associate of Vellore branch. Arun. Arun. Now we present a memento to another young, energetic gastroenterologist from Kaveri Hospital, Dr. Vadivel Kumaran. I request Dr. Pavan Kumar Ervi to present a memento to Dr. Vadivel Kumaran. I request our Joint Secretary of Tamil Nadu API branch, API sector, Dr. Appanraj, to present a memento to Dr. Rabindranath. Rabindranath. Kuduma. I request our scientific core committee member, Dr. Balamurugan, to come on the stage to hand over a memento to Dr. Pavan Kumar Ervi. I request Dr. Manigandanji to come to the stage. He is one of the scientific core committee member in this event. I request him to hand over a memento to Dr. Appanraj. I request Dr. Ilangoman sir to come to the stage to hand over a memento to Dr. Raghupati sir. I am API Vellore District Branch, when we host the TAPICON 2025, is highly honored to present mementos, special mementos to two young gastroenterologists from Chennai with proud and honor. Dr. N. Arun. I will, it is. Huh? The TAPICON 2025 feels honored to welcome our observer from the Tamil Nadu Medical Council, Dr. Vikramji, who will hand over. It is pleasure to call upon my college mate, Dr. Vikram, to present a memento to Dr. Vadivel Kumaran as a special guest of honor. It is honor it is honor to honor Dr. Ikramji with this golden shawl to him. Yes. The eminent organizing secretary of this event, my associate doctor.
So Bipin sir, one second.
While we feel proud to conduct another session, an important session for the current medical practice, whether he is a general physician or primary health care provider or a super specialist. Cardiology. This is going to be chaired by our mentor, a renowned cardiologist from Christian Medical College. Now he is the medical superintendent of an important institution in Vellore. Dr. Jacob Joseph, sir. Please come to the stage to occupy the chairperson. Another one, Dr. Imran Niazi. Dr. Imran Niazi is a senior interventional cardiologist in the KH Apollo Hospital. I'll call upon Dr. T. Adalasu, our eminent physician and a good associate and an able organizer for this 2025 TAPICON in Vellore. Now, it is a time to present the excellent speaker, Rajavel Murugan, the HOD of Toothukudi Medical College. He is going to talk on pathophysiology of clinical evaluation of acute heart failure. Another speaker is going to be Dr. Vignesh Kumar, the young but the energetic cardiologist who has resigned a job from a metro city and come to the rural area to cater the needy people in Gudiyasan Circle. Dr. Vignesh Kumar is going to follow Dr. Rajavel Murugan. Another person, not to say, who was introduced in Indian scenario, intracoronary ultrasonography, which will be helpful to glean vividly the lesions, culprit or whether whatever may be the thing. Dr. Vinod Kumar, the senior consultant cardiologist from Sri Ramachandra Medical College. Thank you. Please continue.
Respected chairpersons, respected learned audience, and my dear postgraduates, very warm good morning and welcome to all. So the topic here is acute heart failure. So pathophysiology and clinical evaluation. So you all know that acute heart failure is always a great emergency and we have to act very swiftly and we have to treat immediately to save the life of the patient. So it is a need of the hour. So of the acute heart failure, nearly around 50% of cases are admitted into ICU directly. And of the 50% admitted into the ICU, nearly around 30% die in the first day. And remaining 30% may die in the second or subsequent admissions. So this Ramana-like statistics may lead to an awestruck situation. So we have to understand the heart failure. So heart failure may be divided into two types. One is de novo heart failure, another one is acute decompensated heart failure. So de novo is a one which is a first onset heart failure so in which the patients had never had any type of heart failure in the past. But acute ADHF is a already chronic existing heart failure. It is acutely decompensated by some of the precipitant factors or triggers, and we are going to see so what are the trigger factors and all. So if you want to satisfy or treat successfully the hunger of your spouse, right, by giving dosa or idli, so you have to understand the hemodynamics and the physiology and ingredients of dosa, how to make a good dosa, right? So if you want to treat the heart failure successfully, effectively, first you have to understand the pathophysiology and clinical features. Then only you can diagnose the heart failure, then only you can successfully treat the heart failure. So next 12 to 30 minutes, I will be talking on the pathophysiology. So imagine our circulation as a canal, right, canal of circulation, and the heart failure, the canal is blocked by the cardiac dysfunction, which is the first trigger. And again, this canal is surrounded by 4 important mountains, right? So the first mountain is the endothelial dysfunction, the second one is the RAS system, third one is the arginine system, and fourth one is the inflammation, right? Actually, this is this was taken by an article, the article European Heart Journal of Association, and yes, so I'll deal all the 4 important pathophysiology one by one. The first pathophysiology of any acute heart failure is a cardiac dysfunction. So you may know what is a cardiac dysfunction. It may be systolic dysfunction, it may be diastolic dysfunction, or any myocardial injury, or any arrhythmias, usually the tachyarrhythmias. Nearly around 14% of all acute heart failure are caused by this tachyarrhythmia. So it is also important one. And then we all know that valvular heart disease is also another component of cardiac dysfunction. That is one of the pathophysiology of this acute heart failure. And the second important mountain is the neurohumoral hypothesis. So you all know, so what is a neurohumoral hypothesis? So the basic and core concept of neurohumoral hypothesis is a RAS system, right? Renin, angiotensin, aldosterone system. So whenever the heart fails, it may be acute heart failure or chronic heart failure, the first system stimulated, triggered is a RAS system. So this RAS system will lead to all types of complications. It may be sodium retention or water retention or vasoconstriction or anything else. So all the main and core components of all the complications or pathophysiologies of this AHF is caused by this RAS system. And the second one is also arginine vasopressin system. It preserves water, and thereby it leads to water conservation and water accumulation lead to edema, all the complications. And the recent concept is a secretion of interleukins, IL-1, IL-6, IL-10, and TNF alpha, tumor necrosis factor alpha is also another. These are other important cytokines, which is one of the pathophysiologies which lead to the clinical features of acute heart failure. And the third one is a renal dysfunction. This is a very important pathophysiology. You have to understand the renal dysfunction. Why? Because there is one terminology called worsening renal dysfunction. Worsening renal dysfunction. This is a criteria. This actually is a prognostic indicator of heart failure. If the heart failure is associated with the worsening renal function, then the prognosis is very worse. It has been proved by so many articles. So that will be revealed later. And then the fourth important mountain is a vascular dysfunction. So the vascular dysfunction, actually it is an endothelial dysfunction which is triggered by the inflammatory cytokines, IL-1, IL-6, IL-10 and TNF alpha. So what does it cause? It increases arterial stiffness, it causes vasoconstriction, and the afterload is increased, and of course systemic vascular resistance is also increased. So ultimately the heart fails, right? So ventricle is remodeled, the arterial is remodeled, so ultimately the heart fails. This is one of the important component. So you cannot blame one pathophysiology as a failure, right? So like our Thaklai failure, so you cannot blame Kamal Hassan alone for Thaklai failure, right? You cannot blame the cardiac dysfunction alone. So there are 3 other failures, Mani Ratnam, A.R. Rahman and Trisha also. So please remember 4 important pathophysiologies for failure of heart. Number 1, cardiac dysfunction. Number 2, vascular dysfunction. Number 3, renal dysfunction. Number 4, neurohumoral hypothesis. The main important thing is the RAS system and the arginine vasopressin system, right? So you have to understand the clinical congestion and the hemodynamic congestion. So these 2 entities are very important. Nowadays the clinical acumen is very much deteriorating among all the budding physicians. We are always fond of investigation. If the patient is having chest pain, do echo. More chest pain, angio. The patient is having headache, CT. More headache, go for MRI. So we never bother to give weightage to the clinical symptoms. So symptomatology will help you to make so many important diagnosis, especially in AHF, acute heart failure. So the time duration is only 4 minutes is allowed. Within 4 minutes, if you are in the ER, you have to diagnose, you have to identify the triggering factor, you have to find out the etiology, and you have to treat effectively and successfully. So please give weightage to the symptoms and signs. So what are the symptoms and signs? So apart from the fluid congestion, so this redistribution is also one of the important pathophysiology to cause AHF. So if one road is blocked, the traffic will move to the another road, right? So if two roads are blocked, and then the vital road is affected. So the splanchnic circulation is blocked. Peripheral circulation is blocked. Ultimately, the congestion will go to the pulmonary circulation. So that will end up in acute heart failure. So now, what are the trigger factors? So you have to identify the trigger factors. So many studies have been done. So this is one of the important study published in JAMA, right? So they have identified, surprisingly, so the infection, pneumonia is the first and most common triggering factor. Around 15% of all patients of AHF admitted in the hospital. And the second one is hypertension. Uncontrolled hypertension, accelerated hypertension is the second triggering factor. There is a 14%. And then the 12 to 13% due to ACS, it's the acute coronary syndrome. And again, other important factors is the poor compliance to the medication. So these are all the trigger factors you have to keep in your mind. And this is a recent guidelines. There is a 2016 ESA guidelines. So this is on order of frequency. So first cause is the ACS. The acute coronary syndrome is the commonest triggering factor. Tachyarrhythmias, remember tachyarrhythmias. And then the accelerated hypertension, and then the infection in the form of pneumonia. There is the most common infection that will lead to AHF in so many patients. And then clinical evaluation. So how to evaluate the patient clinically? So the first step is that you have to confirm the diagnosis, you have to assess the severity, you have to identify trigger factors. So these are the three important steps. And remember, you are given only 4 minutes. In the first 2 minutes, you have to identify, you have to satisfy all these three steps. So symptomatology, again, I am stressing on the clinical symptomatology and give weightage to all the symptoms of the patient. So dyspnea is the most common symptom of AHF, as you all know, right? So it is okay. Then the patient may complain of not obvious dyspnea. Rest dyspnea may not be there. So instead of rest dyspnea, exertional dyspnea. Some of the studies says that exertional dyspnea will lead to more worst outcome in the case of acute heart failure. It is proved by so many studies and articles, right? And then recently, one important symptom is the bendopnea. The patient may complain of bendopnea, right? You have to take care of that, and you have to give weightage to that symptom also. It may indicate underlying acute heart failure, right? And other symptoms you all know, that orthopnea, exertional dyspnea, right? And don't forget, this is abdominal bloating is also another important symptom of acute heart failure. Early satiety, that is also proved to be one of the important core symptom of acute heart failure. Then coming to the signs, right? Acute heart failure, remember, only 4 to 10% of acute heart failure present with cardiogenic shock, right? All other patients are presenting with normal perfusion and normal BP. So BP is not the important sign to diagnose acute heart failure. Instead of blood pressure, please give concentrate on pulse pressure, right? Pulse pressure, if it is less than 25%, so it is a more important component and more important sign which indicates the worst prognosis in acute heart failure. And of course, JVP, right? So jugular venous distension in 80%, it is seen in 80%. It is published in so many articles. These are two important articles I have taken as a reference. And then of course, RALs, right? Crepitations. So always give your time. It takes so much of time for auscultation. So first auscultate over the base, and also all of the lung fields. If the RALs is present, it definitely indicates it is an acute heart failure, right? And high CVP predicts worsening renal function. So that I already told, worsening renal function is a prognostic indicator. So high CVP is a very important prognostic indicator. And then of course, these signs you all know. There is a capillary refill time, cold extremities, and then hepatojugular reflux, and hepatomegaly ascites. These are also another important signs, right? So remember, hypotension is different from hypoperfusion. So normal BP may present with signs of hypoperfusion, okay? So these are the signs of hypoperfusion. There is a narrow pulse pressure. Remember, it is not the BP, pulse pressure. Pulses alternance, right? Take time to feel the pulse. And the cold extremities, obtundation, and the worsening renal function. And this is an important slide of my presentation. Please give your time to take into this slide. So these are 4 important classification: warm, dry, cold, wet, and then cold, dry, right? This is the worst is a cold and wet, whether the patient is congested and deperfused, cold and wet, okay? And if the patient is cold and dry, you can be somewhat happy. The patient is congested, but perfusion is somewhat acceptable. So like this concentration, so once you see the patient, you classify according to this classification and you select the patient, then you can choose the therapy, right? So these are the investigations. So what are the investigation important? So you may see ECG is having the high negative predictive value. So always go for ECG. What about X-ray? So we used to see the X-ray. If X-ray is normal, no pulmonary edema. It is not like that. So 50% of individual X-ray is normal, right? And the surprising fact is the cardiac troponin, right? So relax AHF study, the proof that 90% of individuals with the AHF are having high cardiac troponin. So cardiac troponin is having a high predictive value, and of course the procalcitonin, right? So I want to stress only 3 points: blood urea nitrogen, cardiac troponin, and procalcitonin are the 3 important factors. And again, you all know that natriuretic peptides, right? Pro, BT, BNP, right? So there are so many studies published. There is a pro-BNP. NT-pro-BNP is the most specific marker of cardiac failure, acute heart failure especially. And these are the causes. There is a CHAMP criteria, right, as already told. And risk stratification, how to stratify the risk. So many studies are published, so many profiles are there. Only 3 profiles I am going to highlight. One is the ADHERE registry. It gives importance to number 1, blood urea nitrogen, number 2, systolic BP, number 2, creatinine. If the creatinine is more than 2.5, so remember, look at the mortality, it is more than 19%. So 3 important, as per the 3 important criteria, so this ADHERE stratification is done. The number 2 is the effect risk index stratification. So this takes up the age, systolic BP, respiratory rate, blood urea nitrogen, and hemoglobin also included. And this is another most important guidelines and commonly followed guidelines. The get with the guidelines, heart failure risk score, right? So this takes up only 7 criteria: age, systolic BP, blood urea nitrogen, heart rate, sodium level, COPD, and of course the race is also important. Okay. So with this, game is not over. So you can repair the heart. You can apply POP for the heart if you are diagnosing the case, right? If you are assessing the severity, if you are finding out the triggers, if you are finding out the etiology, and classify according to the hemodynamic classification. There is a warm, dry, warm, cold, right? And cold, dry, and cold, wet. So this is important classification. So this is a take-home message. So acute heart failure, it is de novo, it may be de novo or ADHF. De novo may be the commonest, right? Acute coronary syndrome is the most common cause of acute heart failure. Remember, these are the 3 important indicators. There is a CVP, pulse pressure, it is not the blood pressure, and worsening renal function. So many criteria are there. So important criteria is the GWTG, ADHERE, and pro-BT BNP is the most important marker. Of course, the procalcitonin is also an important marker, and ECG is having high negative predictive value, so go for ECG always, and X-ray is having only 50% predictive value. So thank you for the opportunity. I thank the organizers for giving me this opportunity. Thank you, one and all.
Thank you, Dr. Rajavil Murugan, for the excellent way of how to examine a patient and explaining the pathophysiology, why we should examine a patient within 4 minutes and come to some conclusions. Thank you so much. We will move on to the next talk.
Next, I am very proud to welcome Dr. Vignesh Sukumar, intervention cardiologist from Gudiyatham. As already has been introduced, he has come down from Metro City to serve the rural area, and already Dr. Rajavil Murugan has given very importance of clinical examinations. Now, Dr. Vignesh will throw light upon the therapeutic approaches in acute heart failure. Over to you, sir.
So good morning, one and all. So at the outset, I'd like to thank the organizing committee and the scientific chair for giving me this opportunity to talk on therapeutic approaches in acute heart failure. And the previous speaker, Dr. Rajvel sir, has already made my job easy by explaining the pathophysiology to you. So I would like to just stick on to my topic, therapeutic approaches in the acute heart failure. So the acute heart failure, it could be the different terminologies have been used to call this acute heart failure, something like an acute heart failure syndrome, acute decompensated heart failure, and heart failure syndrome, congestive heart failure. All these terms have been used in the past. So the presentation as an acute heart failure can happen to any spectrum of heart failure presentation, like with those with the preserved ejection fraction, and those with mid-range ejection fraction, and those with reduced ejection fraction, and sometimes those with improved ejection fraction also present with acute heart failure symptoms when they non-adhere to the medicines. So I think this has already been discussed. So we have the Forrester classifications: warm and dry, and warm and wet, cold and dry, and cold and wet. So when a patient presents to you with acute heart failure, you evaluate him and classify him and fix him in any one of these 4 subsets. So as a clinical presentation, there can be 4 different phenotypes of presenting when the patient presents as an acute heart failure. Like in acute decompensated heart failure, where the main pathology will be the left ventricular dysfunction, and patient may have increased left ventricular filling pressures, sodium and fluid retention, and volume overload heart failure. The second phenotype could be acute cardiogenic pulmonary edema, where more than the fluid accumulation, the redistribution, as Dr. Rajvel sir said, redistribution from the splanchnic circulation into the pulmonary circulation and causing the pulmonary congestion and pulmonary edema. And usually when the patients have high afterload left ventricular diastolic dysfunctions, like an accelerated hypertension or a valvular heart disease in the mitral leaflet, mitral valve, and can present with pulmonary edema. And the third phenotype could be an isolated RV failure, where RV dysfunction is the main pathology, and the precapillary pulmonary hypertension causing systemic congestion will be the pathophysiology around the isolated RV failure. And cardiogenic shock is the worst of all the 4 subtypes, where the severe biventricular dysfunction, the decreased cardiac output, end organ hypoperfusion, and usually the systemic vascular resistance in these subset of patients has a biphasic course, where there is an initial increase in the systemic vascular resistance followed by fall and shock. So one size does not fit all. So when a patient presents to you, you analyze him and classify him based on the clinical profile, whether he is congested or he is hypoperfused, and the pathology, you should pathophysiology, whether he is in accumulated state, fluid accumulation state, or a redistributed fluid state, and what are the precipitant factors like an arrhythmia, infection, thyroid disorders, or a non-adherence to medications, and what is the underlying cardiac pathology which has caused this acute presentation, like in a valvular heart disease or a cardiomyopathy, and associated comorbidities, renal and hepatic dysfunction. So you classify him in according to this, and picturize him into the wet and warm, and wet and dry, cold and warm, and cold and dry classified substates. So when a patient presents to you with suspected heart failure, the initial thing what we have to do is you look at him whether he is in shock. So whether he needs a circulatory support, whether in the form of pharmacological or mechanical support. When the patient is in respiratory failure, you give him oxygen, and need for ventilatory assistance in the form of non-invasive or an invasive therapy can be determined on patient basis. So in the initial emergency department, you classify these, you analyze these things, and immediate stabilization, and shift the patient to ICU. So when in the ICU, as the previous speakers pointed out, you look for CHAMP, whether the patient is in acute coronary syndrome, or a hypertensive emergency, or arrhythmia, which is a precipitating factor, or an acute mechanical cause, or pulmonary embolism, which are acute treatable causes which can be identified and treated, and so that the patient can recover from the acute decompensation state. So you identify the cause and evaluate accordingly, and diagnostic workup can be done accordingly, and the optimal management strategy can be done. So when a patient presents with acute heart failure, so you need to classify into the hemodynamic profile, whether the patient is wet or dry. So once the patient, you find out whether the patient is wet, you look for the peripheral perfusion. Whether the peripheral perfusion is adequate, then you classify him as wet and warm. For a wet and warm patient, you look for type of the fluid accumulation, whether the vascular type fluid distribution, where hypertension is the predominant factor. You treat him with vasodilator and diuretic. The cardiac type fluid accumulation where the congestion predominates, you give diuretic, vasodilator, and sometimes ultrafiltration if the diuretic is resistant. So when the patient is dry and warm, it's always already a compensated state, so you just need to adjust the oral therapy and send him back. So when the patient is dry and cold, that is the hypoperfused and hypovolemic state, you give a fluid challenge and consider inotropic support if this patient is still hypoperfused. The worst of all condition is the wet and cold heart failure, where the systolic, based on the systolic blood pressure, if the systolic blood pressure is less than 90, you give him inotropic support, vasopressor support, and consider the mechanical sublets, circulatory support if the response is not adequate for the drugs. And if the systolic blood pressure is more than 90, you can also try vasodilators in this case. So coming to the drug therapy for heart failure, so diuretics, you have two options. You have the loop diuretics, furosemide and torsemide. So when you start the diuretic, the patient imagine a patient who is non-adherent to the therapy and presents to you with an acute decompensated state. So you initially start the dosage of diuretic so that at least equal to the previous tolerated dose or slightly higher than the previous dose. So the loop diuretic, the satisfactory response for a loop diuretic dose should be 100 ml per hour urine output in the first 6 hours. And if you check the urine sodium level, it should be more than 50 at least at 2 hours time. So suppose if the urine output is or the congestion is not cleared with the loop diuretic, you always have another option of thiazide diuretic, something like a oral drug called metalazone, where you can have a sequential nephron blockage with another receptor. So potassium sparing agents, so usually aldactone or eplerenone can be used, one as a diuretic effect, two as to counteract the hypokalemia caused by the loop diuretic effect. Vasodilators, you have the vasodilators nitroglycerin and nitroprusside. When the patient presents with acute accelerated hypertension and acute LVF, you usually start NTG or sodium nitroprusside, and the starting dose could be 10 mics per minute, and you can go step up every 20 minutes or 10 minutes with increase in dosage of 10 microgram per minute and bring down the blood pressure. So another vasodilator, nitroprusside. So when you use the vasodilators, you always have a caution that patient may land up with reflex tachycardia, hypotension, and tolerance may develop with continuous use. So nitroprusside can sometimes cause isocyanate toxicity. The third drug is the nesiritide. Nesiritide is a recombinant B-type natriuretic peptide. It increases the intracellular cyclic GMP and causes increase in the arterial and venous dilation. It decreases the wedge pressure and vascular resistance, improves the cardio output. Sometimes patients develop hypotension and that may lead to renal dysfunction, has longer half-life, so use should be cautious. So there are two trials which studied nesiritide. One is the VMAC trial and the other is the ASCEND heart failure trial. So there was definitely change in the pulmonary capillary wedge pressure when nesiritide was used compared to nitroglycerin, but death or hospitalization for heart failure was not significant at 30 days when compared with placebo. So the other drug is the opiate. Though no recommend, Europeans do recommend IV morphine in selected patients. The Americans, AHA, don't recommend usage of IV morphine in patients with acute LVF. So even in the other registry, there were worse outcomes when patients were treated with IV morphine in acute stage because of the sedative effects of the drug and respiratory depression. So, but even off-label, we do use IV morphine in selected patients in acute LVF in pulmonary edema. Digoxin is used when the AF is the precipitating factor for acute heart failure. So, IV digitalization or oral digitalization can be tried. You always look at the ABG and the electrolytes before starting digoxin, and as usual, AHA don't recommend the digoxin. Inotropes and vasopressors, they improve the myocardial contractility. Sometimes they do trigger arrhythmias because of the sympathomimetic effect. You always monitor ECG and blood pressure when you start the inotropes. The options available are dopamine, dobutamine, milrinone, levosimendan, epinephrine, and norepinephrine. So we all know about the other 4 drugs. So let's discuss something about milrinone. So milrinone is a type 3 phosphodiesterase inhibitor. So Optime HF is the trial which studied milrinone. So more episodes of hypotension and atrial arrhythmias precluded this usage. So and the cost also is another precluding factor. Levosimendan is a calcium sensitizer. So unlike the previous drugs, so it increases the affinity for the calcium rather than increasing the intracellular calcium levels inside the cardiac myocyte. So the EADs and DADs won't happen with levosimendan. So two trials studied levosimendan, Revive 1 and 2, and Survive. Survive compared levosimendan with dobutamine. There was definite change in the BNP levels from the baseline, but there was no change in heart failure hospitalization or all-cause mortality when compared to dobutamine. Vasopressin receptor antagonists are the other options. We have tolvaptan and conivaptan. Tolvaptan was studied in Everest trial. Beneficial effects include improvement in the congestion state, hyponatremia balance, and decrease in body weight. However, there was no difference in mortality or heart failure hospitalization. Approved by FDA only when there is an associated dilution hyponatremia in patients presenting with acute heart failure. Emerging therapies include ularitide, a synthetic form of urodilatin which binds to the atrial natriuretic peptide. Relaxin, which is a recombinant analog of the pregnancy hormone relaxin. It stimulates nitric oxide and inhibits the endothelin and AT2 receptors. Decreases the filling pressure and increases the cardiac output. Omem captive mecabal is a cardiac myosin activator studied in the trial Atomic HF. Esteroxam is a SERCA2A activation and sodium potassium ATPase inhibition molecule, and a trial which studied it was Horizon trial. Sinacigard is an active soluble guanylate cyclase inhibitor. So high episodes of adverse effects. So the trial was stopped previously. Other molecules, a chimeric fusion product of CNP and DNP, nitroxyl donor, beta-arrestin biased AT2 receptor, all these have been studied in acute heart failure, but none of these have come into recommendations. So coming to the non-pharmacologic therapy. So non-pharmacologic therapy, you always have a ventilatory support, whether it could be an invasive or non-invasive. And patients with atrial fibrillation with high ventricular rate and acute hemodynamic unstable state, you can always go for electrical cardioversion. Renal replacement therapy, when the conventionally used diuretics are not responsive in the presence of renal dysfunction, severe hyperkalemia, acidosis, and worsening renal parameters, you always consider ultrafiltration. Mechanical circulatory support, when everything else fails, you can go for mechanical circulatory supports, intra-aortic balloon pulsations, and impella catheter, tandem heart, VA ECMO are the options available. So you always assess clinically and echocardiography, you can always assess the congestion state and hypoperfusion state before starting the treatment and after starting the treatment. Even then, if you don't find something, if there is any mismatch with your clinical and echocardiographic picture, you always have an option of hemodynamic monitoring of heart failure, especially in patients with cardiogenic shock. So the direct measurement of central venous pressure, pulmonary artery systolic pressures, and wedge pressures and cardiac output is possible with the hemodynamic monitoring. Especially for patients receiving mechanical or circulatory support, it helps in escalating or de-escalating the therapy. It can assess the candidacy for LVADs and usually assess at time 0 and then periodically after every intervention. Transition from acute heart failure to chronic heart failure. When the acute phase subsides, implementation and the uptitration of guideline-directed medical therapy of ARNIs, ACE inhibitors or ARBs, beta blockers, mineralocorticoid receptor antagonists, SGLT2 inhibitors, all these has to be started. So management of residual congestion. So once you've already treated at the pre-discharge stage, the residual congestion especially happens when patients with anemia, diabetes, and significant tricuspid regurgitation. So this has to be addressed. Patients with residual congestions at discharge have a associated higher 1-year mortality, 28% compared to those without residual congestion at 18.5%. So pre-discharge indicators of good response include subjective improvement in the patient's dyspnea score, resting heart rate should be less than 100, no orthostatic BP fall, adequate urine output, and the saturation levels should be more than 95% in room air, and decrease in body weight. So treatment outcomes, in hospital outcome, mortality rate is around 3 to 7% for patients presenting with acute heart failure who are not in cardiogenic shock, and those with cardiogenic shock, the mortality rate shoots up to 40%. So predictors of poor outcome include advanced stage, previous heart failure hospitalization, renal dysfunction, very high BNPs and hypotension. High degrees of congestion always associated with longer hospital stay. So you can always see that there is the different trajectories. So uncomplicated hospital course goes fine, and some patients right from the beginning they dip and invariably worsen and collapse. And some patients they have a initial improvement and then followed by worsening. Some have a waxing and waning course. So different trajectories of outcomes happens with different subset of patients depending on their underlying cardiac condition and the associated precipitating factor and all other subsets. So Long-term outcome, 25% of the patients get readmitted with heart failure within 30 days. The Everest trial, where the 12-apton was studied, said that 46% of patients got admitted with heart failure, 15% got admitted with cardiovascular causes, and 39% got admitted with non-cardiovascular causes at the end of 3 years. So median survival decreases when more heart failure hospitalization. Thank you.
That was a nice talk, Dr. Vignesh, who gave importance to the latest drugs. And next speaker will be introduced by Dr. Imran.
And I'll call upon Dr. Vinod Kumar, Senior Cardiologist from Chennai, for his topic on current concepts in management of dyslipidemia with special reference to inclisiran, which is the latest PCSK9 inhibitor.
Very good evening, good afternoon. At the outset, I want to thank Dr. Vetrivel sir for giving me this wonderful opportunity. It has always been a pleasure to be addressing physicians. For past 1.5 hours, we have been discussing a lot of things about emergencies, acute heart failure, acute gut interventions. So let us move to outpatient clinics, which we all see every day. So before venturing into the topic is very lighter, and it's about 10 to 15 slides. Before going into them, I just want to know what will be your target LDL for your patients? What LDL do you want to reach for your patients? Any number, please. 70, good. Any other number? 55, excellent. Any other number? 35. Any other number? So that's a good thing. All these numbers, 70, 55, 40, 35, all these numbers are correct. Let us see how all these numbers pan out to be correct. And what are the drugs you use to treat cholesterol? You want to reduce LDL, what are the drugs you commonly use? Fantastic. Any other drug? Bemdoic acid, excellent. Estimate, wonderful. Then anything else? Okay. So people all know everything, so there is no need for a talk right now. So wonderful. Currently we have an excellent group of drugs to treat lipid. Lipids forms the base for all problems of acute coronary syndrome. We all know that. Today we will try to bring in the older drugs, but I would like to concentrate on the newer molecule as mentioned by few, PCSK9. So PCSK9 is an injectable molecule, so we will talk about that in a couple of slides from now. So we all know the burden of ASCVD is extremely high in India. We have about 54 million people being affected. 25% of the people die because of ASCVD. And when compared to the Western population, the patients who are getting affected by ASCVD is very, very early. It is extremely early, 10 years at least early. So modifiable risk factors, if you see, there are 3 modifiable risk factors like hypertension, major risk factors. In top 3 comes the LDL. So LDL is one factor which can be modified very effectively to reduce the risk of heart attacks or any ASCVD event. So we know LDL gets involved from the beginning, that is from endothelial dysfunction to plaque formation, the plaque becoming vulnerable, then becoming a rupture, then going for an ACS event, and finally a mammoth atherosclerotic deposition. All these stages, if you see, LDL plays a very important role. That makes us one big question. It's a modifiable risk factor and it is involved in entire process. So we want to address LDL at every level. So whenever you try to address LDL, we are effectively reducing the ASCVD events. So now we are going to the first question of guidelines. So like different numbers are there, right? From 70 to 35, how it happens? So it pans from 2011 to 2025 currently. So initially what they all felt is any patient should have, high-risk patient should have LDL less than 100. And very high-risk patient, the LDL should be less than 70. Initial 10 years back, this was the thought process. Then as goes by, in spite of achieving this target, patients developed events. So when the secondary prevention comes into play, they thought these numbers are not sufficient. So numbers started falling. So they said in high-risk patient they wanted less than 70, and a very high-risk patient they wanted to bring down the LDL less than 55. Then came now the latest guidelines of 2023 in European Society as well as LAI, Lipid Association of India. These guidelines are shrinking now, the numbers. From 55, now extreme high-risk group has come. What they are saying in that, whenever there is an extreme high-risk group, instead of 55, you target 40. That's what European Society of Cardiology says. What does LAI says? It goes one step higher. Like never, always Indian guidelines they follow, European guidelines or American guidelines. Here, LAI alone is little one step ahead of European guidelines. What they are saying, if it is a patient is an high-risk group, target 40. If in spite of being at 40, if the patient develops atherosclerotic event, even you try to reduce it to 30. In spite of 30, if he has an event, extremely high-risk group, target 10 to 15. That much is the lowering of LDL level, which is trying to be achieved on a extremely high-risk patients. So now we will go with European guideline. Let us be loud. So extreme high risk, 55, extreme high risk, less than 40. So newer targets are shrinking. So when you have these targets, how much Indians are able to achieve this? When you put them on statins, as we all, the golden standard therapy for LDL reduction, only about, when you want to achieve 70, only 50% are able to achieve. When you want to, 50% are not able to achieve. When you want to try to achieve less than 55 with only statin, nearly 80% could not achieve the target value of less than 55. Now, this puts us a question. We need more drugs which can help or assist statins to decrease these levels. So, now we have drugs like, as mentioned by Estimab, is one good drug which acts at the level of gut. It absorbs your, whatever you consumes food, the food from the gut, cholesterol levels are got absorbed to Estimab. Then we have bempedoic acid, which is a ACL inhibitor, which works at the level of liver. And so we have these kind of newer drugs which can assist statins to reduce LDL. But still, a lot of patients, we are not able to achieve target levels. And whenever the patient have familial hypercholesterolemia, heterozygous familial hypercholesterolemia, which was thought to be 1 in 500 before. Now we are talking about 1 in 200 or 1 in 250. That is also relatively, when you see your first cholesterol levels, patients comes up with LDL of 220 plus. These patients have a strong tendency towards familial hypercholesterolemia. So when we talk about familial hypercholesterolemia, before going to PCSK9, I will tell a small story. Till 2003, it was thought if it is familial hypercholesterolemia, the major contributors were never thought about PCSK9. There was a case report from Japan. A 49 years old patient was reported from Japan. Usually it was caused, 80% of the patients will have a mutation in ApoB. ApoB and other factors contribute to familial hypercholesterolemia. But this time in 2003, they documented one more mutation in PCSK9. That family had a PCSK9 mutation which had an extreme heart attack and the patient lost life. Once they are reported from Japan, the American scientists, they started studying their familial hypercholesterolemia patients and they started seeing the similar PCSK9 mutation in that group too. So the interest in PCSK9 started exhibiting from 2003. Now by 2015, we got the therapeutic agent. That much is the influence of that particular molecule. So moving into the PCSK9, we should know what is the use of PCSK9, how it acts. That is very important. LDLC receptors are very, very important, which are present on the hepatocytes, which will catch hold of the free-flowing LDL molecules in the blood. It will hold. So whenever LDLC receptors are good in number, they will catch hold of the flowing LDL molecules, and your LDL levels in the blood will come down. So what happens? This PCSK9 goes and sits over the LDLC receptor and destroys them. So the LDL levels goes up. We need some agent which can prevent this PCSK9. So we need PCSK9 inhibitors. So then they started developing molecules, like 2 types of molecules are currently available in India. One is PCSK9 inhibitor, that is a monoclonal antibody. Another one is a PCSK9 synthesis inhibitor. That is 2 drugs are there. One is evolocumab, another one is inclisiran. MAB is antibody, that is called evolocumab, it has to be given, is called Repatha. It has to be given 2 weeks once. Once in 2 weeks, you have to give this injection. Then we have one more injection, which is called inclisiran, Cybravia. This has to be given once in 6 months. This is PCSK9 synthesis inhibitor. How it happens? MAB goes and attaches to the LDL receptor. It destroys it. And MAB goes and sits with the PCSK9 and destroys it. So LDL receptors are preserved. And whenever the free-flowing LDL goes and sits in LDL receptor, values come down. What does synthesis inhibitor does? What is inclisiran does? Inclisiran, what it does is goes one step ahead. It is a small interfering RNA. It goes into the hepatocyte level, and what it does, it cleaves the PCSK9 by altering the mRNA. So it prevents the formation of PCSK9. One is going and combining with antibody is combining with monoclonal antibody is combining with PCSK9. Here, inclisiran prevents the formation of PCSK9. So these are the two molecules which are available. So inclisiran has done multiple studies. About a lot of phase 3 trials are currently available. They have shown to cause sustained LDL reduction of 50% from the baseline, which is we always try to achieve in our patients. Next is effective reduction of LDL-C is whether it is sustainable, whether it gives a continuous effort. How they wanted to check. When they give this inclisiran once in a year, they were able to appreciate 36% reduction in LDL. When they give the inclisiran once in 6 months, they are able to achieve a reduction of about 50 to 60%. That's the reason this molecule has become once in 6 months. So if you have a cholesterol, LDL is extremely high, put an injection now, and after 6 months you can go for one more injection. It can be added with your statin. If the patient is not tolerating statin, then you can go independently with this PCSK9 inhibitors. Then, so the other factor, we always talk about residual risk factors. What is this residual risk? In spite of having your LDL less than 55, you seems to have the patients develop one more events. So what is this risk? This risk are estimated through lipoprotein little a and ApoB. For example, this ApoB and lipoprotein little a are not generally touched by statins. But we all know the lipoprotein little a, when it reduces the risk of heart disease. Similarly, if you reduce apoprotein B by 10% on a CAD patient, you reduce the risk of heart disease by 21% in 1 year. So these two factors are not touched by your regular drugs like statin, estimab, bempedoic acid. But both PCSK9s like inclisiran and evolocumab have a great influence on this particular subset. They reduce both ApoB as well as they target lipoprotein little a. And it is usually lipoprotein little a is reduced by the main trials by 25%. Orion all trials including all the population. But Orion 18 is very special. It is done on Indian population. They found lipoprotein little a reduction by 40%. So lipoprotein little a is the one test being done in an adult only once in a lifetime because it's genetically mediated. If it is high more than 50, if it is milligram per deciliter, or if it is nanogram per deciliter report, if it is more than 150, that patient bound to have higher cardiovascular risk. It can be measured only once because it is not influenced by anything else. It cannot change it. But these newer drugs are doing the magic. They are reducing the lipoprotein little a by 25 to 40%. So whenever you have a very high risk patient or whenever you suspect a high risk patient, high ASCVD risk patient, you do a lipoprotein little a. This is done only once in lifetime. So whenever you get a patient with hypertension, diabetes, hyperlipidemia, you can do this and you can be much more aggressive on this particular patient when you are treating them. So that gives us a very good idea where the patient stands. So it's a very important point to be considered. And then Victorian initiate. So now currently this molecule has been approved for patients in spite of statin therapy. If you are not able to achieve your target LDL, then you have to add PCSK9 molecule after estimate. But this trial is called Victorian initiate, where the patients were enrolled at the beginning. If the patient comes with an ACS, the LDL is 180, then put inclisiran or PCSK9, then give along with that statin. This trial shows that we are able to achieve more than 8 times easily the patient target LDL level at the initial stage rather than at the later stage. And inclisiran, it is extremely safe and it has been followed up for more than 3 years in the follow-up data of Orion 8. And the only side effect associated with inclisiran is injection site. Otherwise, there is no. You can give the full dose of inclisiran even in a renal failure patient. Similarly, hepatic failure till the moderate range, you need not have a dose adjustment. So very safe drug. There is no major complications have been documented so far. So CV benefits, already the MACE is towards satisfactory, as shown 26% MACE reduction, and numerically numbers of MI and stroke events are on the lesser side. And Orion 4 is a CVOT outcome trial, which is to be expected to be released on 2026. Because of the benefit of this molecule, it is already into the market. And as I said earlier, inclisiran, first dose, followed by 3-month dose, and every once in 6 months. And all the guidelines currently recommend PCSK9 after full tolerable dose of statin with estimate. If the patient is not able to achieve the target LDL of that particular patient value, then you can add inclisiran. So effective reduction without convenient dosing and the least side effect, this molecule can be effectively utilized among the patients. Thank you for this wonderful opportunity. If you have any doubts, I'm happy to answer them.
Thank you, Doctor, for nicely highlighting the importance of inclisiran, how it was usually a third drug, but now it is moving on to the first-line drug as well. May I request the speakers, all others too, to come to the stage, please, so that we can take questions. Dr. Rajavel Murugan and Dr. Vignesh, please. Any questions from the audience? You can use the mics.
Any questions from the audience side? PGs?
So you're talking about the lipoprotein small a here. So what would be the ideal age at which you would advise as proper screening with the lipoprotein small a? Because you said it should be once in a lifetime.
Adulthood. Once the patient has reached adulthood, we can check, because it's mainly mediated through genetics. So it cannot be changed. It will not be changed by your lifestyle or exercise or your regular diabetic or hypertensive or dyslipidemic medications. So above 20, anytime you can check. Once you check, you will know at what risk factor you are.
Because we are moving towards the stage of primordial prevention now.
Yeah, that's the main.
Can it be done at birth?
Basically, currently, international guidelines, they are saying when you want to, though atherosclerosis start at the birth, but the common recommendation currently is to check patients' lipid profile when they reach adulthood around 20. That is what Western guidelines says. Now, this molecule, they are even trying to see whether it can be used in primordial prevention. Already trial is going on. What they are doing is, instead of giving once in 6 months, they are trying to give this molecule once in a year. So when you give this molecule once in a year, there will be a reduction of LDL by 36%. So whether that should be sufficient, they are saying once the ACS event happens, then we can dose increase to 6 months once, so that it can be used as a reduction for about 60%. Why this becomes important? If you use this as once in a year, your LDL doesn't go up, then the chance of the patient going in for an ACS event is going to drop down significantly. That's what current aim is, but still we need guideline support and paper outcome to do it. And in our center, we are doing a Victorian Prevent trial, where we are doing not established ASCVD patient, those patients who have diabetic and hypertensive. We are enrolling them with zero coronary artery disease. We do an angio. If the angio is normal, then we enroll them for this Victorian Prevent trial. I'm being the principal investigator at my site. We have been following up for almost now 2 years now. And from high-risk patients, now we are moving into preventive strategy. And exactly in UK, they are trying to go for primordial prevention. So probably in another 10 years, when this molecule is out of patency, it will be available in Neil Grease. Everybody is going to take a prick once in a year.
Yeah, I think by this target, I think we are going to address only the macrovascular disease rather than the microvascular disease.
Yeah, absolutely. We are targeting macrovascular disease.
Our target should be more of a microvascular disease where it starts much earlier, rather than the macrovascular disease where we can do all these interventions and all these things.
Yeah, probably then we have to address diabetes much stronger way. See, 3 things are going to come now. All 3 are injectable. One is lipid drugs are going to become injectable. Diabetic drugs are more and more becoming injectable. And we are going to have anti-inflammatory drugs, which are going to come into the market. We are doing a trial in our center. So once these 3 drugs, anti-inflammation, anti-diabetic becoming injectable for a longer period of time, and anti-lipidic drugs, then both microvascular and macrovascular can be addressed very effectively.
Thank you.
Govindra from Salem AP, sir. Sir, regarding inclisiran, is it available in Indian market? And
Yes, sir, very much available in the market. Probably I have used commercially also rather than from the trial. So far I have used 9 vials, 9 patients on them, and one of the good numbers in Chennai. It was initially introduced at the cost of 1 lakh per 1.1 lakh per the injection. It is expensive, that is the problem. Now the company, we have been discussing this with the company too. So now they have come up with, if you buy an injection, the second injection comes at free of cost. So buy from the distributor, it's about 90,000. So the next injection will come to the patient home at 45,000. So it's about, per year therapy is going to cost you about 90,000. So about 8 to 9,000 per month. That is going to be the cost of the therapy, and very much available, sir.
We also have Repatha.
Repatha. That is a monoclonal antibody.
Monoclonal antibodies.
That is, we have to give that injection, it's evolocumab. It has to be given once in 2 weeks. Once in 2 weeks. That cost of that particular injection is 18,000. Probably they are going to revise the cost because the inclisiran has become very, very competitive. So this comes about 1 year, 24 injections, it comes about 2.5 lakhs. This is coming about nearly 90,000. So probably in a due time, they will reduce the cost. Right now, they are giving 3+1 vial.
Subcutaneous or IM?
All are subcutaneous, sir. Both the injections are subcutaneous.
Thank you, sir.
I think this will be the last question.
Sir, premature graying of hair in adolescent and young adult in relation to dyslipidemia. We observe many children and adolescents, they are coming with gray hair. And it's a highly common things we observe in clinical practice.
It's a very good question, but there is no RCT to define that process. Probably this might be a part of familial hypercholesteremia triads.
Yes.
Probably we can look into the other symptoms. If that fits in, then we have to assess, sir. Genomic analysis is the only chance by which we can prove this, but they are proved to be very, very expensive. So we don't do it. But it's a very good sign. Probably I will assign to some of my residents to check on this. Currently, I don't have any data known to me, but probably if others can throw a light.
Thank you all the 3 speakers for highlighting the importance of acute heart failure and inclisiran. Due to lack of time, we will not take another question. Dr. Vetrivel, please. Let's give a big hand to all speakers.
Thank you, Dr. Rajavel Murugan sir, and Dr. Vignesh Kumar brother, and my friend Dr. Vinod Kumar for excellent narration on the subjects, cardiac failure, acute, and the therapeutic measures, and especially the anti-lipid drug, PCSK9 inhibitor inclisiran by Dr. Vinod Kumar. And thank you very much for the chairpersons, Dr. Professor Jacob Jose and Imran Niazi, and my friend Dr. Adalarsu. It's the time to honor them. We honor Dr. Professor Rajavel Murugan. I request Dr. Professor Jacob Jose to honor Dr. Rajavel Murugan of Tuticorin. I request Dr. Imran Niazi to honor Dr. Vignesh Kumar. Please come. I request our young friend Dr. T. Adalarasu to felicitate our young speaker Dr. Vinod Kumar with this memento. I request our energetic nephrologist Dr. Venkatraman to come to the stage to honor Professor Jacob Jose. I request our organizing chairman, Dr. Sukumarji, to come to the stage to honor Dr. Imran Niazi. I request our intellectual and meticulously organizing things, my dear friend Dr. Satish Kumar, the organizing secretary, to the stage to honor our young friend Dr. T. Adalarasu. It is a high time API Vellore District Branch feel proud to honor Dr. Vinod Kumar, who is always associated with us. He has already spoken to us. He has come from the famous Ramachandra Medical College. We feel honored. Both Dr. Satish Kumar and Dr. Sukumarji will honor Dr. Vinod Kumar. வாங்க சதீஷ் வாங்க வாங்க Thank you, sir. Now I hand over the mic to the young doctor, the young physician, Dr. Bala Murugan of Narayani.
Next session, Clinical Pulse. I invite Dr. Vetrivel sir, Dr. R. Ilanjaliyan, Dr. Bhakya Mary Jerome to chair the session. Next will be Dr. Professor G. Ananda Subramanian Oration. I invite Dr. N. Subramanian sir to speak on Keep Your Bone Healthy, Current Treatment of Osteoporosis.
I request the organizing chairman, Dr. Sukumar sir, the organizing secretary, Dr. Satish Kumar sir, on the stage to initiate the first oration in this prestigious TAPICON 2025. Citation inga? Ma citation கொடுங்க. இது கொடுமா அப்படி. I request the organizing secretary, Dr. Satish Kumar, to bestow on the Dr. Subramaniam the medal, gold medal of TAPICON 2025, the Professor Dr. G. Ananda Subramaniam Oration. Association of Physicians of India, Tamil Nadu State Chapter, presents Dr. G. Ananda Subramaniam Oration by Dr. N. Subramaniam of Tirunelveli. Dr. G. Ananda Subramaniam Oration was instituted by the Association of Physicians of India, Tamil Nadu Chapter, in honor of Dr. G. Ananda Subramaniam, who was a professor of medicine in Government Rayapeta Hospital, Stanley Medical College, and director of the Institute of Internal Medicine, Madras Medical College, Chennai, and a renowned physician for more than 50 years. The API Tamil Nadu State Chapter, with great pleasure, is pleased to honor the prestigious Dr. G. Ananda Subramaniam Oration for the year 2025 to Dr. N. Subramaniam, MBBS, MD, MRCP, UK. Dr. N. Subramaniam studied MBBS in 1997 from the prestigious Tirunelveli Medical College, MD General Medicine 2001 from Kilpauk Medical College, Chennai, He is a consultant rheumatologist and working as assistant professor in the Department of Medicine, Velamal Medical College and Research Institute in Madurai, Tamil Nadu. He is a member of Royal College of Physicians, MRCP, Edinburgh, UK 2009, and MRCP Rheumatology from British Society of Rheumatology in UK 2010. Fellow of Royal College of Physicians, FRCP, Edinburgh, UK in 2016. Fellow of Indian College of Physicians, FICP in 2023. Dr. N. Subramanian is a member of Association of Physicians of India, Indian Rheumatology Association, Royal College of Physicians, Edinburgh, British Society of Rheumatology, and Indian Medical Association. He was the president of Indian Medical Association, Tirunelveli, Honorary Secretary, Indian Medical Association, Tirunelveli, 2019. Association Physicians of India, Tirunelveli, City Branch from 2020 till present. Dr. N. Subramaniam is a speaker in APICON, TAPICON, IRCON, conferences nationally, UULAR, APLAR conferences internationally. He was the land referee, Journal of IMA, JIMA in Medicine, Rheumatology 2021, specialist reviewer, Journal of API, India in 2023, co-editor of Tamil Nadu Association Physicians of India, E-Magazine, March 2019. Assistant editor of Indian Journal of Rheumatology, January 2017. Editor of Indian Rheumatology Association Newsletter 2020. Editorial board member, Indian Journal of Orthopedics and Rheumatology 2019. Dr. N. Subramanian authorized many chapters in medicine update book in Indian College of Physicians monograph, and he authorized the topic of rheumatic rarities, dish, athenosis, fluorosis, 2018, 30 publications on his name and listed on ResearchGate. Dr. N. Subramaniam received many awards starting from Maruthuva Nakshatram Award 2023, IMA Tamil Nadu State Branch, and Indu Tamil Isai Award, Academic Leadership State Award, Tamil Nadu State Branch, July 2022, Best Teacher Award by IMA, Tamil Nadu State Branch, September 2022, Best Branch Secretary National Award, IMA, December 2020, Best Academician Award, API, December 2021, API Development Award, National API 2022, Bharat Jayodi Award, National Award for Meritorious Service to the Community of IFS in March 2017, Best Citizen of India Award in May 2017. The Association Physicians of India Tamil Nadu State Chapter takes immense pleasure and honor to award the prestigious Dr. Ananda Subramaniam Oration to Dr. N. Subramaniam at the 21st Annual Conference, APA Tamil Nadu State Chapter, TAPICON, hosted by the Vellore District Branch. We feel honored to bestow this oration citation.
Is that correct? Or? Good afternoon, everyone. I'm really humbled and honored to be part of this API Vellore State Conference organized by Vellore Branch and also Tamil Nadu API. I'm really proud to be with you. So thank you, API Vellore team, Dr. Vittuvel sir, Dr. Satish, Dr. All other organizing secretaries and other team. And also my fellow teachers and professors and the PGs. So I'm really happy to be part of this initiative, and Dr. Ananda Subramanian sir is well known in Chennai circles and also in Tamil Nadu API, clinical cardiologist, and I'm really glad to be receiving this oration on his behalf. So I'm thankful to my teachers from undergraduate, Prof. Edwin, and postgraduate, Prof. Tamilwan sir, and also Dr. Paul Emery from UK Rheumatology, Without their efforts, I can't be standing in front of you. And these are my teachers from MD Medicine. So you all know Dr. Parandaman sir. So I'm really honored to be part of his team, and all others are my teachers from MD Medicine. So the topic over the next 10-15 minutes going to be on osteoporosis. Because we are all going to get older, so we will all get some point, like osteoarthritis, we might get bones which can be brittle. So it's increasing in India also. 1 in 8 males and 1 in 3 females suffer from osteoporosis. That is as of current statistics, and it's going to go up beyond 50 million later this year. Just 2 points worth noting about osteoporosis in Indian patients. Males are getting more, and also the age is younger than the Western population. So it's a definition. It's going to be based on the bone mineral density, below 2.5 based on T-score using the DEXA scan. But there are a lot of risk factors which can be modified based on the age, sex, and other factors, which I'll share with you in a few minutes' time. So the burden is projected based on this data. It's going to be above 75% very soon in the next 15 years. 2050, we all will be living up to 80 years. So it's going to go up. So this is last year. So 6 crore osteoporosis patients across the country, and many are women. So if you look at the bone health, so the skeletal life cycle, so when you are an adolescent, the bones are growing, so it's a process called modeling. And once you reach the late teenage, then it's going to be stabilizing and going to be more mineralizing. It's called scaffolding, osteoid factors. And then once you reach 30 to 40, it is going to stabilize and plateau, and then we're going to get into the osteoporosis onset. So it's going to be, if you're making any changes, it should be in the early 20s and 30s, so if you want to improve. So that's a peak bone mass. At the age of 30, it consolidates, and beyond 40, it's going to be on the downward trend. Of course, it's complicated by our hormonal factors also, both in the males and the females. The males are getting osteoporosis earlier than the females. So osteoporosis is like for the juniors on the teaching slide. So you get loss of bone mass. So the O1 structure is lost, and it can be separate bone islands, more fragile bones, risk of fractures. So it's still, many people are not aware. Of course, endocrinologists and geriatrician and rheumatologists are talking about osteoporosis, but it should be in when you are talking about hypertension, diabetes, and lipids, that should also be coming in every consultation once you are reaching more than 40 and 50. Of course, with the current generation of less activity, more sedentary life, this is going to go up. And obesity is also increasing. Less activity, again, that's a high risk also. So over 100 million people every year do get fractures with osteoporosis. So, and 3 out of 4 people suffer from lactose intolerance. That again increases the osteoporosis risk. So I was looking to the data about Indian studies, less because it's not much talked about. This is one 3 years ago. So you have more osteopenic patients in the south, but along all the 4 regions of country, you have about 40 to 50% of patients have osteopenia, and the remaining about 20% of patients do have osteoporosis. That's probably looking at the DEXA scan. Also, they had fractures before, so that may trigger an assessment. So this is for teaching slide, normal and wedging, and then biconvex, and then crush fracture. So that is due to the bone mass architecture lost, and there is a mild height loss and moderate height loss and a severe height loss. You have crush fractures. So we shouldn't see these fractures anymore because we should be more looking at primordial prevention, as we have discussed earlier on. So this is one of my patients who has been on steroids and long-term complications. So if somebody is suspecting osteoporosis, or they had a fracture, in fact, low trauma fracture, predominantly we are looking at, and then we should look at risk factors for osteoporosis. Usually the renal functions, vitamin D levels, and also parathyroid hormones are commonly to be looked at. And we request everybody to look at the DEXA scan, because that is the only one diagnostic tool as of now to assess and the risk factor and also prediction of osteoporotic fractures. That is the WHO guidelines also suggest the same. You do use the T-score and Z-score for different age group. So These are indications for DEXA based on the WHO guidelines. So apart from the primary osteoporosis with the age-related postmenopausal, and other risk factors are endocrine, patients on steroids, especially with the rheumatoid and connective tissue disease and malabsorption, CKD, and also who have sustained low trauma, low impact fracture in the recent past. This is the Sheffield Frax tool. So you can change it to different countries, so that will have demographic variations, and that looks at the parameters you can see about the previous fracture, height, weight, sex, smoking, and also risk of steroid use, and whether you have a primary or secondary osteoporosis, and then the T-score from the DEXA scan. So you can type it and you can calculate it, you can show it to the patient that this is a high risk of fracture, so we need treatment. If they don't have risk, then you look at the healthy profile also. So this will be, the next page will come up with this 10-year probability of major osteoporotic fracture. So if it is in the green, you do not treat, and if it is yellow, you have to measure the BMD and regular monitoring, and if it is red, you have to treat osteoporosis. So this is the guidance as of now for patients who have postmenopausal beyond 50. So diet is important, healthy foods rich in calcium, vitamin D, which I'm sure and all of us will have less intake, partly because we don't go out in the sun and predominantly under cooler atmosphere. So in fact, today morning there is a pediatrician who sent his report. The vitamin D was 6.4, and he had ankle pain. So many points towards low vitamin D in our population especially. And the other risk factors already I have alluded to. So apart from previous fracture, steroid use and body mass index, and there is a family history of osteoporosis also is there as genetic link. And current smoking alcohol also carries a higher risk and a previous possibility of vertebral fractures in the past. And if they are younger age group, then you look at the risk factors and you go with this modeling and type in the Frax tool, and you get a 10-year fracture risk. And if it is less than 15, you do lifestyle modification. If it is 15% and more, then you look at pharmacotherapy, and if it is more than 20, definitely they need therapy. And what are the drugs? I'll share in the next slide. So if we are going to be on therapy, so the common drugs currently being used are bisphosphonates, whichever oral bisphosphonate, intramuscular or intravenous. So you just follow the pathway here, and initial treatment for 3 to 6 months, but it has to be reviewed, and standard therapies go up to 5 years. So if it is zoledronic acid, and if it is ibaduronic acid, then it's at least 3 years before reassessing. And this is bisphosphonate therapy. If they are intolerant or if they are fracturing in spite of bisphosphonate, then go for anabolic therapy, which is the parathyroid hormone, either teriparatide or abaloparatide, which are newer drugs, and romosozumab, which is the sclerostin inhibitor. So these are the drugs which we have currently. So definitely they need calcium and vitamin D supplementation, because that is the one which improves the bone density reasonably. And the other drugs which treat osteoporosis are, as I alluded to, raloxifene is still there in the group. We don't use it very much. Western population, they tend to use it. Romosozumab and also abaloparatide. So denosumab is the one which is recently being pumped in. It's a rank ligand inhibitor, and it's a monoclonal antibody, again blocks osteoclast maturation and thereby reducing the bone reabsorption, and it's given every 6 months. So it's a good drug, but the 10-year data is also very positive. So it has effect both on the cortical and the trabecular bone. And a couple of studies, like the FREEDOM study, which looked at the fracture risk reduction. So it has shown 68% reduction in the vertebral fractures and a 40% reduction in the hip fractures compared to placebo and the non-vertebral fractures after 3 years of therapy. And this extension trial up to 8 years, that also showed effective fracture risk reduction out of 10 years. So definitely it's going to be long-term. And this study showed combination of teriparatide and denosumab, because teriparatide we still use it for patients who had fractures. And denosumab we also add into that, so that improves the bone microarchitecture better than the individual treatments, particularly in the cortical bones, especially in the vertebral fractures. Abaloparatide, which is the selective agonist of parathyroid 1 hormone receptor, which is given once for subcutaneous injection for 18 months, followed by allodenate orally for 6 months. That improves bone mineral density and reduces fracture risk. This is a sclerostin inhibitor, which is a monoclonal antibody. So that also has shown benefit over a 12-month period but they all have to be followed by oral bisphosphonates. So whichever therapy beyond bisphosphonates, so they will be given for a set period, like 18 months or 2 years or 3 years, followed by oral bisphosphonates to build and stabilize the bone density. So there is a currently licensed drugs for osteoporosis and effect on fractures. You can see for vertebral fractures, all of them can be used, and non-vertebral, so again, they can be used. But if hip fractures, teriparatide has less effect compared to the other drugs. And the ONJ is a concern from the dentist. Somebody who is on steroids or with the osteoporosis treatment, the dentists are really scared to touch, so because of risk of ONJ, but there is very, very minimal. And it's once a year therapy with the zoledronic acid, so very, very less risky. Especially with the adequate follow-up, it should not be a problem at all. This is my own review a few years ago on current treatment of osteoporosis in our Indian Journal of Rheumatology. So this latest couple of studies showed a 12% relative risk reduction with abaloparatide versus teriparatide, which is a newer version of parathyroid hormone for osteoporosis. So this is a retrospective study again that showed a 17% relative risk reduction of fractures, both in vertebral and hip, with abaloparatide compared to teriparatide. So this is the guideline for the PGs. Prevention and treatment of osteoporosis is very good. Osteoporosis International, approved in 2022. So there is no set recommendation for one patient because it's tailor-made to individuals and how they are active, how their job, and what their risk factors like other comorbidities, diabetes, hypertension, lipids, and others, and their activity also. So the drugs I've already alluded to, so we have to tailor-made to particular patients. This is a guideline which I've used for this talk. So guidelines for prevention and treatment of osteoporosis last year. And these are the drugs currently approved across the world in both female osteoporosis and male osteoporosis. Sarcopenia is the one which is newly being discussed, especially in metabolic bone disorders. So it's naturally after the age of 30 to 40, we tend to lose the muscle mass because of aging. So if we do regular physical activity, we can prevent, and especially in the elderly population, because of limiting due to the osteoarthritis or visual difficulties or imbalance, they tend to lose the muscle mass. And that is going to add more risk to the osteoporosis with respect to falls and also instability. So definitely they need to be improved. And overall, it's estimated that about 20% of older adults have sarcopenia, and that we also, as a physicians, we need to look at that concept also. Management guidelines, so we look at the diagnosis as a primary osteoporosis or secondary osteoporosis, risk factors assessment, and then risk fracture assessment for future over the 10 years, and look at the comorbidities and assess their bone health with regards to hormonal profile and the drugs I've suggested. Surgery has definitely a role. If somebody who can't take any medicines orally, you can give IV, but if it is an acute fracture, then you can do kyphoplasty, vertebroplasty. That's definitely still has a role, and they need to be annually reviewed. So there should be a close interface between the physician, orthopedician, and also rheumatologist. So ladies and gentlemen, so management recommendations from this study is looking at regular exercise and muscle strengthening activities, risk factor management, and also anti-catabolic drugs. Adequate calcium, vitamin D are essential, and the drugs include bisphosphonate, calcitonin, parathyroid hormone, and denosumab as per affordability and availability. Evidence-based recommendations show that bisphosphonates remain the drug of choice for our country, and parental zoledronic acid scores over others partly because of compliance, so that we know that the patient has taken it. And followed by denosumab every 6 months, and teriparatide for 18 months, if we are going to go for second-line therapy, and followed by bisphosphonates for another 3 to 5 years. And other options, abaloparatide and romosumab, are still options for future. So the key message is bone health to be maintained starting from the age of teenage. And vitamin D, exercise, and regular activity to maintain the muscle mass are very important. Bisphosphonates and anabolic drugs do help to prevent osteoporotic fractures, and the newer drugs have a role to play at specific settings. So just reading this morning about the scientific report. So that's looking at the Chinese herbal medicine in terms of preventing osteoporosis. And they also have like a Jiva studies. They have studied the magic clusters looking at the genomic involvement of the specific herb and also the bone modeling. So that's interesting. So that's tissue-specific gene expression. So I thought I'll share with you. So if you want to follow me, which I'm on the research gate, and we do raise awareness among the public, both with IMA, APA, and also patient forums. So Osteoporosis Day every year remembered at October 20th. And how to keep your bones healthy. So diet, physical activity, and that's it. And keep your feet on the toes or toes on the feet. What can you do to prevent osteoporosis? Healthy diet, physical activity, and also in conferences, we need to look at the more healthier diet option, I think, and healthy future. So these are references. So with that, I really thank the Tamil Nadu APA chapter and also Vellore branch for giving me this oration in memory of Dr. G. Ananda Subramanian sir, and my teacher, Dr. Parandaman sir is here. Thank you, sir. So it's really, in front of your teacher, you're giving an oration, so my hands are trembling. So thank you once again.
Thank you, sir. Thank you for your excellent oration and very good coverage of all the points, sir. May I now ask the next speaker?
Thank you.
Usually, oration doesn't need any questions. Next speaker will be Dr. R. Balamurugan, the renowned diabetologist and senior physician from Coimbatore. Is going to speak on the diabetes and sepsis, which is very important. When we are encountered with the scenario of sepsis, especially urosepsis or other sepsis, our hands are crossed when it is not responding. So let us hear from Dr. Balasubramaniam sir.
Sir, Balamurugan, eh?
Balamurugan.
Vetrivel sir, thank you very much. And I think he is too tired and so exhausted. Eh? I can see in your face the... So thank you, the organizing committee of this TAPICON, especially the scientific committee chairman, and good to come to Vellore to see all our colleagues, and I can see a lot of younger colleagues here. And greetings from Coimbatore, and we are organizing the Tamil Nadu RSSDI State Conference in August 9 and 10 at Lee Meridian, Coimbatore. I welcome you all the seniors as well as the younger PGs and other students. So generally, when we talk about the sepsis, I just want to give an overall gist of what I am going to talk in the first itself and then conclude. Generally, infections in diabetes occur more frequently, spreads more widely, and heals less rapidly. Some infections are more common, like E. coli, Proteus, Pseudomonas, and Klebsiella. Some infections complicates, like Streptococcus, Legionella, influenza. Some infections occur exclusively in diabetes, like malignant otitis externa, rhinocerebral mucormycosis, necrotizing fasciitis, emphysematous cholecystitis, emphysematous pyelonephritis, and Fournier's gangrene. The delayed wound healing, recurrent furuncles, and boils and pruritus vulvae, and balanopastritis serve as the harbingers of diabetes. This is just in a nutshell. So let's start by defining sepsis. It's very difficult to define. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. This was the definition from the European Society of Intensive Care Medicine of the Society of Intensive Care Medicine. So the inappropriate response to the microorganism invasion, characterized by an overwhelming systemic inflammatory response and cardiovascular collapse. Defining sepsis is very difficult, as I said, but it is not a definite diagnosis. You can see sepsis, suspected infection plus SIRS, suspected infection plus 2 or more, Q-SOFA score or rising SOFA 2 or more. Severe sepsis, sepsis plus hypotension, the category has been removed. Septic shock, sepsis, hypotension after fluid resuscitation, sepsis plus vasopressors to keep the mean arterial pressure more than 65 millimeters, and lactate more than 2 millimoles per liter. Again, the criteria of infection, everyone know that. The temperature, many a time, we think only hyperthermia indicates an infection and sepsis. But on the other hand, in a diabetes, especially elderly people, women with diabetes, it's highly unassuming that, many a time they present with hypothermia. Many a time the staff nurses in the ward come and tell us, sir, the temperature is normal. I will ask, please be specific about the temperature. Sir, temperature 95 degree Fahrenheit, it's normal, sir. 97 normal. So hypothermia is more alarming sign of sepsis than pyrexia, tachycardia, respiratory rate more than 20, PaCO2 less than 32, and WBC count 12,000 and above. And again, the SOFA scores, sepsis-related organ failure assessment. This is called in short SOFA. Sequential organ failure assessment, on the other hand, the parameters include the mean arterial pressure, vasopressor use, platelet count, bilirubin, GCS, creatinine, PaO2 by FiO2 ratio, and the need or necessity for using the mechanical ventilations. And the Q-SOFA score are HAT, hypotension, altered mental status, and tachypnea. Does not need laboratory test and can be quickly done at the bedside. And supportive or confirmatory evidence in sepsis, the arterial blood glucose analysis, which will tell you that metabolic acidosis with an anion gap of more than 5 milliequivalent per liter, blood counts obviously leukocytosis or leukopenia, increase in immature WBCs, toxic granulation on dull bodies, and thrombocytopenia. The CRP may be increased, coagulation profile may be altered, the increased PT and INR, the D-dimer and FDP may be increased. Increase in serum procalcitonin, increase in serum lactate, and positive microbiology. These are all various because it's not a simple diagnosis. We need to suspect and we need to act aggressively, and we need to use all these laboratory tests to support your diagnosis and for a follow-up also. And how diabetes predisposed to infection? Hyperglycemia-related impairment of immune response. Hyperglycemia depresses the neutrophil chemotaxis and adherence to vascular endothelium, phagocytosis, and intracellular bactericidal activity, and opsonization and cell-mediated immunity. There's a vascular insufficiency, sensory peripheral neuropathy, autoimmune neuropathy, skin and mucosal colonization with pathogens like Staphylococcus aureus and Candida species. Organism-specific factors that predispose diabetic to infection. The glucose-inducible proteins promote adhesion of Candida albicans to the buccal or vaginal epithelium. The ketone reductases allow rhizopus species to thrive in high glucose acidic conditions, especially conditions like diabetic ketoacidosis. Macrophage killing of certain organisms like Bacteriuria, Pseudomallei is impaired in diabetes. Again, diabetes induces endothelial dysfunction, and it is a procoagulant state. Sepsis also activates vascular endothelium through a cascade of inflammatory mediators. Therefore, excessive endothelial activation contributes to the organ dysfunction observed in sepsis and septic shock. One of the common infections, urinary tract infection, almost common in 25% of women with diabetes. Asymptomatic bacteriuria is 4 times more common than non-diabetics. Treat in pregnancy and urological intervention. And E. coli is the most common pathogen. Cystitis, there can be dysuria, frequency and urgency. Acute pyelonephritis, flank pain, fever and vomiting. So treat with good antibiotics. And the fungal cystitis, whenever the routine management is not working out well, and sometimes you should think about fungal cystitis, which will respond to the fluconazole orally 200 milligram or then 100 milligram per day for 4 days. Surgical intervention is required if emphysematous pyelonephritis. This is a picture of emphysematous pyelonephritis, exclusively seen in diabetes, 70 to 90%. As I already said, E. coli most common, followed by Enterobacter, Klebsiella, Proteus, Streptococcus, and Candida. Risk factors: women, obstruction in the urinary tract, clinically flank mass and cryptus in the abdomen or thigh. Gas in the plain X-ray, you can see in 85% of the time. Almost CT scan abdomen is the test of choice. You can see in the picture, you can see the emphysematous pyelonephritis, and treatment is medical therapy with percutaneous drainage. Nephrectomy may be indicated sometime. Mortality is as high as 30 to 40% with conservative treatment alone. Sometimes this is emphysematous cholecystitis, caused by gas-forming clostridial organisms due to ischemia of the gallbladder wall. Plain X-ray abdomen may show you a gas in the lumen or within the gallbladder, but CT is more sensitive. Here also you can see the CT picture shows the gas in the gallbladder. And treatment of choice is rapid removal of the gallbladder and broad-spectrum antibiotic therapy, ampicillin with sulbactam 3 grams IV every 6 hourly. Alternatively, ampicillin plus gentamicin, clindamycin can be used, and ceftriaxone plus clindamycin or metronidazole, piperacillin with the tazobactam every 8th hourly. Often complicated by the gallbladder gangrene or perforation, mortality is 15 to 25%. The respiratory tract infection, not more common but delayed resolution and recurrence in more common. Staphylococcus and gram-negative bacteria are nasal carriers in 30%. Tuberculosis, usually a late presentation. Higher lobar lobe disease. Normally, we have right upper lobe disease more common, but here you can see the higher lower lobe disease, cavities, pleural effusion, and multi-lobe involvement is quite common. But streptococcal and Legionella, influenza virus are associated with greater morbidity and mortality in diabetes. Mucor are also common in diabetes, and treatment of the community-acquired pneumonia, the macrolides and beta-lactam agent and newer quinolones, CAP in hospital management, cefuroxime, ceftriaxone, azithromycin, doxycycline. Influenza, and this is very, very important, please note, the influenza and the pneumococcal vaccine should be given for all diabetic patients. All the practitioners and PGs, please note this and try to put into your practice, because most of the guidelines on this vaccination recommend this in diabetic patients. This is necrotizing fasciitis, spreads along the facial plan, necrosis of the overlaying skin, common sites, abdomen wall, perineum and extremities, presence with fever, local pain and systemic toxicity. You can see the picture in the foot. And the type 1 is caused by an anaerobic streptococci and enterobacteria. Type 2 is caused by a group of beta-hemolytic streptococci and staph. Prompt surgical debridement and fasciectomy is very, very important. Many times we stop just giving antibiotic, that is not sufficient. Aggressively, one hand we need to control the blood sugar. On the other hand, give antibiotic, surgically do multiple release incision in this, in addition to the antibiotic. And again, this is Fournier's gangrene. It's a polymicrobial necrotizing fasciitis of perineum, scrotum and penis caused by non-clostridial gas-forming organisms. 40 to 60% of them have diabetes, predisposing genitourinary and colorectal pathology. Extensive tissue destruction, thrombosis of blood vessels, abundant bacteria spreads along the facial plans. And what are you going to do? Medical management with the broad-spectrum antibiotics and piperacillin, tazobactam, clindamycin. Despite good antimicrobial therapy, mortality is 25 to 35%. Treatment surgical, excision and surgical unroofing is necessary. Extensive debridement is necessary, but orchidectomy and penile amputation is usually not required. Laparotomy is sometimes required for a urinary and fecal diversion. And this is again skin and soft tissue infection, which can lead to sepsis. The intertrigo, inflammation involving two closely opposed surfaces. The candidal or occasionally bacterial viral. The weeping red patches very clearly seen in the picture are plaques or papules. KOH mount we can diagnose. Use miconazole, clotrimazole and ketoconazole. This is typical infection of diabetes. Malignant otitis externa, common in elderly diabetic, involves external auditory canal and skull caused by pseudomonas, potentially life-threatening, present with severe ear pain and discharge and hearing effects. Polypoidal granulation, cranial osteomyelitis and intracranial extension may occur. When we were students in diabetes in Madras Medical College, we have treated many cases of this malignant otitis externa. Before the advent of a good glycemic control and the antibiotic therapy, the mortality was very high. And this very important is, how do we diagnose this? The MRI with gadolinium and gallium and technetium scans are very useful in defining the soft tissue and bone involvement. Surgical debridement is most often required. Anti-pseudomonal antibiotics are required. And the duration of therapy is almost 4 to 6 weeks. Mortality is almost 20%. This is rhinocerebral mucormycosis caused by Rhizophus and mucor species, which grow best in the acid medium. DKA is the predisposing factor. Present with nasal stuffiness, epistaxis, facial and ocular pain. Characteristic, the black eschar you can see in the diagram. Many times we have seen a lot of cases following the COVID, sir. COVID, high blood sugars, diabetic ketoacidosis one hand. On the other hand, rampant usage of steroids. There were rampant cases of rhinocerebral mucormycosis. In our hospital itself, we have operated 5 patients during the COVID. Complications, cavernous sinus thrombosis, cranial palsy, frontal lobe abscess, carotid jugular vein thrombosis can occur. And this is again imaging, confirm the CTR, MRI will help. Biopsy scrapping a discharge strained with KOH can show broad septate branching hyphae. You can see in the diagram. Fungal culture grows sporangia and rhizoids. How do you manage it? The liposomal amphotericity, which was on high demand during COVID period, it's not at all available. It was going in the black market. So even though it can cause toxic like renal damage, and monitoring serum creatinine is very important. The posaconazole, the oral broad spectrum triazole, only azole effective. The treatment is almost, we need to continue for almost 3 months treatment for this, and aggressive treatment of diabetic ketoacidosis. The diabetic foot infection, everyone know. Many think people, very mild infection, people think the mild infection ought to lead to severe sepsis. Early identification of the foot infection and proper management with a team is very, very important. Diabetologist, foot care surgeon, and we need to work together to control and identify early diabetic foot at risk so that we can avoid the severe sepsis. So diabetic foot infections are very common. We need to examine the patient from rather than foot to head in diabetic patients. And this is mellitus, endemic in South Asia, often undiagnosed, underreported. It is caused by Burkholderia pseudomallei, spreads through direct contact with contaminated soil and water, especially through skin abrasions. Clinical spectrum ranges from skin nodules, pulmonary infection, encephalomyelitis, and to chronic suppurative infection. So how do you treat it? Bacteria is isolated from blood, urine, sputum, or pus of the involved area. And actually, intensive therapy, ceftazidime can be used. Then cotrimoxazole also almost for 20 weeks. So, dear friends, and what are the take-home message to you on diabetes and sepsis? Majority of the ICU admissions in diabetes care are not aware that they are diabetic. Skin and GAT infection are common at very high blood sugar of more than 500. Genitourinary infections are common with blood sugar of 300 to 400 milligram. CNS 200, 300. Respiratory infection complication occur even with the blood sugars of 100 to 200. Longer the duration of diabetes with adequate control of blood sugar have lesser infective complication. Avoid ICU admissions by diabetes education, early diagnosis, and appropriate intervention. Thank you very much.
Thank you, sir, for the elaborate lecture. We will take questions at the end of the session. Now, ma'am will invite the next.
I invite Dr. Manigandan from Vellore to give us speech on the clinical medicine, a forgotten art. In the era of artificial intelligence, we are not only forgetting clinical skills, we are also forgetting to teach our juniors also. And I hope Dr. Manigandan will enlighten in this aspect, and adherence to the timing is highly appreciated, sir. Thank you.
Definitely, ma'am, because I am from organization committee, so definitely ready to the time, ma'am. It's a pre-lunch session. I think as ma'am has said, in the advent of the CT, MRI, PET CT, the clinical medicine which is become a forgotten art. So that's why I made this presentation. Yeah. So first I'll go by case scenarios. Just I want to make emphasis that what is the role of clinical medicine in spite of the various technologies which are available. Because many of us, when I went, when I spoke to many of the DNB students, when I asked for a cardiac failure, everybody said NT-proBNP and echo, but nobody said about elevated JVP or S3 or Krebs or hepatomegaly. Nobody said. So that's why I want to make explain with the clinical scenarios how the clinical medicine played a major role in this thing. The case one, 50 years old female, postmenopausal by 3 years, no history of JDM or PH, mother of 3 children. Her complaints were severe low backache for 6 months. She was asymptomatic before 6 months, and the pain was insulin onset, gradually increased in severity. It was worse since last 3 months, and pain was 10 out of 10 and 0 to 10 pain scale at time of presentation. She has been consulting number of general practitioners, but her symptoms not reduced. No root pain or weakness of lower limbs or bowel and bladder disturbances. And no history of fall or weight loss, abdomen pain, nausea, vomiting or emetemesis or melena. Past medical and surgical history not significant, family history not significant, personal history, tobacco chewing for the past 10 years. General examination, pallor was present, cardiovascular system was normal, respiratory system was normal, abdomen was soft, mild hepatomegaly was there. And CNS, central nervous system, higher mental functions were normal, reflexes were intact, vibrations were mildly impaired over the toes, SLRT, straight leg raising test was negative on both sides, power was normal, and bowel and bladder was normal, anal tone was intact. So based on this, the clinical findings, our diagnosis was chronic low backache for evaluation with no root pain. So now the investigation side, complete blood count showed a hemoglobin of 9.5 and peripheral smear mild hypochromic and microcytic anemia with hypersegmented polymorphs. Stool for rectal blood was negative. Renal function tests were within normal limits. LFT was normal except for low albumin, and calcium, phosphorus, and uric acid were normal. Now coming to this X-ray, what you can see in the X-ray, there are multiple osteolytic and osteoblastic lesions seen over the vertebrae and the pelvis. So you have an osteolytic and osteoblastic lesion which is seen in the LS spine and the pelvis. So actually bone metastasis classified into 3 types: osteoblastic, osteolytic, and mixed. Osteolytic is characterized by destruction of the normal bone, seen in multiple myeloma, renal cell carcinoma, small cell lung cancer, NHL, thyroid cancer, Langerhans and listosis, and majority of breast cancer also produces osteolytic lesions. Whereas osteoblastic characterized by deposition of new bones, seen in prostate cancer, carcinoid, small cell lung cancer, Hodgkin's, or medulloblastoma. And mixed, actually the mixed lesions are seen only in very less conditions like breast cancer, gastrointestinal cancer, and squamous cancer. With coming to this picture, now how we approach this patient has low back pain, and X-ray showed osteolytic and osteoblastic lesions were seen. So it's a mixed lesion, so possibility of breast cancer, GI cancer, and squamous cancer. So we went to examination again. We checked for the breast examination, there was normal and no lump. And most importantly is, what we missed, or what I missed is, the left supraclavicular node of size 3 centimeter, which was non-tender and hard in consistency, was seen, which was missed. So what I want to emphasize is the clinical examination. I think now everybody must have got the diagnosis. What are the diagnosis? So clue to the diagnosis that, and we did upper GI scopy. He showed a ulcer in the lesser curvature, also probably growth. Biopsy showed adenocarcinoma of stomach, and excision biopsy of the left supraclavicular node showed metastatic adenocarcinoma deposits, and patients were referred to tertiary care center, Adair Cancer Institute for further care. So now what is the peculiarity of this case? Usually in gastric cancer, the commonest metastasis are peritoneal membrane, liver, and lymph nodes. And lesser common sites are spleen, adrenal, ovary, lungs, and brain. And metastasis to the bone in gastric cancer is very rare, and usually that too presenting as an initial presentation is very rare. Usually they may present with weight loss or nausea, melino or something, but that too as a only low backache and with the bone metastasis is very rare. And most importantly, whenever you have a gastric cancer with skeletal metastasis, the alkaline phosphatase levels will be elevated, but this patient was normal. So we have published this case as skeletal metastasis as an initial presentation of a gastric cancer, a rare case report. So now I want to emphasize that head-to-toe examination. What we learned, general examination is very important in each and every case. Even though patient had a low backache, we have to examine as per the protocol, then we should not have missed this. Coming to the case 2, it's a very interesting case. 30-year-old male referred by a gynecologist. He was unable to give sample for semen analysis, that is aspermia. No history of any trauma, no history of any prior surgery. And clinical examination, he was very morbidly obese. He had a central obesity with small hands and feet. He had clinical features of insulin resistance like acantha nigricans and skin tags were present. Cardiovascular system was normal, respiratory system was normal, abdomen was soft, and testicular volume was very low, which was confirmed with ultrasound. It was only 4 ml on both sides, which is very less for his age. And he had a micropenis, stretched penile length was only 4 centimeter. Central nervous system was normal, and you can see the picture of the patient is morbidly obese, and he has very short hands and feet. Now his testicular volume is low, and the stretched penile length was only 4 centimeter. Now coming to these investigations, fasting blood sugar, he had a mild diabetes with HbA1c of 7.8, CBC and RFT was normal, and his testosterone was low, 8.25 nanogram per deciliter, and FSH was high, and LH was high. That means our diagnosis was hypergonadotropic hypogonadism with morbid obesity, very cause. This was the clinical picture how the patient presented. Because hypergonadotropic, because FSH and LH is high, and testosterone levels were low, and with morbid obesity. What is the cause? Anybody can guess? Actually, we missed a very important clinical thing. What the missed history is, he was morbidly obese from the childhood, and he has been trying to reduce his weight, but he couldn't. And he cannot resist eating food. What is the diagnosis? Yes, it was a Prader-Willi syndrome, which was presented in adults. Usually we see in children, this patient has been not seen and he has not consulted anywhere, and he presented as an adult, and we confirmed with DNA methylation study. So it's a rare genetic disorder due to loss of paternal chromosome, presence of hypotonemia, hyperphagia, obesity, and endocrine dysfunction. Usually adults face unique challenges like metabolic complications, psychiatric issues. These are all various phases of Prader-Willi syndrome. Clinical examination which showed us his short stature, central obesity with abnormal fat distribution, small hands and feet, hypogonadism, and behavioral features like compulsive eating. This behavioral feature we missed. That is the reason why we couldn't, and they're confirmed by genetic testing. And management is GH and testosterone therapy, strict dietary modification, and behavioral therapy, SSRIs for mood disorder, CPAP therapy for sleep apnea, and cognitive assessment and support. So eyes do not see what the mind does not know, which our professors used to say. Coming to the last case, 44 years old female mother of 2 children, present with fever, on and off since 3 months. And patient initially had fever with joint pain for 3 months back, investigation done, which showed thrombocytopenia, leukopenia, and she was diagnosed as a viral fever and started on doxycycline and sent. Again, patient fever persisted, came to another doctor after 1 month, where again underwent investigation. It showed thrombocytopenia and leukopenia, and she underwent dengue and scrub typhus and were negative. Patient was again told viral fever and was prescribed on carry pill and sent. Now, patient came to our center with these documents after a month with persistent fever on and off. I don't know, we actually surprised to see the clinical finding. Patient had a very massive splenomegaly, which has been missed for almost 6 months everywhere. Patient goes with the investigation saying they have fever, WBC count is low, platelet is low, dengue, and they prescribe, and this patient has been sent for this for the past 6 months. And with a CECT abdomen, showed a massive splenomegaly with splenic, hilar, and perigastric collaterals, no features of cirrhosis, no evidence of thrombosis in splenic vein or portal vein, and multiple nodes were seen at the mesentery, iotocaval, retrocaval regions, and possibilities were lymphoma or tuberculosis. I think you can see the splenomegaly. It's almost size is more than that of a almost liver. The spleen is more than the liver, and you have splenic, hilar collaterals and perigastric collaterals. You can see the X-ray. I think X-ray shows hilar prominence. CT chest showed multiple enlarged mediastinal lymph nodes, noted in bilateral lower paratracheal, para-aortic, and bilateral hilar stations. Multiple patchy hair sphere opacities were seen in the bilateral lower lobes. Possibilities were tuberculosis and sarcoidosis. So then, this is the perihilar node and mediastinal node. And we did a LDH11 AC level. We can see that the AC levels is markedly high. And we did a cryotransbronchial biopsy from subcarinal lymph node was taken, which showed a non-caseating granulomatous lymphadenitis, which was suggestive of sarcoidosis. And with endoscopy also, it showed portal hypertensive gastropathy and no varices. So the patient was started on high-dose steroids for sarcoidosis, beta blockers for portal hypertension, and calcium and vitamin D for skeletal protection, and cotromal blockers for pneumocystis jirovecii pneumonia. I think this is a very interesting case where a sarcoidosis patient presented with a massive splenomegaly. So same thing, head-to-toe examination is important in all the cases, even though our investigation favors a different diagnosis. So I think in all the past 3 case scenarios, even though we used multiple investigations like cryotransbronchial biopsy, but the basic thing, the clinical examination of a lymph node or a splenomegaly, which was missed. So that's what I want to stress. Always the clinical medicine plays a major role. I think this is an interesting quote from the Lost Art of Clinical Skills from American Journal of Medicine. The rapid extension of laboratory tests of greater accuracy, there is a tendency for some clinicians and hence for some students reaching a diagnosis to rely more on laboratory reports, less on the history of the illness, the examination and the behavior of the patient and the clinical judgment. While in many cases, laboratory findings are invaluable for reaching correct conclusion, the student or the clinician should never be allowed to forget that it takes a man, not a machine, to understand a man. I repeat, it takes a man, not a machine, to understand a man. Thank you. This is my mentor, Professor Dr. Sheshadri, who have been guiding me throughout, especially about this clinical medicine. And thank you.
Thank you, sir.
Questions can be asked during lunch session.
Okay. So in the interest of time, the question sessions can be asked during the lunch time. I request the speakers to come up to the stage.
It's a pre-lunch good session on both the speakers. I mean, it is a wonderful oration our Dr. Subramaniam sir has given, we feel honored to present a small memento. In addition to the citation and other thing, I call upon our State Secretary, Dr. Gunasekar, to come to the stage to felicitate our orator with a memento from this TAPICON 2025 team. We are honored to present a memento to our young speaker, an eminent general medicine practitioner from the rural hamlet of Balajabad, Dr. G. Manikandan, who has vividly spoken on the clinical medicine which we are all forgetting to institute. Thank you, Dr. Manikandan. I call upon Dr. Gunasekharan again to felicitate Dr. G. Manikandan sir with a memento. I call upon one more personality who is untiringly, efficaciously performing the organizing work, even though our physical health of delivery time. And I am really proud to present our able-handed scientific coordinator, Dr. Anita, who can give the memento to Dr. Madam Jerome, Bhagya Jerome. I request Dr. Gunasekar to honor with a memento to Dr. Ilancherian, the Professor of Medicine from Chengalpet Medical College.
And I request our State Secretary, Dr. Gunasekharan sir, to give the memento to our scientific chairperson, Dr. Vetrivel sir.
We invite the guest speaker all the way from Coimbatore, Ilya. Sorry. We'll give him the memento in the next session. I think we are adjourning for lunch only for 30 minutes. 30 minutes will be, because there's a jam-packed workshop is going on. That is why the sparse attendance in this hall. In the afternoon session, I think definitely we'll have packed hall. We have got good plenary session, especially there is a case presentation by our organizing secretary, Dr. Satish Kumar, involving 6 brainy people. Thank you very much. It is honor to honor the guest speaker. I request our, we can call forefather, Dr. Narasimhan sir, to come to the stage. Where you have gone? Narasimhan sir and Manikandan sir, and to present a memento from the TAPICON. Vanga Sandar sir, vanga. Vanga. Yeah. TAPICON 2025 feels honored to honor our guest speaker all the way from Coimbatore, Dr. Balamurugan sir, the senior physician and diabetologist. Sir, Subramaniam sir, Gunasekar sir, please come. Venkatraman sir, vanga. We feel very much proud to honor the guest speaker, Dr. Balamurugan from Coimbatore, with this special memento and shawl. I request Dr. Chandrasekhar sir, who has come all the way from Chennai, previously. And we feel proud to present this unique memento to Dr. Balamurugan. சரி ஓகே
வாசரிஞ்சு பா அந்த போடியம் அந்த உள்ள பொக்கே வச்சுக்கிறாங்க எத்தணுமா அது அட்டாச் ஆகுது ஆமாம் அது முன்னாடி ஒரு சின்ன ஒரு பீஸ் வந்துருக்கு இதெல்லாம் செட் பண்ணுமா அந்த லேப்டாப் வச்சுக்கிறாங்களா அதெல்லாம் மூணு நாள் வச்சு ஏன்பா நீ தான் யூஸ் ஆகலன்னு சொல்லி கொடுத்து அனுப்பிச்சிங்க என்னப்பா நீங்கள் மாற்றி மாற்றி பேசிக்கிறீங்க நான் உள்ளே வந்து நான் கீழே இருக்கா நீங்கள் பிரகாசம் பேக் பண்ணுங்க டிவி இருப்போம் டிவி வேறு எதாவது குடோனில் இருக்குதாப்பா அதை பார்த்துட்டு ஆ ஒன்று இருக்குண்ணே லேண்ட் கிராபிக் சிக்னல் போட்டு இந்த கால் பண்ணுங்க
ஸோ இப்போ அடுத்தது என்னன்றது பார்த்து இதில் ஒன்றும் மாற்றம் இல்லை போயின்னு நான் போய் அங்கே ஸ்டார்ட் பண்ணிட்டு வந்துடுறேன் நான் ஸ்டார்ட் பண்ணிட்டு இவனுங்க எங்கே நம்பர் தான் கூப்பிடலாம் இருக்காங்க ஸ்லைட்ஸ் போடுறது ஏன்பா உங்கள் ஆளை கூப்பிடுப்பா சீக்கிரம் ஃபோன் பண்ணி
டிலே ஆனால் எல்லாம் டிலே ஆகும்
பா உங்களால் டிலே ஆக வேணாம்ப்பா அண்ணா இவனுங்க சரியில்லைங்க இவனுங்க அதை பற்றி நல்லா தெரியும் எனக்கு நான் சொன்னால் கூட நீங்கள் உட்காந்து நீங்கள் கொஞ்சம் மேனேஜ் பண்ணுங்கள் யார் யார் மாற்றி கொடுக்கணும் எப்படின்றத சதீஷ் சார் இருக்கார் Dear friends, good afternoon. Greetings from TAPICON 2025. We'll be going to witness the afternoon session. The first session is a mixed basket. In this, there are 3 speakers and 2 chairpersons. May I call upon with honor Dr. Gauri Shankar, the Professor of Medicine from Government Vellore Medical College, to be the chair. And my dear friend, the veteran physician from Erode, Dr. A.P. Nandakumar, as a chairperson. In the interest of time, we call the first speaker from the famous Christian Medical College, Vellore, Dr. Kurupa George, will be deliberating his talk on role of poison centers in improving poisoning care, the CMC PCC experience.
A very good afternoon to everybody. I'd like to thank the organizers for this opportunity to share our work from the CMC PCC. So, I'm briefly going to talk about the burden of poisoning and snakebite in India, and also the role of poison centers in improving poisoning care. Most of us are familiar with the bleak scenario in India. Every 5 minutes, 1 Indian dies of snakebite, and every 5 minutes, 4 Indians are disabled because of it. We are the country with the leading number of deaths every year, totaling almost 60,000. When it comes to poisoning, every day, 2 Indians die of pesticide self-poisoning, and every week, 2 sanitation workers die of toxic gas inhalation. With this on one hand, we also have a very low doctor to thousand population ratio, one of the lowest in the world. And given this scenario that we have, it's also quite alarming to note that for a country of 1.4 billion, we have less than 10 poison centers to help with actually managing this burden. And this is in comparison to Europe. For a population of 744 million, they have 70 poison centers. Coming closer to where we are, looking at our Vellore district, we have unique challenges that we have faced here over the past few decades. One, our block here has a very high suicide rate. We have close to 2,000 emergency department visits every year because of deliberate self-harm. And mortality in Tamil Nadu because of poisoning is one of the highest in India. We had audited our referral pathways to look at patients who were presenting here with poisoning. And we noted that at least 88% had attended one regional hospital before coming here. All were either discharged against advice or had been referred following clinical deterioration. On looking at why they had deteriorated, the three main reasons were: one was a delayed access to appropriate antidotes, the second was inappropriate antidote administration, and the third was suboptimal clinical stabilization and resuscitation prior to transfer. As we all know, this region has almost 60% of India's tanneries and the associated effluent treatment plants are located in and around Vellore. And deaths are occurring due to lack of adequate personal protective equipment and also delayed medical care. There are also chronic health effects which are occurring due to toxic exposures which have been left unaddressed. So putting all these together, there was a high incidence of deliberate poisoning, delayed access to appropriate antidotes and antivenom, incorrect antidote administration at primary contact centers, suboptimal resuscitation and clinical stabilization at the primary contact center, and unique occupational exposures, all leading to high poisoning-related mortality and morbidity in this region. And it was in response to this that the CMC Poison Center was started. So what is a poison center? Poison centers are specialized units that provide poisoning and envenoming related information to healthcare personnel and the general public. The most basic part is a poisons information center which provides information. And there are different models of poison centers, but each of them has to have a poisons information center. But poison centers can also have a clinical toxicology unit where patients with poisoning are managed, and analytical toxicology laboratory facility could also be part of it. So the world over, there are different models, and we'll discuss what we do here. So the Poisons Information Center will actually provide information on various diagnostic aspects of poisoning and envenoming related to the identification of toxins, their toxic dose, elimination half-life. Also provide information on first aid and management, such as decontamination, antidote, and enhanced elimination. They could also provide information on chemical safety and respond to emergency situations where there is a release of chemicals. In addition, poison centers also will be conducting relevant need-based research, training of health workers and community outreach, and also contribute to regulatory interventions and policy initiatives. So coming to our poison center, we were established in 2019 in the Medicine 1 unit. And our Poisons Information Center, we work 24 hours, 7 days a week throughout the year. We can be accessed via a toll-free number, email, or WhatsApp. And the primary information source is TalkSpace, which is our database. And we also have in-house case and product data files. So our center has our Poison Center also has a clinical toxicology unit, which I'll come to. So coming to the Poisons Information Center, our team is made of physicians and a nurse educator. And the workflow at the center is we receive a call pertaining to poisoning. It's taken by an on-call physician who will then get the relevant clinical data from the caller, and based on what information is sought would provide that information. A review call would be made 4 to 6 hours later, and then this information would be entered into our database by our nurse educator. So this is how our Poison Center works. We also have a clinical toxicology unit where we provide interdepartmental consultations across our institution. We also manage and evaluate patients with heavy metal poisonings, alcohol, nicotine, and other substance use disorders. And we have both inpatient and outpatient facility for this. We also provide some basic analytical toxicology service where bedside screening tests, immunoassays are provided, dithionite tests for paraquat poisoning, and we also collaborate with other laboratories in our institution, which have other testing facilities, such as the ICPMS for heavy metal estimation. And our fourth component is education and awareness. So we have a nurse educator, and we are actively involved in conducting a lot of education for a varied group of people, so for adults and children, on various aspects which I'll be coming to later. So what is the impact that we've had? From the time we started, we've got at least close to 50,000 calls, and every year the number of calls that we've been receiving has been steadily increasing. We've received calls from every state in the country. Most of our calls are from Tamil Nadu and the southern states. If you look at the calls, a majority are from healthcare providers, though we do get calls from the public, and that is increasing. We've also noted that many centers are situated in remote areas, so almost 60% of our calls are from primary and secondary hospitals. And in such places which are resource limited, it's very important to rely on clinical skills and simple bedside techniques to diagnose and manage poisoning and snakebite patients. We get, our data shows that there are almost an equal number of calls pertaining to children and adults. And the type of calls, when it comes to children, the majority are accidental exposures, whereas when it comes to adults, it's the opposite, and most of them are related to intentional or deliberate self-harm. If you go into the kind of exposures that we encounter, the five most common, the first leading it is agrochemicals, followed by industrial and household chemicals, pharmaceuticals, bites and stings, and finally plants and mushrooms. And if you break this down further, when you look at agrochemicals, we see pyrethroids, rodenticides, herbicides being far more common than organophosphates. Though generally people, whenever they think of an agrochemical, a pesticide, the first thing they think of is actually OP. Looking at industrial and household chemicals, significant number of exposures are because of corrosives and irritants, household essential oils, and minimally toxic household products. And then coming to pharmaceuticals, psychotropic drugs, there are many multi-drug overdoses and certain others. And when it comes to bites and stings, the most common call is because of snake bite, followed by scorpion and other stings and bites. Looking at outcomes for the patients, when we've looked at that, almost 71 have actually been cured and discharged. We have found that 6% had to be referred to another hospital. Similar, around 11% were discharged against advice, and 9% continued to be admitted at 48 hours, and almost 3% had expired. So I'll just quickly go through a case study of a kind of call that we received. So this call came from Chad Hospital, Bagaim, and the incident occurred in Javadi Hills, which is close by, where a 33-year-old male woodcutter, while cutting tall grass in a forested area at around 12:30 in the afternoon, developed stinging pain in the left hand at the base of the index finger. He swung his hand and the snake was thrown away and killed. Within 30 minutes, he developed swelling that extended till the elbow. There was mild bleeding from the bite site, and he subsequently went to the nearest primary health center. He reached that place in 2 hours, Javadi Hills being quite a remote area. And on reaching the hospital, he was treated with Avil and dexamethasone and then referred from there. 4 hours later, he presented to the Chad Hospital, and it was from here that we received a call. When he had presented here, they noted that the swelling extended beyond the elbow. The 20 WBCT was positive, and they shared a photograph of the snake. And their query to us was, shall we administer antivenom? So this is the image of the snake. The specimen had been brought, and we were able to identify this as the Indian green pit viper. They had described it as a green thin snake, so we assumed that this is what it was. And using these images, we were able to consult a herpetologist who was able to confirm the snake. And the advice given was not to administer antivenom, because we know that the Indian polyvalent antivenom does not neutralize venom from this particular snake. And because of the 20 WBCT being positive, we advised that they could refer the patient to a center which would have blood products, and in the event that the patient clinically had bleeding and required the same. So the patient, after 4.5 hours, then was referred to our center, where we saw the patient in the emergency department and admitted him. These are some images which shows the edema, and the 20 WBCT, by the time he had reached us, was negative. His total count was 12,600. PT-APTT was normal, fibrinogen 228, and an elevated D-dimer. So the coagulopathy he had was actually resolving. There was a very small subclinical venom-induced consumptive coagulopathy which was improving. We admitted him and managed him conservatively. He was monitored, given pain relief, and discharged after 4 days once the signs of local envenoming had begun to subside. On follow-up on day 10 post the bite, he was doing well. So just to highlight how, these are the kinds of doubts that clinicians have when they get patients, and this is where we are able to provide information which actually is able to guide treatment for patients with poisoning and snake bite. And over the last few years, the common clinical difficulties and scenarios that we've faced when people call in is unknown bites being assumed to be a snake bite, administering antivenom for all snake bites. A lot of bites by snakes are from non-venomous snakes, or they may not, or like in this case where it would not help to actually give antivenom. Rather, they could have side effects and serious reactions because of receiving the antivenom. And assuming that all pesticide poisoning is actually OP and administering atropine, that's also very commonly done. We end up having patients who then have toxicity because of that. And also the significant resource constraints under which people are working, where they do not have access to tests and further treatment. Another area is mass chemical exposure events, and these are the numbers over the last few years. Just last year, we've had almost 32. And in such situations, I've just put up some images of instances where we've been involved. We are able to provide emergency information for the public and health providers on containment measures, first aid, decontamination, and medical stabilization and antidote therapy, and disseminate this via electronic media. And in many instances, we've also helped to coordinate and guide the transfer of patients with industrial chemical exposures from peripheral centers to our Center for Advanced Management. So apart from this, we're also actively involved in health worker training and community outreach. So we do have training for doctors, their annual CMEs and CNEs on managing and diagnosing snake bite, responding to chemical incidents and chemical emergency preparedness. Apart from this, we are involved in training nodal officers at the state level and primary health workers on snake bite management, and we've been involved with the Ministry of Health and Family Welfare to train doctors across the country in many states of our country. We are also involved in training school children, and over the last 5 years, we've reached close to 8,000 school children, teaching them about appropriate first aid and snakebite prevention. Because if you teach small children, they're likely to practice the right thing. And this is also one of the areas we are involved with. Just last year, we have trained close to 4,000 village we've made visits to villages in the community and trained close to 4,000 people. We also we educate our patients who come with snake bite on prevention and appropriate first aid. So we are involved in a lot of training activities, and one is the training of industrial personnel in various aspects of chemical safety. Also on the safe storage of agrochemicals for patients and the general population as well. So these are our activities, and I'd just like to put up our Poison Center number for any queries, our website, and you can access us even by email. And I'd like to close here. Thank you.
Thank you, ma'am. Excellent presentation. And the CMC EPC Center It's a very, your way of treatment, not only in treatment, also a rapid response, and also giving guidance to the remote areas through media. It's really appreciable. Thank you.
Thank you, sir.
One more thing, ma'am. Alluding to the use of polyvalent vaccine in snake bite, after confirmation of the particular snake species, is there any research studies for use of monovalent vaccine, antivenom?
Yes, sir. There is. We do know that in many parts of the country, for instance, in Kerala, we have the hump nose viper. We do not yet have antivenom for that. So yes, we do need to work on developing monospecific antivenom for certain snake species which are regionally very important. So even certain vipers in Northeast India and in, like the hump nose viper in Kerala, it would be important, sir.
Is there any ongoing research?
Yes, so there is, but I think we're still very far from actually having a product that would come to the market.
Thank you.
Only one question. Your experience with paraquat poisoning, madam. In paraquat poisoning, your experience.
So most of our, we still see patients with paraquat poisoning, and the outcomes are quite poor. But we do have a certain number of patients who, we are able to manage conservatively and who have pulled out. But those who go into respiratory failure because of the alveolitis, those are the patients that we have actually lost. Yes.
Wonderful. Wonderful lecture. What is the sensitivity of the whole blood clotting time? 20 minutes test you mentioned, no?
So around 60 to 70%, so.
Okay. What are the conditions to be positive?
So in many other conditions, can you repeat your question?
DIC, what are the conditions to be positive?
Anybody who is on, say, warfarin, having underlying coagulopathy, liver disease, it could be positive.
Okay. Thank you.
The picture of snake, green color, pachepambu, you have seen, is a non-poisonous.
Yes, sir.
The patient developed cellulitis edema. Edema is most likely due to the anaerobic sepsis infection due to saliva from the snake. Do you advocate metronidazole in the management of the cellulitis in the snake bite of non-poisonous cadre?
Okay, so in non-venomous snakes, we do not expect any local reaction, but if there is evidence of an infection, like you're suggesting cellulitis, there would be a role for antibiotics.
In our intensive medical care, we used to give metronidazole in a non-poisonous with cellulitis. So metronidazole plays a major role in the management of non-poisonous bite cellulitis.
Thank you, sir.
Thank you, ma'am. Thank you.
Thank you.
If there are no questions from the floor, next I call upon Dr. T. Geeta from Coimbatore to deliver a talk on approach to endocrine hypertension. Over to you, ma'am.
Good afternoon to one and all of you gathered here, respected chairpersons, respected members of the audience. I'm very grateful to the scientific committee for having given this topic, approach to endocrine hypertension. Hypertension is one of the commonest non-communicable diseases, and 85% is due to essential hypertension, but there's a significant number, 15% due to secondary hypertension. And in secondary hypertension, endocrine hypertension is a major cause, which is very much neglected or rather not identified. And it's very interesting to note that many a time, an endocrine disorder might first present as an initial presentation only with hypertension. And given the fact that in due course of time, endocrine disorders will present with a cluster of symptoms and signs that are so specific for the endocrine disease, it's not possible to miss it. And more interestingly, endocrine disorders are completely treatable. Many times the hypertension occurs on account of an endocrine neoplasm. It's surgically correctable, and without any morbidity and mortality, the patient can live if the patient has been diagnosed early. So that's the most important aspect on the basis of which I decided to take up this topic. So secondary hypertension as already mentioned, can range anywhere from a renal parenchymal disease to a renal vascular disease to an obstructive sleep apnea, aortic disease, or even due to drugs. I have had at least 2 patients who had very high blood pressure, youngsters on account of cocaine poisoning. NSAIDs, exogenous cortisol administration, OCPs are all some of the reasons for secondary hypertension on account of drugs. And endocrine causes, when do we consider? First of all, before going into endocrine causes, when in the first place we consider the possibility of a secondary hypertension. What are the clinical clues? A young patient presenting with hypertension. This does not mean that an elderly person presenting for the first time with hypertension need not be a secondary hypertension. Anybody with a malignant hypertension, patients who have consistently a very high blood pressure, more than 160/110, patients with end organ damage, patients who have resistant hypertension, that means not responding to 3 different classes of drugs, which includes a diuretic, patients with refractory hypertension, which means that on 5 different classes of drugs. So all these are patients which definitely need to be evaluated for a secondary hypertension. And among the secondary hypertension, when do we consider the possibility of an endocrine hypertension? We have a plethora of findings, as already mentioned, symptoms and signs. If looked carefully, you just cannot miss it. So to just familiarize with the audience, anybody presenting with paroxysms of hypertension, say for example, the commonest we know is pheochromocytoma or paragangliomas. Patient may present with paraparesis, quadriparesis on account of hypokalemia, as in Conn syndrome, primary aldosteronism, myopathies in hypothyroidism and hyperparathyroidism, metabolic alkalosis in Conn syndrome, metabolic acidosis in Gordon syndrome, unexplained GI symptoms in the form of nausea, vomiting in hyperparathyroidism, primary hyperparathyroidism, visual disturbances in problems related to the pituitary gland. There is a macroadenoma, as in cases of acromegaly. Psychiatric manifestations, patients with hyperparathyroidism, Cushing syndrome, electrolyte disturbances, as already mentioned, hypokalemia in Conn syndrome, sometimes hypernatremia in Conn syndrome, hypercalcemia in hyperparathyroidism, cardiac disturbance, dysrhythmias, atrial fibrillation. Sometimes it is the only manifestation of a hyperthyroidism, lone atrial fibrillation sometimes, where we are not able to identify any other presentation. Young stroke, many times patients present with a young stroke, we search for all causes, but it might after all be an endocrinal cause. And always get into the history of the family, and any family history of somebody in the family with less than 40 years of age who had hypertension. Patients with PCOD usually present during adolescence, and many times they are hypertensives. Do not always think it is because of PCOD. It could still be because of an endocrine hypertension. Obstructive sleep apnea is both a cause and effect of endocrine hypertension. The reason is, in obstructive sleep apnea, there is stimulation of the RAS. This results in increased production of mineralocorticoids. This aggravates the hypertension. On the contrary, when there is an increase in mineralocorticoid presentation, as in the case of Conn syndrome, there is retention of water and salt, and it produces parapharyngeal fluid retention and edema, which is a cause of obstructive sleep apnea. Anybody with a goiter. Neurofibromas or neurocutaneous markers may be present in pheochromocytoma. Renal calculi, as with hyperparathyroidism. And if there's an onset before puberty, precocious puberty, consider as in the case of virilizing tumors, Men's syndrome, or even with congenital adrenal hyperplasia. So all these are some of the extensive kinds of presentations, and still there are more. So we have to look out for these. So coming to a case report, this was a case which presented in our hospital. A 47-year-old female patient who had an 8-year history of hypertension. She was on calcium channel blockers. She had been presenting frequently with episodes of hypokalemic periodic paralysis. During this episode, she came to us. During the workup for the hypokalemic paralysis, we found she had urinary potassium loss. She had low serum potassium. ABG revealed metabolic alkalosis. And in due course, we went to find out that there was high aldosterone and low renin levels, which produced an increased aldosterone-renin ratio. It is to be remembered that endocrinal workup is costly. It's not cost effective, and it is time taking. So we have to very much depend upon the clinical clues, the symptoms, and the signs before we actually land up with serological investigations. So while investigating, this case turned out to be a primary aldosteronism, and this is quite the commonest cause of endocrine hypertension. And another thing is to be remembered, this patient also had a right suprarenal mass. Many a time, we call what is called as incidentalomas. Incidentally, while doing an ultrasound abdomen or an ultrasound of the neck, you may find that there are masses. And as I told you, many of the times, these masses, if removed, will cure the patient of the endocrinal pathology and the hypertension. However, in this patient, we did not go for a confirmatory test, which is a saline loading test, for want of funds. And if you still want to know which is the adrenal gland which is active, sometimes you may not have a mass. Of the two suprarenal glands, one might be hyperactive. You'll have to go for an adrenal vein sampling. So this is how we work up. But in this case, with a hypokalemia, with a metabolic alkalosis, with a high ARR, yes, the diagnosis was very clear. And it's also to be remembered that whenever there is a high aldosterone production, there will be a false positive ARR. Whenever there is an increase in renin secretion, there can be a false negative ARR. So ARR, that is aldosterone-renin ratio, is at best a screening test, and it is not the most reliable, final confirmatory test. So we have to keep all these things in mind as we are doing the serological investigations. And when you're treating a patient with antihypertensive medications, it is advised to stop for at least 2 weeks before you undertake these tests. This is a second case report of a 49-year-old man with a 10-year history of poorly controlled hypertension. He had a hemorrhagic stroke in the past. Post-discharge, his BP could not be controlled despite multiple antihypertensive therapy. This was his admission to us. He had a 6-month period of abdominal pain and a weight loss of around 8 kg in 6 months. His serological parameters, basic serological parameters were normal. And his ultrasound abdomen was done because of his abdominal pain. It showed again a right suprarenal mass. Later on, it was proven to be pheochromocytoma. And after finding the mass and knowing that he has had a malignant hypertension, metanephrine analysis was done and it turned out to be high. So when we are evaluating metanephrine, all these serological investigations which you do for endocrine have to be done with a set of precautions, as I meant to you regarding ARR. When it comes to metanephrine, please understand, any patient in the ICU, a patient who is under stress can also have an increase in metanephrine. So there should be an increase in metanephrine of at least 3 times the normal. Or if you are in doubt, you can go for 24-hour urine collection and see for the metanephrines. It should be at least twice above the upper limit of normal. Only then we can consider it as a positive test. I also had a patient, a young woman, 36 years, who came to me with the classical features of a triad of headache. So you must remember this classical features of this triad is very classical for, and it has a high sensitivity and specificity for the possibility of a pheochromocytoma, a pounding headache, palpitation and sweating. I was very sure that she had a hypertension on account of pheochromocytoma, but it was negative. The metanephrine test was negative. There can also be false negative tests because sometimes the production of the hormones can again be paroxysmal, or it can be a small tumor. So it is always possible that these tests can fail us. And some of the prerequisites for a pheochromocytoma testing includes that the patient should be calm, a morning assessment, the patient should already have an IV cannula. Don't prick the patient before taking for a metanephrine test, because all these can increase the stress levels of hormones, and this can produce false reports. So you have a big list of do's and don'ts when you have to go for the screening and analytical tests of endocrine hypertension. Cushing syndrome, the commonest that we see is an exogenously administered cortisol, but it is also possible that endogenous cortisol production, many times from a pituitary tumor or ectopic production, can be responsible. And if it's from the pituitary cause, we call it as Cushing's disease. This also can present with hypertension. And I have given a big list of some of the clinical presentations of Cushing's syndrome. It is not as common as we see in a case of hypertension due to a primary hyperaldosteronism. And for Cushing's syndrome, you will also have other associated findings like fasting hyperglycemia, hyperlipidemia, hypokalemia, leukocytosis. They are always prone to a higher level of infections. And the case detection is with 1 milligram overnight dexamethasone suppression test and a midnight salivary cortisol test. This is a third case report. It's interesting that this lady was the grandmother of one of my house surgeons. She was 65 years when she presented to me. She was taking care of this boy. She was very active, cooking well, and the boy was a little upset because she was no longer interested in cooking. She was lethargic. She complained to me of constipation. She was not even interested to talk. She was depressed. I was clueless when I saw her. She was not a known hypertensive, but when I examined her, she had a high blood pressure. Her serological examination, which was done in the course of examination, it was not anticipated because I wasn't aware at that time, and it was 14 mg%. So it was because of a hypercalcemia. I later referred her to the endocrinologist, and she was found to have parathyroid tumor. And then, of course, she went for a resection, and she was doing well. So the most common cause of hypercalcemia, especially when they present like this, you have to consider a primary hyperparathyroidism. And again, patients can have a multitude of symptoms and signs ranging from neurological changes, psychological changes, to osteoporosis, to renal lithiasis, etc. Acromegaly is something, whenever you go to the wards, this is something that I have seen very frequently in the sense that within my career of 20 to 25 years, at least 4 to 5 times of acromegaly. You must always observe the patient. One very interesting symptom that patients with acromegaly will tell you is that there is an increase in space between the teeth. You will find that they have a macrognathism, increasing spacing of the teeth. Look at their face, they may have a frontal bossing. Look at their hands, they will have a splaying or large hands. Look at their feet will be large. Sometimes there is also hepatomegaly, splenomegaly, cardiac enlargement, and they again can present with hypertension, usually in the age group of 40 to 50 years. And many a time it is because of a pituitary tumor. And in those days, we were advised to just take a lateral view of the skull, where you will see the pituitary fossa, the sella turcica. Usually it is the size of a peanut. You can just fit in your tip of the little finger into that, pocket. But now you will find that it is enlarged. So that was one of the ways before the arrival of MRI in our institution. This was one way by which we used to identify with the given set of clinical findings that it could possibly be an acromegaly. And of course, thyroid disease, day in and day out, we notice thyroid diseases. Hyperthyroidism can go in for systolic hypertension and pulmonary hypertension. And hypothyroidism can produce diastolic hypertension. And as I told you earlier, many a time hyperthyroidism need not present with all the classical presentations. I remember a 72-year-old woman who presented to me with just atrial fibrillation. And when I sent her for a workup to the cardiologist, he simply told me one statement: do a thyroid assessment and please send her to me. You know, there is a condition called apathetic thyrotoxicosis, where the individual is totally apathetic in the sense most of the symptoms are lacking or not present. They may just present with a hypertension alone or an atrial fibrillation alone. And congenital adrenal hyperplasia, it's more common in children, and they can present with hypertension. So to end up, this is just the message I would give you. Any patient with episodic or malignant hypertension, sustained hypertension, high blood pressure, family history, younger age group, please consider a secondary and get into all the details of the history, rule out the possibility of drug intake, and always look for clusters of symptoms and signs, and go for a very systematic approach and apply the appropriate screening tests. And imaging plays a very big role, because many of the time, as I told you, there will be tumors which are responsible, ranging from ultrasound to CT scan to MRI to many of the nuclear medicine scans are very useful as far as endocrine hypertension is concerned. And somebody had already put this: the eyes see only what the mind is prepared to comprehend. And I think we as clinicians can do a better job. Don't take hypertension lightly, evaluate, and definitely it may be of great help to the patient. Thank you.
Wonderful presentation, madam. Which is the commonest endocrine disorder with hypertension you are coming across in OPD, madam, and like medical colleges? Any commonest?
Thyroid disorders, sir.
Thank you. Thank you.
Any questions from the floor? There is none. Thank you, ma'am.
Thank you very much.
Now we invite Dr. Arun VG, a consultant physician from Salem, regarding practical tips to use artificial intelligence in modern medicine.
Good evening, good afternoon, everybody. Hope I don't bore you off post-lunch. Thank you. So, yeah, artificial intelligence is one word that we've been hearing in and out nowadays. Take whatever industry it is, artificial intelligence is taking over. Now, the big question is whether artificial intelligence will take over the job of the doctors or not. Let's see how artificial intelligence is being used in the healthcare industry at the moment. So artificial intelligence, there is a revolution that is happening especially in medicine at the moment. There have been lots of revolutions in the world. Industrial revolution, the computer revolution, the Y2K revolution, everything. Once the computers came in, there was a talk whether the jobs will be obsolete, which is not. So we still, as humans, we are still working. So the same applies to medicine as well. So artificial intelligence is transforming the healthcare industry, enabling breakthroughs in medical imaging, drug discovery, personalized treatments, predictive analysis. This is just an introduction for the far-reaching impact of AI on the future of health medicine. So how do you define artificial intelligence? AI refers to the simulation of human intelligence in machines, enabling them to perform tasks that typically require human cognitive functions, like learning, problem solving, and decision making. So we as humans, we acquire knowledge, that is the input, and we do an output. Let's say you touch, you feel, you go, it is sensed, it is processed in the brain, and then there is an output. Likewise, the machines also has to have an input, and then they give an output. So the input is given by the humans, and the process of it, it has to learn. So the artificial intelligence has to learn. That learning process has to be done by the humans only. So artificial intelligence needs humans to consume whatever data that is being provided to the computers or the artificial intelligence. They learn by that, and then they solve the problems. So when did this come to medicine? So ChatGPT, this is news articles. There are a few news articles. ChatGPT diagnoses rare neurological disease in a 4-year-old after 17 doctors miss it. So this is in US. This 4-year-old has been suffering from severe pain in her legs, weakness in her legs, and multiple doctors, actually 17 doctors had missed this. It was actually third cord syndrome. So which was picked up with the mother had typed in all the blood tests, all the MRIs, all the scans, and all these symptoms that the patient had into ChatGPT, and ChatGPT gave the diagnosis. Then the mother went in asking the physicians to test for the third cord syndrome, and they found it to be the third cord syndrome. So that is when it has been used in medicine as well. AI paradox. So there is a crunch. Recently there was an article in the newspapers telling this is from Tirunelveli. Due to shortage of doctors, all the leaves have been cancelled. So we've been overworking and underpaid. That has been the norm for a lot of time. And there has been number of rising suicides in the medical professionals. So mental health is also being affected. So is AI the answer? We have to look in. So is AI better than doctors, and should we be using it? Yes, AI is different, but it is not exceptional. It is not the, it has to, it doesn't sit outside the rule of evidence. Again, evidence-based, we practice evidence-based medicine. The AA also has to sit in this evidence-based medicine. Whether in the future, if let's say AI diagnoses something, are the insurance agencies going to pay us? That's the next big question. So there is an healthcare professional, there is a patient, and the third person is the person who pays. And that insurance agencies, are they going to pay? Whether if the AI detects something, that has to be dealt with. So key aspects of AI learning. So AI, there are lots of data that is available on the internet, online. So that data is taken inside, and that has to be learned, and over time it improves. So likewise, let's say if we have a patient, we do learn on the second patient. One patient we treat with some antibiotics, it doesn't work. We go for a second antibiotic. Likewise, AI, we have to give data to the AI so that AI also learns those things as well. And they have been programmed to solve complex problems and to make decisions online based on the available information. And decision making, language understanding. Language understanding is basically Siri and Alexa. That is speech to text, or speech to speech as well. Alexa is basically speech to speech. Siri is a speech to speech. When you talk, it answers us back. So that is a form of artificial intelligence. And object recognition, you upload images to it, and then it tells you what the diagnosis or whatever. So as I've told you, so there's something called as machine learning. So machine learning is something what we already know. So all the data is already there. AI can build it on that, improvise on certain things. And when there is something called as deep learning. So basically, if you put it into perspective, machine learning is something like if you take manual cars, there is manual cars, and then it became automatic. So the gear is automatic. So this automatic cars is machine learning. So there is a sensor which is set, which will change the gears automatically when there is a set desired speed is reached. Let's say at 30 kilometers per hour, it goes to the second gear, third gear respectively. And if you reduce the speed, the sensor works. So that has been taught to AI. And deep learning is what has been happening in Tesla cars, where there is an artificial, you don't have to drive, the car itself drives. So that is what is the aim of every industry, where it can replace humans. Like cars, there is no, the driverless cars has been the norm of future. So whether this is possible or not is what we have to look for. When you put it into perspective from the medical perspective, whether this going to happen or not, we don't know, but we aim for it. So without the doctors, whether the AI can predict something and treat a patient it's a questionable thing. So we are safe for now. So next thing is language processing. As I told you, there is speech to text and text to speech. And robotics, we've been looking at robotics for a long period of time. And there are multiple. Recently, there is one surgery which was done sitting in one country and doing it in another country. Okay, and image recognition is through vision. Before I go into this, I want to show some practical tips to use AI. Hope my screen is visible. Okay, so the first thing I want to show is this is called as gamma.app. This is a form of artificial intelligence to do PowerPoint slides. So for everything whatever I'm showing is free of cost. It is not paid versions, and everything you have to log in with your Google account. So now I'm going to create a new PPT. So you can either copy and paste a text. So if you go and use ChatGPT, it will give you a text, and you can paste it in this, which can create slides for you. Or you can generate with AI. Or you can upload a PDF. Let's say you have a journal, you upload the PDF, and it can generate an PPT for you. So I'm going to generate. Let's say I'm going to do acute kidney injury. Okay, so I'm just gonna, I'm not giving any other prompt to AI. I'm just typing in acute kidney injury, and it's going to give me the slides. It might take a few minutes. Okay, so this is the slide one, acute kidney injury, a critical challenge. What is acute kidney injury? Common causes, recognizing AI, AKI, diagnostic and staging, management, prevention, and conclusion. So this is, it gives you 8 slides. It can give you only 8 slides initially. So this is unpaid version. Paid version can give you any number of slides. And if you want to change the color of the theme, and if you want it detailed, brief, and medium, if you want to use AI images, or if you want to generate, you want to change anything, you can change anything here. So I'm going to generate these slides now. Okay. So I'm not doing anything. AI is working for us. It will give you nice images. It will give you an so it is typing everything. It is doing on its own. Okay, so this is something which is easy to do. It will give you nice slides. Yes, obviously you have to present this. You have to read about it and then present. But it is easier for us to make slides, and it looks beautiful as well. You can change, and each slide, everything can be changed. If you want to edit anything, if you want to change anything, if you want to change the image, everything can be changed. And this can be downloaded or shared as PDF and everything. So you can export it. You can export it as PDF, export it as PowerPoint, or Google Slides and everything. So this is one tool where you can do PowerPoint slides. Next thing I want to show is we've had multiple flow charts. You would have seen multiple flow charts like management of hyponatremia, hypoglycemia, hyperglycemia, whatever it is. So there is multiple charts which are there, which you put it on the slide, it is unreadable. When you look from far, it is unreadable. So this is one app where you can create your flow charts very easily. So this is, I'm just showing an example. So this is, I can change the shape of whatever you want. Okay, I'm clicking on this, and then if you put in, it will create another box. Okay, if you want another box, it will create another box. So this will create, if you want to split the flow chart into 2 pages, this is one useful tool which we can do. Okay, this is one app. This is called as Miro, M-I-R-O, miro.com. This is again a free version as well. Everything I'm showing is free app. Next thing I want to show is Mind Map. So this is a Mind Map AI. So where you can generate a flow chart by just clicking on the AI. So I'm going to generate, create a mind map. So I'm going to create a mind map for treatment of hyponatremia. So probably the internet is not working. So I've already generated one. Sorry. Okay. So here, if you see, so that it has created a treatment of hyponatremia. So whether it is mild asymptomatic, moderate to severe, hypovolemic, euvolemic, and hypervolemic hyponatremia. So it has given you a flow chart. If you want the flow chart to be up and down, left side, right side, everything can be changed here. You can make the layout customized. You can be changed, anything can be edited here, colors can be changed, everything can be changed in this. So this is Mind Map AI. So if you want to use it in MacBook, so there's an app called Mind Note. Again, this you can create flow charts in this. So now I want to show something else. This is Google Scholar. So simple Google Scholar, I've searched for papers on side effects of bariatric surgery. Okay. So in view of time, I've just already clicked everything. So this is a self-report of gastrointestinal side effects after bariatric surgery. Okay. So I've tried to open this article, which is not available. So this has to be purchased. You can see only the abstract of it. So you don't have this article. So I just have to copy this, and there's an app called SciHub. So if I paste it in Sci-Hub, it will give you the whole article. So this is the original article that has been published. So you can use it for free. Not all articles are available in this website, but it is developing each and every day. Okay, so you can download this. So if you want to look into, if you don't want to read the whole article, and if you want to analyze this article, there is another website called as SciSpace. So SciSpace, there's an option called Chat with PDF. So I'm going to upload this PDF, so that I've already downloaded, which is that self-report on gastrointestinal effects of bariatric surgery. So this will read the whole PDF, and then you can ask any question to this. Okay, you can generate a summary of the paper, results of the paper, conclusions, explain the contributions. So we can ask what is the methodology that is used. So if you ask that, so it will generate an answer. It will show you what is the methodology that has been used in this article, and it will also show you relevant articles in this. Okay, so this is the methodology. What is the study design? What is the participants, data collection, and standardization? So before I finish, I just want to show how this is one common AI tool that we use in a day in, day out. Most of us use ChatGPT. So I want to use ChatGPT. So how do I'm going to use this? I have a ready template. So I want to write a discharge summary. So most common time-taking thing is discharge summary. So I want to write a course in hospital. Okay. So this is a 40-year-old with a male history of cough for 2 months, pulmonary tuberculosis, diagnosed as pulmonary TB, based on sputum examination, chest X-ray, chest X-ray, initiated on ATT, developed raised liver functions, so started on second-line drugs, liver functions improved, symptomatically improved, and I'm asking the ChatGPT to write a course in the hospital for discharge summary. I'm going to generate a course in the hospital. So this gives a beautiful version of the course in the hospital that we can use. I just copy paste it to the discharge summary. Okay, I want to write a advice for this patient in Tamil. Let me ask ChatGPT to write detailed. So I've asked for ChatGPT to write it in Tamil, and it is writing in Tamil. So it can be used in any local languages as well. So this is very useful for us to explain, for us to give it in discharge summary. So what has to be taken, what precautions, what are the symptoms that you expect. So when do you want to repair, when do you want to come back, and everything that is that is written. Okay. So due to lack of time, I'll just end with this. Thank you.
Wonderful, Arun, and it is very useful and very interesting and very informative for doctors and PGs. And is it, as you said, is it possible to replace the clinicians in the future?
I said at the moment, at what pace of AI is being used in medicine, it is not going to replace us. But I don't know about the future, because it is changing every day. AI is improvising itself every day, and it is taking like cars. There is automated cars. Driverless cars have been there for the past few years now. So whether it will take the jobs of the doctors, radiologists, I would say yes. Physicians, no.
Okay. So as you said, it can optimize our work.
Yes, it can reduce the work burden for us. So simply, you can just see in ChatGPT, if you want to write a discharge summary, it can dictate it. You just talk on the phone, and it will give you a discharge summary. So everything can be dictated to it, and then it will beautify it in a special way, and then give it to you.
Yes, it's wonderful. Okay. Thank you.
Thank you.
So in that case, the ChatGPT consultation,
yes, sir.
They go for a second opinion with ChatGPT.
Yes, sir.
In due course of time, will we get more litigation against our own medical profession?
Sir,
that is also.
Sir, medical litigation, yes, but that's what I told you, sir. Initially, insurance is not going to pay if you use AI at the moment. But AI can help us improvising the treatment models. Like we use some scoring methods for certain diseases, like community acquired pneumonia, we use a curb 65 score, which improves whether it is tell us whether to admit it or not. So likewise, it is a tool to help us, and it is not going to replace everything. Yes, sir.
Now it is going to help us in OPD setup, OPD services.
Sir, OPD services, one thing I wanted to show is Google Lens. If you have a rash, if you have some urticarial rash that is there, you go and search it in Google Lens. It can give you a certain diagnosis. It can give you at least a differential diagnosis of what type of rash it is. Okay, we recently had one patient who had IgA nephropathy. After diagnosis of IgA nephropathy, we sent it to Google. We checked with Google. It did tell IgA. So it can help us in outpatient as well, so especially for dermatology and chest X-ray. If there is a small nodule which is there, which is not picked up by the human naked eye, it can be, sometimes AI can pick up.
Can we use Siri for typing or voice typing?
So Siri is to answer, sir. Siri will answer you back. Siri is not going to tell you anything. So Siri will search it and then answer you back. You cannot copy paste it. So ChatGPT will help you in that.
Thank you.
Thank you, sir.
Any other questions?
I think the first AI came in the ECG recorders.
Yes, sir.
How many of you still follow the ECG machine given reports? Do you believe it? Maybe PR interval, maybe heart rate.
Yes.
But we can't go by,
Yes, sir.
Otherwise, we'll be treating everybody as a myocardial infarction.
Yes, sir.
Compared to hematology, the compared to hematology gives all blasts in, then it gives you the patient may suffer from leukemia. I don't think we can use the mission-infused reports.
No, we cannot use it, sir.
Yeah.
We cannot use it.
Probably now, time being, for different diagnosis, things like that, I think we can try.
So we can ask a differential diagnosis. So for rural areas, some general practitioners are there. They can type in the symptoms.
Depends on what's the input you're going to give.
Yes.
Okay.
So the more the prompt, better the outcome.
I don't know. I'm using the computerized CC machine for the last 20 years. It's not improved at all. This is the same status quo. How much improvement you are given?
Sir, improvement is
all the AI, everything. It's something you're teaching, and you're asking a question, like a teacher, professor, taking a class to the students, and you are asking a question again. You are here giving in a documentation form. So the AI is going to pick up from what you have taught it to.
Yes.
Number one. Number two, you said about the suicidal cases and all from the students. I find because the last 10 to 20 years, the number of PG seats have increased. Number of medical colleges have increased. The doctor to patient ratio is coming down.
Yes, sir.
So at that time, I think
in
a
Tamil
country
Nadu
like
it is
India, I don't think we have a human brains itself to make easily work on. We have enough time to work on. Not that we have so much of patient load and not to, to use all these things. But at any time, I strongly feel this all AI cannot replace a human judgment. And
I do agree with you, sir. I do agree with you. AI is not going to replace physicians, at least. Radiologists, I don't know, but physicians, no. It will assist. It will assist us.
Yeah, it can support the physicians only. Yeah.
Yes.
Thank you.
Thank you.
So
Thank you,
at the outset, we thank the organizers of this meet, TAPICON 2025, Vellore APA and Tamil Nadu APA Organizing Committee at the prestigious CMC Vellore. Thank all of you.
Thank you. So I really thank Dr. Vetrivel sir for giving me this opportunity to talk on TAPICON 2025. I thank Dr. Satish Kumar, Organizing Secretary, Dr. Anita Madam, and Dr. Sugumar sir as well. Thank you all organizing team. Thank you, sir.
I thank the organizing committee of the TAPICON. Thank you.
Speaker, Dr. Kurpa George. And all the speakers come to the stage, please. It's very honored to honor yet another talented professor of medicine, Dr. Madam T. Keeda from Coimbatore. I request Dr. Samuel sir to hand over the memento. I request Dr. Arun to receive the memento from Dr. A.P. Nandakumar, our talented physician from Erode. TAPICON 2025 feels honored to honor Dr. A.P. Nandakumar. I request Dr. Madam Keeda to hand over the memento to Dr. Nandakumar, please. It's time to honor our Professor of Medicine, Dr. Gauri Shankar from the Government Medical College, Vellore. I request our HOD of Medicine, CMC Vellore, Dr. Samuel Ansak, sir. Thank you both the speakers and chairpersons and the HOD of Medicine, Dr. Samuel, sir.
We are honored to welcome Dr. M.S. Ashraf from Trichy, Dr. A. Deva from Vellore as the distinguished chairpersons for the upcoming session.
This session is devoted to oration. We are happy to invite another chairperson, Dr. Deva from KH Apollo Hospital, the practicing nephrologist. Today, we have two orations in this session. One is Dr. Guruswami Mudaliar oration, Bumps Along the Bumps, Common Medical Issues in Pregnancy. It is going to be orated by none other than our Professor Dr. Saravanan Thangavel from Coimbatore. We invite Dr. Saravanan Thangavel with folded hands to the dais. I request Dr. Ashraf Shah to present this medal of oration to Dr. Saravanan Thangavel. We invite another chairperson, Professor Ko Bharani Madam, to the dais. Good afternoon, friends. Association of Physicians of India, Tamil Nadu State Chapter, presents Dr. M.R. Guruswami Mudaliar oration. It is going to be orated by none other than our talented physician from Coimbatore, Dr. T. Saravanan Thangavelu. Dr. M.R. Guruswamy Mudaliar was the first physician from South India who has formed a national API along with the 10 national physicians in 1944 in Chennai. He was the first Indian to be appointed a professor of therapeutics at the Madras Medical College. It was a highly honorable post, as back as in those days, it was open only to experienced and knowledgeable British doctors. Dr. Guruswamy Mudaliar was widely known to be a past master at percussion diagnosis, very important. The bridge connecting Kilpak and Chetpat in Chennai is named after Guruswamy Mudaliar. A statue of Guruswamy Mudaliar is instated at the campus of Madras Medical College. He was honored by a special cover released by Indian Postal Service. The Association Physician of India, Tamil Nadu State Chapter, with great pleasure and honor, is pleased to honor the prestigious Dr. M.R. Guruswamy Mudaliar Oration for the year 2025 to Dr. Saravanan Thangavelu, MBBS, MD, Internal Medicine, and FICP. Dr. T. Saravanan studied MBBS in 1997, MD in 2002 from Coimbatore Medical College, Tamil Nadu, Dr. MGR Medical University, now working as Professor of Medicine since 2013 and head of the department since 2019 in the prestigious PhD Institute of Medical Sciences and Research, Coimbatore. From August 2008 to June 2011, he was worked as a junior medical consultant in the Department of Endocrinology, Metabolism, Diabetes at Raja Isteri Penagaram Anna Seha Hospital, Brunei, Jerusalem, fantastic city, Mandarsari Bhagavan, you must be knowing. Dr. Saravanan has many institutional roles and responsibilities, and he is the head of Department of Medicine, chairman of Clinical Audit Committee, chairman of Drugs and Therapeutic Committee, member of EMR Drug Formulary Committee, member of Pharmacovigilance Committee, member of Hospital Infection Control Committee, member of Institutional Promotion Committee. Dr. T. Saravanan was a treasurer, Coimbatore City Branch Association Physician of India from 2006 to 2008, treasurer, TAPICON 2006, scientific committee member, APICON 2013 at Coimbatore, scientific committee co-chair, TAPICON 2020, convener secretary, South Zone, South Mid Zone, API, ICP, PG Masterclass Program since 2021, Land Scientific Coordinator of the Coimbatore City Branch of API. He is a life member of API, RSSDI, ICCM, DFSI, IACM, CCDSI, Hypertension Association of India, and Executive Council member of Association Physician of India, Tamil Nadu State Chapter. Conferred Fellow of Indian College of Physicians in 2016. Dr. Saravanan published more than 41 journal publications and 5 papers are awaiting for publication and more than 6 ongoing studies at present. He is the invited speaker at national, state, district level conferences of API and he is the postgraduate university examiner for the past 15 years. He is a research guide for postgraduate, undergraduate medical students and also been go-guide for academic research project done by clinical pharmacist MPharm students. He is the organizing team member of national, state, district level conferences in association with like API, CUPID, and he is an experienced guide for postgraduate students in poster and paper presentation in multiple conferences. Dr. C. Saravanan awarded Best Teacher for the Year Award 2016 of PhD institutions and received Best Motivator Award from PhD IMSR twice. The Association Physician of India Tamil Nadu State Chapter takes immense pleasure and honor to award this prestigious Dr. M.R. Guruswamy Mudaliar Oration to Dr. Saravanan at the 21st Annual Conference of API Tamil Nadu State Chapter, TAPICON 2025 in Vellore. Dr. T. Saravanan Thangavelu, please. I request Dr. Satish is not there. Dr. Venkatraman, please come. Sir, Asaraf sir, Deva sir.
minutes. For 20 minutes. Oration for 30 minutes.
30 minutes.
30 minutes.
Sir, time on kilo பார்த்துங்க சார்.
இது வந்து oration 30 minutes. Shall I? So very good afternoon to all of you. I feel privileged and honored to stand in front of you all to deliver this oration on the well-renowned physician of our part of this India, Dr. Guruswami Mudaliar. I should thank the Tamil Nadu API chapter and the Vellore chapter API for allowing me to do this oration. So moving on from this level, I'm going to talk about the important medical hiccups which we're going to see during your daily practice in the pregnancy patients. As we all know that the common problems we come across during the pregnancy is going to be diabetes and anemia, which I'm not going to talk about. I'm going to talk about the three other problems which are going to come across during the time of pregnancy, especially hypertension, thrombocytopenia, and the thyroid disorders. So this is the outline of my presentation. I'm going to just take you through these important aspects of hypertensive disorders during the pregnancy. What are the changes in the definition of hypertension during the pregnancy, the changes in the terminology, and how do we manage, what are the medications we play in the management of hypertension during the pregnancy. Similar to that, thrombocytopenia as well as thyroid disorders. So the classification of the hypertensive disorders of the pregnancy, previously used to call it as PH, it's no more called as PH. The terminology changed from that to hypertensive disorders of pregnancy is HDP, which encompasses chronic hypertension, or it can be gestational hypertension, or preeclampsia or eclampsia, followed by that can be a coexistence of superimposed preeclampsia in a chronic hypertensive patient. And it is one of the second most common cause of the global maternal mortality behind these maternal hemorrhages. And this is the classification. We always think about a person with a pregnancy less than 20 weeks, always confirm that we are dealing with a pre-existing chronic hypertension, whereas the age of occurrence or the diagnosis of your hypertension beyond this 20 weeks of gestation, you can say we are dealing with gestational hypertension, or it can be a preeclampsia or eclampsia based on the clinical features and the laboratory parameters, or we can be dealing with chronic hypertension superimposed with the preeclampsia. And this is the definition of these different terminologies which you are going to use in the patients with hypertension and pregnancy, or you can say like the chronic spectrum of this spectrum of the disorders which you're going to see with hypertension disorders of the pregnancy. As I was mentioning, the blood pressure to be monitored or measured at least 2 occasions, 4 hours apart, with a calm and quiet mind of the person, physically, both mentally. Then the BP is going to be systolic of more than 140 or diastolic of more than 90. Any one of these enough to say that we are dealing with hypertension in the person with pregnancy. And the person is going to have these values less than 20 weeks of the gestation. We are also going to say it's a chronic hypertension. Whereas going to happen after the age of 20 or the stage of the pregnancy is going to be more than 20 weeks, then you can say it's a gestational hypertension. Suppose this is going to be having additional features of proteinuria, or this person is going to have the problem of blood pressure more than 160 or 110 millimeters of mercury, or is going to have the end organ damage. We can say severe form, that is going to be end organ damage. Its non-severe form is going to be only proteinuria without end organ damage. And can we say that it's a hypertensive crisis with a preeclampsia in case of blood pressure is going to be more than 160 over 110 millimeters of mercury. And eclampsia, as all know, that is going to be associated with seizures. And why do we know about this hypertension during the pregnancy is going to be the problem which you're going to deal with during the time of pregnancy? The answer is no. There are few studies very clearly tells you about the impact of this high blood pressure during the pregnancy, how it's going to have impact in the future of this person, immediate future and the late future. You can see that the persons can have an increased risk of cardiovascular mortality all-cause mortality, including the vascular disorders related to the stroke as well as renal injuries, including the arrhythmias as well. So this is basically problem. You should understand that it's like your gestational diabetes, what you're expecting to be in the future of the person also going to succumb to the problem of vascular injury. Similar problem you're going to face with the hypertension during the pregnancy as well. And this also very clearly tells you that the occurrence of this hypertension disorders of pregnancy, either gestational hypertension or preeclampsia, was associated with increased risk of premature mortality, particularly CVD mortality, even in the absence of chronic hypertension. It's very, very important take-home message. The person is not having any pre-existing hypertension also. A single episode of, first episode of diagnosis of the hypertension disorders of pregnancy, more specifically gestational, or the preeclampsia or eclampsia going to have the future complications in the form of increased mortality or reduced lifespan of the individual. So you can understand how much the vascular injury or altered vascular biology is happening in that individual. And what is the reason for these hypertensive disorders of the pregnancy, the pathogenesis? Basically, multiple factors been playing major role in the development of HDP. That is your maternal factors like hypertension pre-existing, or diabetes, or chronic kidney disease, or obesity. Or it may be a non-modifiable factors like age, race, or family history of hypertension, or it could be multi-fetal gestation, or nulliparity, or artificial reproduction technique related pregnancy, or it can be a genetic or immunological mechanisms or biological mechanisms can be playing in the development of hypertension during the time of pregnancy. And it's basically another part of pathway of this development of hypertension during the pregnancy is going to be the placental pathway, where the RAS cascade is one of the important area of, or the way of looking at as a development of hypertension during the time of pregnancy. And few definitions which to understand is, as I was mentioning about the preeclampsia as a clinical entity during the pregnancy. As per the ACOG, the new onset of hypertension after the age of, or after the stage of 20 weeks of gestation. And even the absence of proteinuria, you can make a clinical diagnosis of preeclampsia. There's a new definition, addition into that definition of preeclampsia as per the ACOG. And alternative criteria, suppose in the absence of proteinuria, the person is going to the following features like thrombocytopenia, renal insufficiency, or impaired liver functions, pulmonary edema, or cerebral or visual symptoms. Any one of these or two of these symptoms are enough to say that you are dealing with preeclampsia even in the absence of proteinuria. So traditionally we have been looking at preeclampsia as a proteinuria, but not necessarily always as per the ACOG recent guidelines. And what is the etiopathogenesis of this preeclampsia? It's a spectrum of disorder where you can have the overlap with the disorders what we come across during the pregnancy like AFLP also, that is fatty liver of pregnancy, also part of this symptom of, or the spectrum of preeclampsia. Basic problem which is leading on to this preeclampsia is going to be endothelial dysfunction, vasospasm, and uteroplacental insufficiency. Basically, we should understand the pathophysiology. Till now, what we have understood is the vascular altered biology along with the uteroplacental insufficiency can be the reason for development of the hypertension in the form of preeclampsia during the pregnancy. The terminologies of eclampsia, as we all aware about, that's going to be associated with preeclampsia procedures, and it's going to be increased incidence of maternal and the fetal health. Whereas the other type of problem or spectrum of problem which you're going to see with this, the hypertensive disorders of pregnancy is going to be HELP syndrome, where it's a subtype of preeclampsia where you're expecting the hemolysis and elevated liver enzymes and the low platelet count. And it's going to be high risk for the maternal and fetal mortality. And if you see carefully, the 0.2 to 0.6% of all pregnancies, whereas higher rate of this problem of happening at the 4 to 12% in case of severe preeclampsia, the problem of maternal and fetal mortality. And what do we do with these investigations as far as the hypertension disorders of the pregnancy? Few investigations compulsory to think about, or at least for the postgraduates to think about. First one is going to be hemoglobin or hematocrit, platelet count, followed by AST, ALT, and the LDH level. Along with the protein assessment of the urination can be a protein creatinine ratio, ACR, or it can be 24 hours protein estimation. Along with uric acid and creatinine, the basic investigations other than your ECG also to make an impression of is it a pre-existing hypertension or preeclampsia per se, or other spectrum of disorders of the HDP. And how do we manage this problem of this preeclampsia or hypertensive disorders? Commonly, only 4 classes of molecules being recommended. One is going to be beta blockers, that is only the labetalol hydrochloride. Calcium blockers, the well-established information is going to be on the nifedipine, especially controlled release preparations of the nifedipine. Alpha blockers, one of the foremost therapy or important therapy for your blood pressure management is outpatient or inpatient with the methyl dopa. And vasodilators, hydrolysin hydrochlorides also can be tried. And these are the few medications which keep in mind. They have postural hypotension, or it can lead on to problem of the asthma or congestive cardiac failure. With these different class of molecules, the side effect profile also should be a bit familiar with. And methyl dopa can produce some sort of the very good safety in pregnancy, but can produce postural drop in the blood pressure also. And thiazide diuretics also recommended, but not with full evidence, but can be recommended if there is a resistant hypertension which you're finding very difficult to control the blood pressure, but the cost of it can compromise on the placental perfusion also. And intravenously is going to be very high hypertension, very high levels of blood pressure, where you need to think about going in for intravenous. You can use labetalol, or can go for the immediate release nifedipine, which is usually not indicated or not advisable, and hydrolysin intravenously, or sodium nitroprusside very rarely, but at the cost of sometimes can produce fetal cyanide syndrome or poisoning. And nitroglycerin also can be tried in the case of very high blood pressure, which is not getting controlled with your conventional oral preparations. Just this the outline about these medications which you can use with alpha blocker or beta blocker or calcium channel blockers or diuretic as well. Intravenously also you can go with labetalol or sodium nitroprusside or nitroglycerin. And especially mention about this eclampsia, special problem of preeclampsia seizures, where the magnesium sulfate is going to play a major role in the management of eclampsia. Very important is it has got a very short half-life of nearly 5 hours. It's very important that always intrapartum or just prepartum level, start with the magnesium sulfate and adequate dosage of loading dose of 4 to 6 grams, followed by a maintenance dose of 1 to 2 grams per hour at least for 24 hours. It should be maintained intrapartum and 24 hours postpartum. The take-home message should be the magnesium sulfate should be continued for intrapartum and postpartum of at least 24 hours to reduce the further appearance of this or occurrence of these seizures. And these are the medications. Postpartum hypertension. Suppose patient is delivered, how do we go about? Definitely needs to have a continuous monitoring of this blood pressure. You can try with additional medications other than the medications list which I mentioned already, like methyl dopa, beta blockers, calcium blockers, and the diuretics. Can also try with AC inhibitors, ARBs. Usually it is not that much encouraged, but if you are standing with not able to bring down the BP, definitely can try this, but the cost of slight amount of transmission of this molecule or transfer of this molecule into the baby through the milk, breast milk. But very important, like captopril, enalapril can be better safely used in those situations. The situation arises to bring down the blood pressure. So summary of this part of this presentation of mine, the hypertension disorders in the pregnancy. It's very important that it is not going to be the high blood pressure at the time of pregnancy. Always keep in mind the future complications because of altered vascular biology related to both modifiable, non-modifiable risk factors of the mother and the placental changes happening through the RAS cascade. We always keep in mind high increased incidence of both maternal and fetal mortality. Always take care of this problem during the pregnancy, postpartum. Closely monitor the patient with the proper medications list which is encouraged to be used along with the lifestyle modifications as well. So moving on from this to, I'm just taking you all to this thrombocytopenia, another problem which you're going to come across during the pregnancy. And it's nearly 5 to 10% of women during the pregnancy has been postpartum found to have the low platelet. 75% of the causes of this problem is going to be gestational thrombocytopenia. 15 to 20, just now completed the topic on the hypertensive disorders contributing for low platelet in those situations as well. And 3 to 4% a common problem which you're going to see is ITP or immune disorders, and 1 to 2% odd conditions like infections, malignancy, as well as drug-induced problem. And always there are multiple reasons for development of low platelet during the pregnancy. It can be pregnancy related or not related to pregnancy. The foremost is going to be commonest is always common things are common. So gestational thrombocytopenia, The other conditions like hypertensive disorders of the pregnancy, including your preeclampsia, eclampsia, HELP syndrome, acute fatty liver of pregnancy is going to be the commonest pregnancy-related low platelet, which is contributing nearly 90 to 95%. 5% or 6% you can have this ITP along with other conditions, whatever the infections, non-infective conditions. So how do we differentiate these during the time of pregnancy, gestational versus non-gestational or immune-mediated? The points for gestational is going to be 70 to 80% commonest reason. And not only that, always try to appear this, they have this low platelet second trimester, mid-second trimester, the ideal time to have this manifestation of the low platelet usually doesn't cross less than 75,000. So one of the important number is concerned of the platelets going to be less than 75, like 50 or 40 or 30 is going to be definitely you're not dealing with gestational thrombocytopenia. There are rare occasions, but it's very common thing is going to be always above the level of 75,000 cubic millimeter. And there is no biomarkers to confirm that you're dealing with the gestational thrombocytopenia to provide a proper diagnosis. And definitely you will not be able to see any bleeding tendencies or bruises, or there is no fetal or neonatal thrombocytopenia. So all these points adding to the problem of what you're dealing is going to be because of gestational, not because of ITP. And usually it resolves within 6 weeks of postpartum, and there's a 14-fold increased risk of recurrence going to be there. And very, very important point, other than the count of less than 75, occurrence at the time of this low platelet mid-second trimester. Suppose if you are going to notice that the platelet count gradually deteriorating as the age of the pregnancy progresses, that means unlikely you are dealing with gestational thrombocytopenia. You are dealing with probably pre-existing ITP. And why do we develop this, or why these people are developing this? Because of the commonest reason, the changes happening in the pregnancy period, like hemodilution, the accelerated clearance is the main mechanism behind this development of gestational thrombocytopenia. And the difference between this is just an outline about the difference between ITP and the gestational thrombocytopenia, the time of onset, and it's basically a platelet count number, along with outside of the pregnancy, usually you don't get, and neonatal thrombocytopenia, bleeding. This is a basic difference, but the point here I would like to highlight is hypoglycemic point, along with the other spectrum of disorders involvement based on the duration of the occurrence and the number of platelet count is going to decide upon and resolving postpartum or not. To summarize this part of my presentation on the thrombocytopenia in pregnancy, it's basically a common occurrence, and the timing of its onset is very, very important to diagnose the problem, and severity of the thrombocytopenia and association with other comorbidity abnormalities. And isolated mild low platelets may require observation alone, nothing else to be done. And probably you have to think about when you are going to see a patient with a severe thrombocytopenia, especially hypertension, liver enzymes, neurological or renal abnormalities, always think about the red flag signs for abnormal severe problem of pregnancy, low platelet related to pregnancy. The third and last part of my presentation on this pregnancy-related disorders, the thyroid disorders during the pregnancy. And we all know that a lot of changes happening in the thyroid gland as far as this, the factors involved in the thyroid gland synthesis or thyroid hormone synthesis. You get increased thyroid binding globulin with the reduction of the albumin level. It is not only that the thyroid gland size also goes up based on the reserve of the iodine value. Excessive iodine clearance and excessive requirement of the iodine also happening. If it's not properly supplied, you might come across a relative iodine deficiency during the time of pregnancy, and that can be an increased amount of thyroid hormone by 40 to 50%. It is not only that you can see the graph tells you about the different stages of the pregnancy or the trimester of the pregnancy, how the graph moves for this thyroid binding globulin and total T4 always on the higher side, along with the HCC goes up and comes down along with the variations of the free T4 and the TSH. And other than these thyroid binding globulin, thyroid hormone or total T4, free T4, and the other factors like that can be activation of the placental deiodinase type 3 enzyme along with increased plasma volume, immunological changes which is normally happening during the physiology of the pregnancy, which can have impact on the thyroid hormone milieu in an individual with pregnancy status. Basically, it is a problem what we are dealing with. Is it an overt hypothyroidism? Is it a thyrotoxicosis, or is it going to be subclinical hypothyroidism? Few studies very clearly tells you about majority of the time, irrespective of the trimester of the pregnancy, you're going to see with subclinical hypothyroidism the major problem what you're going to deal with, then only followed by overt hypothyroidism, then isolated hypothyroxinemia, followed by your hyperthyroidism. So very, very important, this suspicion and investigation or screening is going to be a major way to look at and screen the problem, because you can avoid the future complications related to thyroid hormonal abnormalities. It is also telling you about the subclinical hypothyroidism going to be more common than the overt hypothyroidism. And what is going to produce the abnormal hormonal changes in the individual can produce the maternal complications as well as fetal complications like your preeclampsia, preterm deliveries or abortions, PPH also, whereas the fetal complications can produce low birth weight or hyperbilirubinemia or NICU admissions as well because of respiratory distress. And how do we approach the patient with the thyroid abnormalities during the pregnancy? When you're going to see a patient with the pregnancy, always screen the patient for TSH level. The level is going to be between 2.5 to 10, always subject the patient for thyroid peroxidase antibodies. And the first one is going to be on this. Sorry. Yeah. There's no pointer. It's going to be the TSH value going to be less than 2.5 percentile or 0.1 micro units. Going to see with the thyrotoxicosis problem, whereas the other category is going to be 0.1 to 2.5. No further workup is required. That means the cutoff value to not to proceed with the further investigation is going to be 2.5 is the upper limit. Then TSH value between 2.5 to 10, you can think about going for this thyroid antibodies here, or negative or positive. It's going to thyroid peroxidase antibody going to be positive with these values of different levels of upper limit of your reference range. We can think about treating the patient with levothyroxine. If this is going to be upper limit of 2.5, thyroid antibodies are positive. And it's going to be 10, can very well treat the patient with levothyroxine. Whereas the value is going to be the negative antibodies with the 2.5, no need for treatment. That means level is 2.5, no antibodies, no need for treatment. And negative antibodies, but upper limit of the reference is going to be 10, you get to treat the patient with levothyroxine. And definitely the TS is going to be more than 10, you're going to treat the patient with levothyroxine. Whereas what dosage should we start for this pregnancy patients? It's going to be overt hypothyroidism. You can very well start the dose with the 2.1. The microgram per kg body is going to be per day is going to be the dosage which can start with. Then slowly reassess after 4 weeks and slowly titrate the dosage to reach the target value of TSH of less than 2.5. Whereas the going to be the TSH value of more than 10, but it is not overt, it's subclinical hypothyroidism. You can start the dosage with 1.35 microgram per kg body weight, and every 4 weeks slowly titrate to reach the target value of less than 2.5. Whereas the other spectrum of this problem is going to be hyperthyroidism or thyrotoxicosis, where you're going to go for this assessment of the free T4 and TSH. All know that free T4 is going to be very much elevated, TSH is going to be grossly reduced, and it's going to be with the antibody positive report also to be assessed with the patients. Then can go for the treatment with the P2 is the drug of choice during the first trimester, second trimester as well. Whereas the carbimazole or methimazole can be postponed for post 12 weeks of pregnancy period because of slightly more side effects seen with these two molecules than your PTU. And it's very important to start this dosage and titrate every 2 to 4 weeks. But the important point here is you're also supposed to monitor the thyroid receptor antibodies during these patients, because during the 18 to 22 weeks and the 30 to 34 weeks, basically to understand is there any possibility of neonatal thyrotoxicosis. So the thyroid antibodies also to be monitored periodically from the age of the stage of your pregnancy, like 18 to 22 weeks and 30 to 34 weeks, to decide upon what is anticipated in the baby in the neonatal period. And sometimes if you are going to get negative reports, you can get this vesicular mole can be one of the reasons for falsely mimicking like thyrotoxicosis. You always keep in mind they'll be coming to the hyperemesis gravidorum, and always think about vesicular mole. And sometimes you can get normal gestational transit hypothyroidism, which may not be requiring antithyroid drugs, can go for only symptomatic therapy. To summarize this last part of my presentation on this, the disorders which we come across during the pregnancy is going to be the thyroid disorders, which is very, very common occurrence, most commonly with the subclinical hypothyroidism, followed by overt hypothyroidism, isolated hypothyroxanemia, followed by your hyperthyroidism. And it's going to have a untreated or poorly treated, proper management of this can lead on to the maternal and fetal complications, which I already mentioned. And proper diagnosis management is very important. Clinical suspicion, screening, followed by investigation, understanding the algorithm to follow, to proceed with how to manage, what dosage to manage, to reduce the, what is called as the maternal and fetal complications to reduce. So once again, I thank the Tamil Nadu chapter of API and the Vellore chapter of API for giving me this wonderful opportunity, and I feel honored to deliver this Dr. Gurusamy Mudaliar oration. Thank you for patient listening.
Thank you, Dr. Saravanan Thangavellu. So, I think since it's an oration, I think any queries to be clarified, we'll ask him to address it in person to you. Can we proceed to the next lecture? I do not know. I think the next lecture is already over. Clinical medicine, I had forgotten, but I think it was over in the morning itself. So I think we can proceed to the next topic.
Next, we have an unique situation. Dr. Ashraf's guest lecture by Dr. Prince Srikumar Payas. Dr. Ashraf is chairing the session, and it is his guest lecture that has been spoken. I request Dr. Prince Srikumar Payas from Kanyakumari to come and give his talk on lifestyle modification, measures in cardiometabolic health. Now Dr. Venkatraman will read the citation, followed by, we'll ask Dr. Ashraf itself to put the medal on Dr. Prince Payas. It's very unique because most of the time the oration is not chaired by the person who...
In national medical journals. He participated as a faculty in various national and state conferences. Dr. Prince received award from Health Minister for services during COVID as District COVID Nodal Officer, and Best Doctor Award from District Collector 3 times, and also Best Secretary Award twice for the Association of Physicians of India, Kanyakumari City branch. So Association of Physicians of India, Tamil Nadu State Chapter takes immense pleasure and honor to award the prestigious Dr. M.S. Ashraf guest lecture to Dr. Prince Srikumar at the 21st Annual Conference of API Tamil Nadu State Chapter, TAPICON 2025 CM Civil. I request her to deliver your lecture. Please.
So, good evening to everybody. I humbled and honored to give this lecture in the name of Dr. Ashraf. And I thank the Tamil Nadu API and Vellore API and the scientific committee of this TAPICON for selecting me for this lecture. So my topic is lifestyle modification. This is known to everybody. We all know, but we won't practice. That is the situation now. And my objectives are so these are my objectives. I mainly concentrating on the diet, physical activity, and weight management. So why it is important? Because WHO says 70% of deaths are due to NCDs. In India, it is 65%. 1 in 3 adults are living with the metabolic syndrome in India. So more than 1 billion living with obesity. Of that, 39 million are children,
it is predicted by 2030, another 250 million children are going to be obese. And India has biggest young myocardial infarction. And undiagnosed diabetes is around 39 million, according to WHO. According to INDA study, it is more than 60%. So INDA study also shows that diabetes is prevalence is 11.4 and hypertension 13.5, and abdominal obesity is nearly 40%. So all NCDs are on the rise. So the cardiometabolic diseases like hypertension, diabetes, dyslipidemia, obesity, all are preventable, and it is reversible, and it is controllable by the lifestyle measures only. So it is very much important to us to talk about this lifestyle modification to all the patients. So this metabolic syndrome is due to our sedentary lifestyle. We are having low physical activity, more desk job, and we are not moving much, sitting for a long time, and we are eating more. Now we are shifting from the homemade food to the fast food culture, and it is because of that we are developing metabolic syndrome. According to National Cholesterol Education Program and Adult Treatment Panel, and harmonizing definition is a joint statement of ADA, WHO, and other some organization. These are the 5 criteria they have said: central obesity, hypertriglyceridemia level more than 150, and low HDL level less than 40 for male and less than 50 for female, pressure more than 150/85, and fasting glucose more than 100. 3 of this is present, then we call it as metabolic syndrome. All of you know about this obesity. This is accumulation of excess fat that is sufficient to impair the health. So generalized obesity is measured by BMI. BMI less than, more than 30 is called obese in Western, but in Asian Indian it is 25. The desirable is 18 to 23. So we are most worried about this central or visceral obesity. So this is the most marker of coronary artery disease and metabolic syndrome. So measurement for Indian is 90 centimeter for male and 80 centimeter for female. Weight hip ratio is 0.9 for male and 0.8 for female. So what are the things they will develop due to this cardiometabolic syndrome? So they develop cardiovascular diseases like myocardial infarction and peripheral vascular disease, heart failure, hypertension, type 2 diabetes, cerebrovascular disease, cognitive decline. This metabolic dysfunction associated steatotic liver disease. This is the new term. Now, most of the 1/3 of the world population is having this disease. In India, more than 40% of the patients, 40% of the population is having this disease. And the good thing is 85% of this can be reversible with the lifestyle modification and weight reduction. Of these patients, 15% of the patients are going to develop steatohepatitis, and this 15, another 5% can go for cirrhosis and HCC. So this is an important thing. We have to advise all the patients to adopt lifestyle modification, and chronic kidney diseases and polycystic ovarian syndrome, cancers are also common in this metabolic syndromes patients. So main thing is diet. Diet, no one size fit to all. So diet should be individualized. Diet must be realistic, flexible, and we have to take into the patient's likes and dislikes, and patient's activity level, what medicine he is taking, what is his age. Everything should be keep it in mind before advising a diet. The diet, we have to maintain the body goals, and we have to achieve the glycemic, blood pressure, and lipid goals also. So balanced diet is, all of you know, this contains all the essential micro and macronutrients in right proportions to maintain the health, energy, and prevent diseases like obesity, diabetes, heart disease, and malnutrition. So the carbohydrate is 45 to 65%, protein 15 to 20%, and fat 20 to 30%. So this food pyramid, all of you are aware, the base level is most of the grains and pulses can be taken in sufficient quantities. Second level, vegetables and fruits taken liberally. Third level, plant protein and vegetable protein can be taken as moderately. Top level, it is processed food and oils, it used sparingly. So energy is measured in calories, and we have to calculate how much energy we need from the ideal body weight. Ideal body weight is measured from the height in centimeter minus 100. This 25 into ideal body weight is for normal person, normal sedentary life person. And if you reduce the weight, you have to reduce the calorie intake. So this is how we calculate the daily requirement. If the man having 60 kg weight, we need 25 calories per kg, 1500 calories. Protein 1 gram per kg, so 60 grams. That comes around 240 calories. And fat, 30% of the total calories, that is 450 calories, is equal to 50 grams of fat. And rest is from the carbohydrate. This is how we calculate the daily requirement. So coming to the carbohydrate, we South Indian, we eat more than 70 to 80% of the amount of food is carbohydrate. This is simple carbohydrate, complex and dietary fiber. Simple is sugar found in fruits and honey. It provides quick energy and blood sugar will shoot up. Complex carbohydrate present in the whole grains, legumes and starchy vegetable, green leafy vegetables, and it will break down more slowly, and it is offering sustained energy. This is preferable in all our population. So dietary fiber, which is found in fruits, vegetable and whole grains, this aids digestion and regulates blood sugar, and it will give a feeling of satiety and fullness of stomach. So daily requirement is 45 to 65%, and minimum requirement is 130 grams, which is needed to meet the glucose need of the brain. So ADA recommends for diabetic patient no ideal percentage of calories from carbohydrate. However, low carbohydrate diet is very useful. It is less than 25 grams of the total daily calories, 51 to 130 grams. Very low carbohydrate diet, or otherwise called ketogenic diet or this paleo diet and all, it is less than 50 grams per day, less than 10%. The problem with this diet is we can't follow this diet for a long time. For a short period, it is okay, and it is useful in reducing the HbA1c and weight. But the problem is most of the patient will slip back to their routine diet pattern. They don't follow it for a long time. And long-term effect also is not known to us now. So high glycemic index foods increases the incidence of type 2 diabetes. Normally, high fiber, low glycemic index carbohydrate foods are preferred. So sugar, this is added sugar. American Heart Association recommendation is less than 6% of the energy intake from the sugar. WHO says it should be below 10. Below 5 is having additional health benefits. So man 9 teaspoon amount to 150 calories, and female 6 teaspoon. Sugar sweetened beverages like this Coke and Pepsi and all, these contains 100 ml contains 11.1 grams of just sugar. 2 liters of this Pepsi or Miranda will have 220 grams of just sugar, and it will give 880 calories. So don't take this sugar sweetened beverages regularly. Keep it for special occasion. Occasionally you take, this is just sugar, nothing but sugar. The recommendation is 1 liter per week maximum. Fruits, we all know it is good. Fruit consumption according to the ADA, if the patient is having uncontrolled diabetes, we can allow 1 portion. If the patient is having controlled, we can allow 2 servings. For a normal person, we can allow 4 or 5 portions. 1 portion is 80 to 100 grams, it will come around 15 grams of carbohydrate. We should avoid dry fruits because dry fruits like dates have 75 grams of carbohydrate per 100 grams. So the dry fruits should be avoided in diabetic. In normal person, it can be taken in a small quantities. Moderation is the key. So vegetable, non-starchy vegetable and starchy vegetable. Non-starchy vegetable is low in calories. It is found in all green leafy vegetables, brinjal and cauliflower, cabbage and tomato, all these vegetables. The starchy vegetables are the root vegetables, potato, corn, green peas, plantains, topica. So all this contains more carbohydrate and it should be counted as carbohydrate intake. The non-starchy vegetables are preferred for all and it is also preferred for diabetic patients also. So protein also according to AHA, according to ADA, it is individualized. So there is no evidence to say there is an intake above or below the recommended dose. Recommended dose is typically 0.8 to 1.5 grams per body weight per day. It is 50 to 20% of the total calories. Will improve health in normal. So normal individuals, there is no effect if you increase or decrease the protein intake. Meal plan slightly higher protein is helpful in diabetic patients. Low protein you should give in type 2 diabetes with CKD, eGFR is below 30. So ADA again says this plant protein is better than this animal protein, even though animal protein contains all the essential amino acids and it is more nutritious because of its saturated fat. ADA now says plant protein is better than animal protein. This plant protein is more in legumes, soya, nuts, seeds, pulses, and this mushrooms and all. So limit red meat and processed meat. So red meat is there in beef, pork and lamb. Sausages and bacon also should be limited. So nuts, all of you know this nuts is a rich source of proteins and it is good. But the problem with the nuts is 100 grams of nuts gives you 500 to 600 calories. So you should take just one handful of nuts, which is equivalent to 30 grams to prevent NCDs, and take it as unsalted and unroasted. So fat again, ADA says there is no percentage how much they can take, but the quantity is not matter. The quality of the fat is mattered, whether it is saturated or unsaturated. So I limit the saturated fat to 10%, aim for 7% for patients having high cardiovascular risk. It is found in the red meat, butter, cheese, ghee, and coconut oil, and processed snacks. So trans fat, it is produced by the partial hydrogenation of the unsaturated fat. It increases the LDL and decreases the HDL. And 2% increase will increase 23% increase of the CAD. So if you heat the oil to its boiling point and deep frying, it will turn into trans fat. So if you use olive oil, then you fry it for deep frying, it will turn into trans fat. So it is found in all bakery items and fried foods and fast foods. And reusing also, we are taking the street foods, they are using the oil, it contains more trans fat. So unsaturated fat is good and it lowers the LDL cholesterol and raises the HDL cholesterol. The monounsaturated fats, it's found in olive oil and canola oil, nuts, almonds and cashew nuts, peanuts, etc. Polyunsaturated fat is found in sunflower oil, corn, soybean, and see which oil we use. Use only 5 to 15 ml of oil per day. That will comes around 500 ml per person per month. That is the recommendation. And you can use different oil for different purpose. Don't use only one oil. And don't reuse the oil. don't deep fry the food items with oil. So everybody is talking about this cholesterol. See, now the recommendation is you have to see the food as whole. Not you should not take the egg yolk yellow or something like that. So our recommendation before is 300 milligrams of cholesterol per day is our recommendation. Now AD is taking it out, and what we need is 1,200 to 1,800 milligrams of cholesterol. It is synthesized in our body mainly by the liver. In a normal person, the liver can adjust. If you take more cholesterol, it will produce less cholesterol by itself. But in diabetic and in cardiovascular risk patient, we can reduce the cholesterol intake. So finally, you prefer unsaturated fat, limit saturated fat, avoid trans fat. So salt, it is less than 5 grams per day, and it equals 2,300 milligrams sodium. And most of the salt comes from our processed and restaurant food, not from the salt shaker. And cook food with less salt. Check the food labels always for the salt content. Limit pickles, papads, and chutneys. Train your tongue for less salt. So this is the healthy plate concept. The vegetables, I already told you, the starchy vegetables we have to take, and the fruits, 2 servings can be given. What I ask my patient is, I will ask the patient to take vegetable salad and fruit salad before taking their major meal. So usually they will eat everything, and after that they will eat fruits and all. So I will ask them to take before your major meal. Uncooked vegetable is better than cooked vegetable. So fruit salad and vegetable salad is good. And protein, as ADA says, plant protein is better. And you reduce the saturated fat and increase the unsaturated fat. Whole grains should be quarter of the plate. So regarding the physical activity, this is again individualized. Someone like walking, another like swimming. So whatever physical activity you do, something is better than nothing. So small amount of physical activity also gives you good effects. So physical inactivity is the major economic burden on the nation because of these NCDs. So now sitting is the new smoking. More than 8 hours of sitting without breaks is equal to smoking or obesity. Take a short break from sitting to standing every 30 to 60 minutes. The exercise needs motivation and initiation, and consistency is the key. You see, you have to do regular exercise to get more benefits. So WHO says at least 150 minutes of, say, 3 types of exercise: flexibility exercise, and aerobic exercise, and resistance exercise. 150 minutes per week of aerobic activity, or 75 minutes of vigorous intensity activity is advised by WHO. Resistance training, at least 2 to 3 sessions. Flexibility and stretching will improve the range of motion, reduce the muscle stiffness. If you advise the Parkinsonism patient to do exercise, you can reduce the dose of the sine-dopa. So drugs with this exercise will do wonder in Parkinsonism patients. So WHO recommendation is not 150 minutes is not enough. If you are able to do exercise, you do 300 minutes per week. Even more you can do. If you do more, the benefits are more. But there is a limit also. If you don't overdo it, if you are overdoing it, you feel so tired and you will feel pain. The pain is due to excess accumulation of lactic acid in the muscle. If you feel like that, you stop and you take 2 days rest and then start the exercise. So children and adults, 60 minutes per day, at least 2 days of weeks as muscle strengthening activities. And for older adults, multi-component activities are advised. So any patient or anybody want to reduce their weight or control the diabetes, you can do exercise as more than 300 minutes per week. So high intensity interval training, it is doing a short burst of intense activity and a period of low intensity. So it is like running and walking, running and walking. So this will you will lose more calories because of this afterburn effect. So do it 2 to 3 times a week. So this weight management is the very difficult thing, because you can reduce weight. After some time, you again regain your weight and you put on the weight. So I ask the patient to buy a weighing scale and keep it in the hall itself. When he crosses the hall, he has to weigh his weight. Every day, if he is weighing his weight, then he will control his weight. So the weight management is major thing is our diet. And diet with the regular physical activity, we can maintain our weight. So less than 5% weight loss improves the glycemic control. Pre-diabetes, 7 to 10% weight loss, they can prevent diabetes. 5 to 10% body weight loss, the BP also comes down. So our aim is to attain ideal body weight. This overweight people should aim at least 0.5 kg per week. That will come around 300 to 500 kilocalories per day calorie deficit to attain 10% weight loss in 6 months. Severely obese, 500 to 1000 kilocalories, that will come around 10% weight loss in 6 months. See, you have to lose 7,700 calories to reduce 1 kg weight. So 1 kg fat will burn down into 7,700 calories. At the same time, you have to stabilize the weight. See, a small amount of increase of calorie, just 50 kilocalories, 2% of your daily intake. If you take daily in excess, after 10 years, your weight will increase. Guess how much? 20 to 23 kgs increase will occur. Just 50 kilocalories per day in excess to your needs. If you take, your weight will increase. So that much we have to give importance to the weight stabilization. So calorie deficit can be attained from the food exchange, and you use a smaller plate, and Mediterranean diet and DASH diet, which is rich in vegetable, fruits, and whole grains, and a small amount of fish and eggs will be found useful for this type of weight reduction diet. So avoid overeating, nighttime eating, snacks, and while watching TV and all, eating, that you should reduce. So low calorie diets is the safe and effective. It is sustainable and realistic. The 1,200 to 1,500 calories per day. Very low calories, below 800 calories. It is medically supervised. There is one study done in UK, direct trial. It is to find out whether if you reduce the weight will reverse the diabetes. It is diabetic reversal study. That study they have found out those persons who are reducing 15 kg weight reduction, there is a 86% remission of diabetes. But at the end of 1 year, only 46% attain the diabetic remission. At the end of 2 years, only 36% patients attain remission. So it doesn't mean that everyone will get the weight reduction. If you get the weight reduction, and you will get remission. So only 50% of the patients are getting remission, and not all the patients. So intermittent fasting is another tool to reduce your weight. But the problem is we should make a calorie deficit. Otherwise, it is not useful. And what you eat in the eating window is very much matters. And it is not superior to the continuous energy restriction diet. So people will fast, and they will eat whatever they want during the eating window. So ultimately, there is no calorie deficit. If there is a calorie deficit, then it is very useful. So tobacco use, this is the single most preventable cause of death globally. And in India, overall tobacco use is 28.6%. India is having the highest oral cancer burden. Stop nicotine addiction in youth, promote cessation, prevent initiation. What about alcohol? WHO says no safe amount of alcohol, that if a small amount also affect the health. ADA says if somebody is taking alcohol, use it in moderation. So men, it is 2 standard drinks per day. Woman, 1 standard drink. 1 standard drink is equal to 14 grams of alcohol, which is equal to 350 ml of beer, 5%, and 150 ml of wine, 12%, and 45 ml of spirit, 40%. So alcohol is grouped as a group 1 carcinogen. And please do not start drinking for health benefits. Alcohol should not be promoted as safe or beneficial in any amount, especially for NCD prevention. So binge drinking also is very bad. Once a while, occasionally, social drinking we can allow. Otherwise, the alcohol is not at all safe. So sleep is also a consequences on NCDs, all we know. So 7 to 8 hours to 9 hours. If somebody is sleeping more than that, or if the patient is feeling sleepy in the morning, we have to look and we have to investigate the patient if he is having any problem. If he is having hypothyroidism or his blood sugar level is under control. Something like that, we have to investigate on them. To maintain a good sleep, you should have a sleep schedule. You have to go to the bed the same time every day and avoid the screen time 1 hour before bed, and avoid heavy meals and caffeine 2 hours before bed. Create a cool and dark, quiet sleep environment, no TV in the bedroom, no loud music. Get regular daytime exposure and exercise, and that you will induce sleep. And use relaxation techniques also, deep breathing and meditation you can do. Stress management also very important in lifestyle management. So if some patient is in mental stress, they don't take the tablets properly, they don't adhere to our medication, they don't take self-care, and they don't follow lifestyle changes also. So we have to screen all NCD patients for depression, anxiety, stress, and substance use. So provide a brief counseling and referral. We have to monitor and we have to follow the patient carefully. So environmental factors, air pollution linked to heart disease, stroke, and COPD. Unhealthy urban environments also promote physical inactivity, and obesity can occur. Occupational hazards, exposure to carcinogens, water and sanitation is also leading to NCDs, example cancer. Noise pollution also bad for hypertension and cardiovascular stress. Chemical exposure also induces cancer. So regular monitoring also is very, very, very important, because if you say the patient, your blood sugar is coming down normal, that patient will not come to you for another 6 months or 1 year. And again, he will come with more problems. So tell the patient if your blood sugar is okay, but other problems can occur. Your kidney may failure, so you have to come regular follow-up. Otherwise, there is no point in doing all these things. This ADA, AHA, WHO also emphasize the role of follow-up, self-monitoring, and adherence. Empowered patients are more adherent, more confident, more successful in managing their health. So summary, the cardiometabolic diseases are emerging major global health challenge. Follow a healthy diet, more of vegetables and non-starchy vegetables, low glycemic index food, no processed food, less sugar, and less sugar beverages, and take more saturated fat, and do regular physical activity, flexibility, and aerobic and resistance exercise. Reduce weight and maintain the BMI between 18 to 23. Avoid tobacco, moderate alcohol consumption, have a sufficient sleep, and manage stress effectively. Routine screening and regular follow-up is essential. Practice the lifestyle changes before preaching it. In every our flight, the air hostess used to tell when the air pressure is going down and oxygen saturation is going down, you first pull up the oxygen and you put on your mouth first before helping to others. So first, we doctors, we should follow the lifestyle changes before preaching it. Thank you. I once again thank the organizers for giving me this chance. Thank you. Thank you, one and all.
Thank you, Dr. Pius, for the wonderful oration. As this is an oration, there won't be any questions. Thank you all.
Now I request a chairperson to honor the speakers. Dr. T. Saravanan. And Dr. Prince Pius. I request Dr. Prince to honor the chairpersons also.
I'll request Dr. Prince to honor chairperson, Dr. M.S. Ashraf.
I request Dr. Venkatraman to honor Dr. Deva, both nephrologists.
May I now invite our esteemed chairpersons onto the stage, Dr. S. Seduraman, Dr. Philomena, Dr. Lavanya, to chair for the session on hot topics. A warm welcome to all of you. Now I welcome Dr. Ramya from Vellore, will now deliver a talk on the topic Structural Competence Applying Science to Patient Care. The stage is yours, ma'am.
Good afternoon. I invite Dr. Ramya from Vellore to present the topic Structural Competence Applying Science to Patient Care. Over to you, madam.
So somebody who's got diabetes, hypertension, coronary artery disease, despite all this will go and seek alternative medication forms. So why did this patient give up on medical care and shift to complementary alternative medicines? And I want to know, do you think in this patient it has worsened outcomes? Because he's taken fenugreek, which is Valium, he's taking Senna, and then he went to Paramnir, but he still had a stroke, an MI. So definitely yes, the outcomes have become worse. So what will you advise the next patient? Because a lot of patients ask me, can I take fenugreek? Can I take this Ayurvedic medicine along with this? So what will you advise these people? So, and why do people choose alternative medicine? So this is something called medical pluralism. Medical pluralism is practiced by every single patient who comes to us. We also practice medical pluralism. We will try all the home kashayams first before we take our own antibiotics. So this is also very common in India. So why is this? Because there is traditional medicine, there is complementary alternative medicine, and this biomedicine. All these are approved by the government, and there are standardized practitioners who are practicing this. But patient doesn't understand that systems of medicine are different. So in this patient, yes, it has definitely worsened outcomes. And yes, for my next patient, I'll probably not advise complementary alternative medicines. So why did he choose alternative medicines? So cost and ease of access, because he can go to a Ayurvedic medicine practitioner very fast, and he doesn't understand the allopathic system of medicine. And also you should understand an Ayurvedic doctor is a cardiologist, a nephrologist, a cardiothoracic surgeon, all built in one. And he can give you advice for anything, and he can correct all your problems by just adjusting the pitta and the vadam, which we actually cannot tell the patient. But the patient feels holistically cured. The patient doctor understands me holistically, is giving me a holistic medicine, and I feel better. And also there is family and WhatsApp propaganda. And also the structures involved here are culture, there's financial cost of accessing an allopathic doctor, his own belief system, and also he feels that he's got control over his body. So patient autonomy is a major factor in medical pluralism. He thinks he can pick and choose his medicine, and he believes that each medicine is being made for him. It's individualized. That is what he's been convinced by the doctor. So there are many types of pluralism: complementary use, parallel, sequential. Sequential is the most dangerous. They'll take allopathic medicine, alternative medicine, then allopathic medicine, and they'll believe that the side effect of the alternative medicine is the allopathic medicine's problem, and the cure is due to the alternative medicine. So it's a very difficult thing to get the patient out of. So solution is cultural sensitivity, language access. Sometimes we explain to them in English, which is very difficult for the patient to understand. So next one, which I'm going to talk about, is structural competence, is healthcare violence. So it's not rare. So there's a lot of social problem is what we communicate with the patients is very difficult. And there's increasing cost of healthcare which leads to violence. And there's also lack of resources and an inconsistent referral system. So solution is social, avoid misinformation. Again, my advice to doctors is please communicate with the patients, put out pamphlets, talk through media to the patients, and also increase human access. So my summary is recognizing structure is an important part of successful medical practice. Structural competency will reduce violence and improve patient healthcare outcomes. So I just want to put this last picture to show there is no beauty here. This is actually to say that this is a cause of back pain and headache, and if we recognize this, we become a very structurally competent doctor. And again, I thank the Vellore API for giving me this opportunity to speak, and I'll thank the chairpersons, and I'll thank all the audience for your patient listening. Thank you so much. Thank you, ma'am, for such a clear, understandable lecture for this structural and structural competence, and also about the doctor's relationship with the patient, and also about the medical pluralism in a clear, understandable way. Thank you so much. Next, we'll move on to the next lecture.
nutrition or lifestyle that has made my work easy because I won't cover that. There are a few things that has been covered by Dr. Ramya on the holistic aspect of it, and some of it has been covered as AI. So what is lifestyle medicine? Sounds familiar. What is new about it in healthcare? Something that we'll try to go through. So if you look at the NCD epidemiology, we all know, but look at some of the contrast. We know the 4 common risk factors for NCD. Look at the numbers, 17 million deaths per year because of cardiovascular disease every year. In 3 years of COVID, we touched roughly about 7 million deaths over 3 years' time. 17 million deaths every year, 7 million deaths over 3 years. We had a complete lockdown for COVID. Anything happened to any of these places? It was all open, inviting everyone. And we have gone this far. This is from Saudi, that they brought in this restaurant called Heart Attack, and people are enjoying it. The transition that we see, something has become slimmer, something has put on weight. The pyramid of our healthcare, where tertiary is still on the top, large volumes, large investments in the cost, it's time to flip it. The question is, how do we do it? This is a 1948, we all are so familiar with this definition of health, which is trying to bring in those holistic concepts, physical, mental, social, but really speaking, what does it mean to us today? How do we practice it? We have been talking about it in different ways. How do I translate it? If I have about 5 to 10 to 15 minutes per patient, what do I do about it? We are revisiting something that would have been ancient. How do we transit from medical to health? All the medical colleges are called medical sciences. I worked in a place called BP Kerala Institute of Health Sciences. This is in Nepal. First time I saw a name Health Sciences. In CMC we have certain names called pediatrics, we call it as child health. We have got psychiatry, it's called mental health. Just the term health gives you a picture which is much larger than just the medical part. If a patient comes to me with diabetes with high sugars, I make an adjustment in the medicine and send him home. May not do anything much more than that. Maybe a little diet, a little exercise, but do I really understand what this patient is going through? Ramya was sharing about some of these case scenarios that we see in and out every day. From organ to a whole person. From whole person we became organ, and from organ we have specialized and super specialized and super specialized. From symptom to root cause, from disease to well-being. I just use one example. We have a patient coming with malaria. What does the patient come with? Fever. How should we treat it? We all know anti-malarials, but I'm just asking you a question. If I give this patient paracetamol, what happens? The fever comes down. Pharmacologically, we know the fever will come back in 4 hours. So my prescription to this patient is paracetamol 4 hourly for lifetime. What do you think of my prescription? Sounds good? Doesn't sound good. But isn't that we are doing for all our patients? Diabetes, hypertension, Parkinson's, arthritis, you name it. Except infections, you name it. Which medicines do we give it for a period of time and stop it? None. But we are treating all of them. The question is, where is the problem? In malaria, we understand. You hit the malaria, the fever is gone, you don't have to treat fever, you just have to treat malaria. But what about the others? Do we really know? The first line of Harrison will start. SLE is an autoimmune disease of unknown etiology. Sarcoidosis is a chronic rhamnomatous disease of unknown etiology, and you can name it. Everything is, we know some pathogenesis, but the etiology seems to be unknown. So, where do you think the disease pathogenesis really lies? American College of Lifestyle Medicine came up with a concept. What is lifestyle? We lifestyle medicine, of course, American College of Lifestyle Medicine is very biased. People who are very passionate about lifestyle is there. Look at the American Heart Association 2010. They said, no, I think it's too much. The patient's coming with a heart attack, you put in a stent, he comes with a another MI, you put in another stent inside the previous stent. When you cannot put any further, you send it to the cardiothoracic surgeon. But is there a way out of it? We came up with simple 7, added this 8th one called sleep in 2022. Really speaking, this is a concept which has been age-old. Talking about equilibrium, we as scientific people will look at it very skeptically, but is there any wisdom in that? WHO did mention about health in 1948. Where have we reached through all those? We thank our surgery brethren who have taught us how to treat diabetes. We have been treating diabetes age-old, giving them medicines, but suddenly the surgeons came and said, we have a cure for diabetes. And the bariatric surgery was talking about how diabetes was remitted. If you really look at the study, it's very impressive. 1995, 83% diabetes remissions. As the Swedish obese subjects, you look at it, 72 to 37%. Stampede, 75 to 62 to 51. Again, over 2 to 6 to 12 years. Medical treatment, not very impressive. Look ahead, direct. Retune, maybe small number of patients, about 70%, but really speaking, we are nowhere close to that. Reluctantly, maybe American Diabetes Association has accepted the term that yes, you can actually stop medicines, and the term diabetes remission was accepted at this point of time. Long back in 1919, Dr. Dean Ornish, a cardiologist in San Francisco, he, as a cardiologist, was doing his regular practice, but he was also asking a question, is there no other way than to just give them medicines and stent them or send them for surgery? So he put in a small group of patients into a RCT, which was published first in Lancet in 90, and in 1998 in JAMA. So the initial response shows that he had 48 patients, and what he found that over a period of time, this is landmark in one sense, that atherosclerosis we always believed was a non-reversible phenomenon. But he showed that if you do an intensive lifestyle, the disease can reverse. You can see the arteries which was blocked without no stents over here, no surgeries over there. You can see it opening up. This was the first time he actually demonstrated that disease is reversible. If you look at DCCT trial and UKPDS trial, you can see people of diabetes who had proteinuria. The proteinuria did come down with intensive sugar control. So there are diseases which is at a reversible phase, and that gives the clinicians an opportunity to, if you did an intense interventions, you can reverse the disease rather remit it. If you look at this, is a whole list of studies that has looked into this is basically number of studies which are long-term cohort studies where they have looked into does lifestyle have a role in longevities, and you can see all these studies put together. Framingham was the first study we all know. They have gone into 3 generations of people. They were the first to identify the risk factors for heart disease, which were put together. 1970 was the Adventist Health Study, which looked into what are the features that connected to disease and longevity, and the lifestyle factors that we just heard about from diet, exercise, stress was collated together. Harvard Medical School went ahead. They had NHS 1, 2, and 3. This was the nurses' health studies. These are large studies, cohort studies, which are so very difficult to do, and they were asking the questions, and they were finding out all the risk factors. Today, the risk factors that we know of is the result of all these long cohort studies that have shown that saturated fat, trans fat acids are the risk factors. Increasing fibers and nuts are protective. Obesity, sedentary lifestyle are harmful. And all these things put together, and then we have a lot of studies that is coming on environment and longevity, from air pollutions to water pollutions to noise pollutions to food social part. Imagine 1948 I said was the WHO. 1938, almost a decade earlier, the Harvard did a long study by Dr. Robert Waldinger, which they followed up for almost 40 to 50 years. What really they looked was, they looked into two cohorts. These are the grand study and the group study, and they asked them a question. Very interesting. They asked them one question: how is your relationship with your mother? And there were two responses. Some had a good relationship, the other had not so good relationship. Followed them for almost 40, 50 years and tried to look at how were they doing. Those who did not have a good relationship with mothers, many had died, others had kind of a broken up social life and living in a lot of health in disease state as compared to those who had good. Just one factor that they looked into. And when we look into all the factors of longevity, you know what? What is one thing that stands out consistently? We may think of diet, exercise, stress, none of these. Only one thing that stands is social connectedness. Social connectedness, something that is so very important. We just had a crash and a lot of stories of what each families and the disease went through. That one social connectedness is something that really contributes to your longevity, and that is what different results say. In this study it says, strong relationships are the key to happiness. Money and fame don't guarantee happiness. Physical health and emotional well-being are linked. Lifelong learning and purpose matters. Social fitness is as important as physical fitness. Many times we don't know how to interact with the social environment. We go on different extremes, but this is one of the key things that we need to understand. So social relationship, social support, and social engagement. Today we are meeting as TAPICON. I'm sure we are meeting many people from different walks of life and connecting with each other. Very important. Never give it up. Loneliness is more dangerous than obesity and as damaging to health as smoking 15 cigarettes a day. Don't underestimate social connectedness. Money and fame is not equal to happiness. And one of the Nobel laureate, Dr. Elizabeth Blackburn, who did studies on stress and telomere, showed that with increasing stress, your life is shortened. Ozone showed us how important it was to have a meaning and purpose in life. Now these are areas that doesn't fit very classically in our scientific paradigm, the way we look at it. We're just looking at drugs and new drugs and how to get it over there. But we underestimate that these are scientific studies which have shown the reason why people live long and the reason why people live happy is because of a connectedness which has been there. There are different blue zone communities which Dan Buettner spoke about. So health is really an equilibrium between different domains of our life. Disease is a disturbance or disequilibrium in this, and healing is to find a balance. But let me tell you, it is complex. There are a lot of factors that has to be taken, and time is our biggest confounders, a restriction, and transcendence somewhere plays a role. And making a change in behavior is never easy. It's complex, long journeys. Just education at best can achieve this much. The relapse rate is almost 50 to 80%. So if you're banking on education, it will not work. We have to do something more than that. These are different ways that people have tried to find out. What are we doing? We have a course that we run, postgraduate diploma. We have 2 books you can find in our stalls. And this is just to remind you our MAC conference that is going to come. So just want to wish you all a healthy and happy life, hopefully. And all that I want to say, it is scientific. It's not just an emotional word that we are saying about. A lot of science have gone into to bring back the old grandmother or grandfather's talk. What is important for us is now being scientifically validated. Thank you so much.
Thank you very much, sir. Very powerful message is being conveyed to all of us. spread, though the audience is very few, the message should go to all the medical professionals that the social connectivity is the most important factor in having a good longevity of life. Under your experienced observation, you have combined a lot of materials to stress the other side of the coin, not only the medicine, what we give the medicines and the advice. So the personal life and the social longevity and the humanitarian attitude are the most important factor that gives life to the life. Thank you, sir.
Next, I invite Dr. B.K. Singh from Bihar to talk. Next, we have Dr. J.K. Panda, who will be speaking on the topic Obesity, the New Epidemic. Over to you, Doctor.
Respected chairpersons and my dear physicians present in the auditorium, in this beautiful ambience of CMC and the TAPICON situation. I am honored being here, and I thank our team who have done this 21st annual conference with a beautiful ambience and good shines is delivered. Especially I thank Dr. Palaniappan, my good friend, who has called people from all over the country, and we are here in this heritage place sharing some knowledge with you all. Obesity is the new epidemic, is the topic that I'll be touching upon in the next 14 minutes. And all of us know that the obesity has been accepted as a disease by now. For a long time there was struggle to grade obesity as a disease, because it's not only a disease, it's mother of all the metabolic diseases. So if you see the global prevalence, it's 988 million people live with obesity, and surprisingly the women are outnumber the men all over the world, and predicted to be 1 billion people with obesity by 2030. The rates worldwide are increasing. You will see the graph between 10 and 30, both in male and female. And in India, it's a 300% rise in the number, where the financial cost is enormous and metabolic diseases are many. And you will see the associated conditions. Grade 1, grade 2, grade 3, that's weak, moderate and strong association. And very strong association, it goes to 229 plus complications affecting every organ system and medical specialty. So very quickly I'll take you through the facts that many paths can lead to obesity. You can see this definition. It's abnormal or excessive fat accumulation that may impair health, and a BMI of less than 18.5 is taken as underweight. 18.5 to 25 is normal, 25 to 30, 35 and 40 is obesity. But in Asian, we are bringing it to a lower category, this 18 to 23, because Asian Indians are more at risk of metabolic problems. It's a common criteria of a disease, and we see the body-wise, the mind-wise and the heart-wise, it is meeting the criteria of a disease and classified as a disease and a health issue by all world authorities. inches or 12 centimeters, 102 centimeter. In women less than 35 or 88 centimeter is crucial, and when it's more than 102 in male and more than 88 centimeter in female, it's high and it's a better indicator than the BMI that we use. The ethnic differences and the visceral adipose tissue and the waist circumference is very well correlated. And here you can see the biological causes, the genetic causes, the psychological causes, environmental, medications and social all contribute to this disease called obesity. And the signals from the gastrointestinal tract regulate the energy intake, and if you go through the whole mechanism, starting from duodenum, jejunum and ileum, the stomach, pancreas and colon, the environmental factors predisposing to obesity like the socio-cultural and socio-economic, where the prevalence of the fast food, sleep time, reduction in the stress, the racial and the ethnic variations, the extended screen time, more inactive lifestyles. Recently, you heard her speaking on that. The overall eating habits and the preferences, they cause the obesity. Genetic mapping is very complex. More than 100 genes and genetic loci are associated with obesity, and susceptibility loci identified by genetic mapping. It's a very good time. You can see your own genome sequencing and see your possibility of getting obese. The second I'll touch upon is the adaptive biological response leading to persistence of obesity as a chronic disease. That tells you go to gym, you run, you change your diet, lose some weight, and why you regain. That is the adaptive biological response. You have that genetic makeup, you have that interest to eat, you have those factors in the lifestyle, socio-cultural, to gain. The successful lifestyle interventions in chronic weight management, they fail. Following lifestyle intervention is not so sustainable in the long time and very soon we gain weight. That's why the conclusion came, in spite of the lifestyle, the pharmacotherapy is lifelong in a obese patient which has been accepted widely. The adaptive biological response lead to persistence of obesity, the decreasing the satiety hormones and increasing the hunger hormones and decreasing the energy expenditure leading to weight gain is again adaptations that resist the weight loss and the weight gain takes place. The energy balance is regulated by the brain through various sources of input. You can see here the adipose tissue, pancreas, gut, genetics and medications are responsible, and the environment and the hedonic input like increased palatability or the pleasure, they affect the weight gain in a person. And the hunger increases in response to the weight loss, and again the gaining back of the weight takes place. The persistent metabolic adaptation following weight loss is good. That's what we tell a metabolic memory. Suppose you have lost weight at the initial part of your disease, maybe diabetes, hypertension or dyslipidemia, a coronary artery disease or a problem related to the obesity, you get result even after. The long-term pharmacotherapy should be an integral part of the standard of care for obesity management is the third point I want to speak you. The role of brain in regulating appetite, you know very well, the eating for pleasure or the eating for hunger, the homeostatic eating and the hedonic eating are different, and deciding to eat is an executive function, and appetite is normally regulated by a complex interplay of different signals and areas in the brain. And the role of brain in controlling appetite, the many hormones that come into play, the GLP-1, the amylin, the leptin, the insulin, the ghrelin, increasing the hunger, they come into play. The hunger, the pleasure, and the deciding to eat are the balance which works differently in the different people, and the behavioral intervention empower the sustainable behavior in controlling the eating. So the approach approach to obesity management is not only behavioral, not only lifestyle, not only pharmacotherapy. It's about the combination of lifestyle, behavioral, pharmacotherapy, and finally the endoscopic and the surgical interventions. And if we go in a total approach, we'll be successful. The stamped approach to the obesity management include the different BMI levels. When it's a very high, we prefer surgery. When it's in between, we combine the behavioral therapy as well as the drug therapy. And when it's initial, we ask to go with the lifestyle as usual. The treatment strategies, the behavioral, the pharmacotherapy, and the bariatric surgery, you know, the different surgeries practiced, you know, the lifestyle, you know, the drugs like the liraglutide, the phentermine, topiramate, the naltrexone, bupropion, the semaglutide, and now recently launched the tirzepatide and the semaglutide in the weight reduction dose helps us to convince patient to be in therapy. So the American Association for Clinical Endocrinology tells about the stages, and the direct treatment are these patients, and the bariatric options for the weight management, which is the option which exists, and the surgeons and physicians have to plan together for the management in the morbid obesity patients. The weight loss medications are rarely prescribed, and we have a habit of not utilizing them, and you can see here recommended to incorporate the pharmacotherapy as a standard of care for obesity management. There are most of the patients on placebo, and if you are using the drug, there is up to 15.2% patients that have loss of weight. So long-term pharmacotherapy is an integral part of the obesity management, and this is a very important part where I'll tell the people with obesity can achieve sustained weight loss, health benefits, and improve quality of life with proper obesity care. The life expectancy decreases as BMI increases. Obesity is associated with multiple complications. I have already shown with the weak, moderate, strong, and very strong. You can see 229 complications, and very strong are maximum, and associated with metabolic, the hepatic, the cancers, the gastric, the physical functioning, the sleep apnea, the cardiovascular, back pain, the diabetes, the thrombosis, and gout, and whatnot. You see, all the systems are finally affected, including brain, the depression, and the anxiety. And the complications and the weight loss benefits are tremendous. If your body mass index is more than 30, this is the risk factor of the complications like stroke, congestive heart failure, ischemic heart disease, hypertension, diabetes, macula infarction, etc. And the health risk also depend on the lipotoxicity, and the accumulation of visceral adipose tissue is associated with the accumulation of other organs leading to metabolic dysfunction and the lipotoxicity. So the people with obesity, they have all possible metabolic, malignant, and functional problems, including the mental health, and their control can decrease the load very much. The degree of BMI reduction has a different direct effect on the healthcare cost, the benefits of early intervention, effective chronic weight management, and achieve significant weight loss, health benefit, and the improved quality of life. So this shows decreasing in the incidence, the progressive weight loss and its benefits, and the details of the slides are not going in interest of the time, and the effects of obesity on a specific populations are tremendous. With this, I'll come to the last part of the presentation where I'll show you the effect of obesity in the CVD as well. I have already told the benefit. Osteoarthritis, how it gets cleared, the weight loss first recommendation, and the MASLD, with loss of weight, the MASLD reverts automatically, and the most healthcare practitioners in the clinical setting manage obesity as any other chronic disease, and the measuring abdominal obesity can be done by waist circumference, waist hip ratio, waist to height ratio, DEXA, CT, and the MRI. And this is the Edmonton obesity staging system considering medical, mental, and the functional score. And the obesity remains underdiagnosed, leaving obesity if 100%, diagnosed at 40%, receiving treatment at 20%, and prescribed at just 1.3%. So this is the onus is on us. We don't prescribe anti-obesity drugs. We don't educate our patients to lose weight. We treat diabetes, treat hypertension, treat dyslipidemia, and leave the patient. So to summarize, many paths can lead to obesity, and it's caused by a complex interplay of several factors, genetic and environmental, not simply due to the individual's choice or lack of willpower. The adaptive biological response leads to persistent obesity as a chronic disease, and whatever weight you lose, again regains. The long-term pharmacotherapy should be an integral part of the standard of care, and with other chronic diseases, the pharmacotherapy need to be addressed. And the golden example is diabetes. We give drugs decreasing the blood glucose and weight as well. And people with obesity can achieve sustained weight loss and thereby decreasing the risk factors. And most healthcare practitioners, most clinical settings can manage obesity as any other chronic disease. We manage diabetes, we manage hypertension, we manage hypothyroid, we manage migraine, we manage osteoarthritis, but we never tell our patients about the weight gain. So, ladies and gentlemen, to conclude, let us observe, quantify, advise, increase awareness about weight control, and help our patients decreasing weight. That will not only help decreasing the load, help in long run preventing complications. And remember, only diet, exercise, or lifestyle will not ensure to combine the behavioral therapy, combine the pharmacotherapy, even if surgery if it is required. Thank you again for the opportunity, Dr. Palniappan and the whole team of TAPICON, and I'll be happy to take up questions if any.
Thank you, sir, for your excellent talk on obesity. Even though obesity is a very big topic, you have covered everything, and thank you, sir.
Thank you.
The floor is now open for discussion. Please feel free to raise any questions now. If there are no questions, may I now invite the speakers, Dr. Ramya and Dr. Samuel George Hansen. Also Dr. A.K. Panda. I request Dr. Bhavani to give memento to Dr. Ramya. I request Dr. Chittambaram, sir, to honor Dr. Samuel George, sir, for this wonderful presentation. I request Dr. S. Sevaraman, sir. Yes, yes, sir. I request Samuel sir to honor the chairperson, Seduraman sir. I request Dr. Ramya ma'am to honor Philomena ma'am. I request Dr. Palliyappan sir to honor Dr. Lavanya ma'am. With that, we conclude this session. We warmly invite you to stay with us. We transition into the next session of the program. We now move on to our case study presentation followed by an expert panel discussion. To begin this dynamic exchange of knowledge, may I now invite our moderator of the session, Dr. K. Satish Kumar from Vellore, to the stage to guide the panel.
I thank all of you for remaining here for this session. Now, as a part of the panel, I invite the following doctors. Dr. Dhananjay, Dr. Nandakumar, Dr. Venkatesh from Theni, Dr. Marimuthu from Chennai, Dr. Nandini from Vellore, cardiologist, and our core committee member, Dr. Venkatraman, nephrologist, who you already know. I request Dr. Palliyappan, the state scientific chairperson, also to come and help us out. This is going to be a panel discussion where we are going to explore different scenarios of patients that we see in our day-to-day practice. It's not going to be structured, it's not going to be formal of the way we are going to go. If a patient comes like this, how are you going to handle? And we are going to have different experts in our panels. So we are going to see different viewpoints, but all of them evidence-based. So you can see which one will suit which patient from a different expert's view. That's the theme behind this. Everyone had a CV put in front before the talk. We are not going to have that. I'm just going to introduce each of us with a few words. I'm Dr. Satish. I've been practicing medicine for the last 25 years, and that is going to be my introduction. Please, all of you please sit down and introduce yourself. Dr. Venkatraman.
I'm Dr. Venkatraman, MBBS from Stanley, MD from Trinidad Medical College, and DM from Haram and New Delhi. I'm a practicing nephrologist in Vellore more than 13 years. I'm Dr. Palliyappan, currently National ICP Vice Dean, immediate post National APA Vice President, and academic committee chairman of Tamil Nadu State Chapter, running a 100-bedded hospital. I'm a complete physician doing echo, ultrasonography, endoscopy, and all cardiology workup, everything in a rural area. Good evening, I'm Dr. Nandini, consultant cardiologist from Memorial Hospital, Vellore. I
sepsis, non-communicable disease, adult vaccination, and diabetes. Thank you. I am Dr. Nandakumar from Europe. I am a consultant physician from Srihari Medical Center and visiting consultant from KMCH. Field of interest, obesity, diabetes and hypertension and dyslipidemia. Good evening. I am Dr. Venkatesh, Associate Professor of Medicine, Government Training Medical College, with my AGM, PGM, Madurai Medical College. Thank you. Thank you, sir. So we have all the eminent physicians from different parts of Tamil Nadu who are seeing different strata of people. So we'll start with the patients are all hypothetical. So these are not real patients, but these are the patients that will be seen in our day-to-day practice, and how are we going to manage them? So the first patient is a 35-year-old gentleman who has come with a fasting blood sugar of 120 milligram and an HbA1c of 6%. So by definition, he is a pre-diabetic. So now I would like the panel to discuss on, by history-wise, what are the things we can see. It's open, so all of us can answer that. History-wise, what do you see? Physical examination, what do we see in a pre-diabetic? And how do we go about managing a pre-diabetic? Yeah, here. What's the age? 35. 33 years old gentleman, pre-diabetes and hypertension also? No. He has just come with a fasting sugar of 120 and A1C is 6%. Yeah. So here, fasting is 120, so you have to evaluate for the OGDT, whether the patient is in pre-diabetes and pre-diabetes. Nowadays, pre-diabetes is also one of the important word, because fasting blood glucose in Indian scenario, it should be less than 90. 90 to 100, stage 1, 100 to 110, stage 2, 110 to 125 is a stage 2, 126 and above, diabetes. So this stage itself, we have to screen the patient for the presence of the subclinical atherosclerosis, because 1/3 of the pre-diabetic patient, they are already having subclinical atherosclerosis in the form of positive TMT, 20% or 30% block in the coronaries, like that. And these people are also more prone to develop even that's CKD, early phase of CKD, and obesity, whether the patient is having obesity. This stage itself, nowadays in India, that is stage 1, stage 2, stage 3 obesity. Previous speaker Jacob Panda rightly pointed out, obesity you have to look into in the terms of ABCD complication, that is adiposity based chronic complications. You have to look into that. And if it is that, if the patient is having that is a BMI 23 to 24 itself, you have to address properly. Then 25 to 27 stage 2, more than 27. So all these aspects, that is obesity, hold, hypertension, obesity, and dyslipidemia, diabetes, pre-diabetes, everything should be completely worked up and look into in the terms of there is a presence of ACVD. If it is present in the pre-diabetes itself, you have to treat properly. Then only futuristically you can prevent the macro complication. So in a physical examination in a pre-diabetic, what are the things we are looking for, like insulin resistance markers, obesity. Sir was talking about obesity. What other markers can we see, look for and see whether this patient is going to develop diabetes in the future? Other markers like hypercholesteremia, the earlobe crease, xanthosis, xanthelasma, and apart from this, from the history, I would like to elicit whether there was history of CAD or CKD in the parents, and so they are prone for if they are pre-diabetic at this age. So from the markers, apart from obesity, if the person is obese, we look for obesity markers. If he is not an obese person, look for other markers which may be subtle, like xanthoma, xanthelasma, earlobe crease, and markers of obesity, like non-obese persons can have a history of or indicators of NAFLD or MASH, which can be early seen. Again, we talked about history of frequent infections, recurrent infections, history of poor sleep pattern, altered sleep pattern, that weight changes, obesity, weight loss, family history, etc. should ask. So actually, picking up a patient in pre-diabetes is fortunate for a doctor and a patient. And he has come with what symptoms? He has no symptoms. He has just come with the values. So we have picked up the basically first with lifestyle intervention, and to make him, there is a concept called remission. If we pick up in the earlier stage and proper lifestyle modification, both as it was discussed previously also, this may be a repetition, diet and exercise, and it ranges from everything, smoking cessation and his cardiometabolic. Any exercise, not only the aerobic exercise, some strengthening exercise at least 3 times a week, and then the diet, it should be properly balanced diet, and then there are few papers listing out based on the types and the age group it comes, the drugs which may prevent or which may reverse, and there are few papers with metformin, and if it is in the younger age, if we are suspecting type 1, there is a drug biological which we can use. And in clinical examination, it is again already was discussed about the insulin resistance signs, and it's anthropometry and the waist measurement, which we concentrate on central obesity, and it is the forerunner of cardiovascular complications. And of late, there are many interventions are there, but as of now, it is in the pre-diabetic stage. This thing should be concentrated.
Yes, as I said, that is the not only obesity, central obesity, visceral fat, adipose tissues, all those things we should concentrate, and we need to reduce the fat mass, and that should be the ideal in a pre-diabetic stage. It can be reversed if we diagnose pre-diabetes.
So as sir has told, it is an ideal opportunity for the patient as well as the doctor, so we can completely make the patient to remission in diabetes. So it's a window of opportunity, or either we can postpone the diabetes in this patient. So the examination wise, waist circumference very important, and also dental examination for periodontal diseases, and we have to look for skin tags for diabetic resistance, acanthosis nigricans. All these are very important at this scenario. So though we know that this is a pre-diabetes, our body doesn't know that is a pre-diabetes. So our body will be having diabetes, so complications. So we are only grading that as pre-diabetes. So we have to screen every patient as in a pre-diabetes as a diabetes.
So pre-diabetes, just a minute, sir, please. So we know that diabetes is a continuum. It's not a cutoff. Because he's having one number, he doesn't become a diabetic, he doesn't become a non-diabetic. It is a continuum. A person who is having a value of 70 is going to be better than a person who is having a value of 100 fasting or 120. So the idea is to go down. So as the panel was discussing, what we look for in a patient who has come with a pre-diabetic, many times people come with their values to us. I have come with a sugar value of 120, what do I do? So physically examine. When we physically examine him, we look for signs of insulin resistance, acanthosis nigricans, skin tags, xanthelasma, all those things. By examination, we can see if there's a fat liver that is enlarged, that can show a fatty liver. In a lady, if there is acne and hirsutism, we can think of PCOD. So by definition, a fasting blood sugar of 100 to 125 and a A1C of 5.7 to 6.4 will be a diabetic, will be a pre-diabetic. As the panel discussed, this is an important point for us to intervene, because we can push them into remission and we can make them a non-diabetic, and they, without advice, they're going to become a diabetic. So where is metformin indicated? We are talking about lifestyle changes, very, very important. Dr. Samuel was talking on lifestyle changes, lifestyle medicine to make us healthy. So that is very important. But when do we intervene? By adding drugs. Sir was saying metformin, 10% metformin, over the person we can wait. And other people were talking about waist-hip ratio. We are talking about, because we have, Southeast Asians have obesity in their abdomen. They have a lot of visceral fat which is causing the insulin resistance while they are looking thin outside. So this is a thin obese concept. So we have to also think of the drugs they are taking. Now the patients can be taking corticosteroids for some other things like asthma, that can push them into it. HIV, heart medicines can push them into that. Other things like antiretrovirals, oral contraceptives, even common drugs like phenytoin can cause diabetes. So from here, when do we advise metformin or other drugs? Do we have a cutoff, or can we say when can we suggest medications? A person who is 70 years old, sugar is 110, do we start metformin, or younger person, 35, 40, obese, lady, has acne, has polycystic ovary, scope for remission in this patient. If it is so, we can start metformin. But in a female patient, as sir told, when we are thinking about PCOD also, metformin may be a good choice for both this thing. And why it is important is pre-diabetes is as dangerous as overt diabetes with respect to cardiometabolic health. So it is very important, and metformin can be given in these scenarios. Here actually pre-diabetes, if it is the unmarried girl, need not worry at all, only lifestyle therapy. If she married, want to have a child, immediately metformin is the drug of choice. And completed family, pre-diabetes, if the patient is having associated evidence of subclinical atherosclerosis, I will not start on metformin after lifestyle therapy. A class 1A indication is SGLT2 inhibitor and lifestyle therapy. And if it is not there, no evidence of subclinical atherosclerosis in the form of many things, ABI, there is a carotid edema, medial thickening, and all those things, if it is there, and 256 slice, multi-slice CT angio, and there is ED, erectile dysfunction, all those things, definitely I will go for SGLT2 inhibitor rather than metformin. Elderly individual also, if there is a subclinical atherosclerosis, first choice will be SGLT, next choice only will be the metformin. And tolerable dose, slowly uptitrate, and depends upon the OGDD level. Nowadays, half an hour PPG, it should be kept less than 165, 1 hour PPG should be less than 155, 2 hours should be less than 140, and fasting should be less than 90. This is the criteria in India. In diabetes, we can use drugs along with lifestyle modifications. It is reversible, like GLP-1 inhibitors, alpha-glucosidase inhibitors. This can be used since it is having an extra pancreatic effect. It can be used and we can reverse, and once reversed, we can stop it. So the strong family history also we can go for metformin. If there is a strong family history of obesity, we can go for metformin. But we have to start metformin with a caution. That should be started in the night time, preferably. Then we will slowly update it. The thing is, the patient should be obese, and a trial of lifestyle modification is given, and evidence of insulin resistance is there. Right. We can start. Yes, exactly. So we cannot start any patient on metformin because then they will think this is the medicine. Sugars are going to definitely come down, and that will demotivate him from exercise. Any patients with an proven atherosclerotic cardiovascular disease, SGLT2 inhibitor is definitely indicated. But when the patient does not have an ASCVD, giving SGLT2 inhibitors may be postponed. But newer drugs like that are coming up, like GLP-1 receptor agonist with dual agonism, with a GIP, that reduces weight. There are studies which say in an obese patient, if you give them tirzepatide or semaglutide for obesity, not for diabetes, his sugars comes down, his weight comes down, he goes into remission. So when there is an evidence that the ASCVD is there, we can definitely go for SGLT2 inhibitor. So what other, okay, the same patient, this patient came to us, we have advised him, told him to do, as doctor said, we can put him on lifestyle changes, told him to do that, and then he comes back after 6 months. Now the same patient, fasting blood sugar is 155 and HbA1c is 7.8. Now we are going to divide it into two criteria, pathways. Let us say this same patient I am talking about, 35 years old, fasting sugar 155, A1C 7.8, but his BMI is 19. How do we go about that? A lean diabetic. Now he is a diabetic. His A1C is crossed to 6.4. Now it is 7.8. How do we go about managing a lean diabetic? We see a lot of obese diabetics, but how about a lean diabetic? So it's a classical case of lean diabetes where the secretory function is at vogue. That is more predominantly there, but it doesn't mean there is no insulin resistance. That is the thing should be taken up. And based on that, here, even though they are diabetic, the proneness for ketosis is less in this patient. And it can be managed as usual by dietary management, and more stress should be given on balanced diet to this patient, and we can avoid certain drugs which will further reduce BMI, such as SGLT2 and other drugs. extent for a obese or a classical type 2 diabetes. And other latest drugs can be given. GLP-1 and other things can be given, but lean diabetics. But as a rule, we have to stop the patient and metformin, unless it is absolutely contraindicated. Yes. For all type 2 diabetes patients, insulin resistance is the main pathology. So, if at all there is an absolute contraindication related GFR, etc., we can think of DPP-4 inhibitors in these patients. In lean diabetes, we have to rule out LADA and other monogenic causes or other any pancreatic causes. And so we have to do C-peptide, GAD, if patient is affordable. According to that, we can start the medications.
Yeah, rightly pointed by Dr. Kumar. Lean diabetes, rule out LADA, depends upon the C-peptide fasting and postprandial value. Still, the patient may be having insulin resistance. Still, the patient is having subcutaneous atherosclerosis. So, after lifestyle therapy, whether HLT inhibitor or metformin, and third only DPP-4 inhibitor. After that only depends upon the pure
value, increasing the protein intake and correcting the malnutrition improves their diabetes
Okay.
as well. It's a distinct class of
Okay, sir.
drug.
So the idea is when we are talking about a thin diabetic, more than a lean diabetic, a thin diabetic, we expect that insulin resistance to be not there, because that's the opposite is the obesity. Obesity, we expect insulin resistance, you think metformin is the drug of choice. A lean diabetic, previously we used to think insulin secretion is the problem. Even though they are lean, they have visceral obesity, and metformin will be the choice one. So because that has reduction in, there is no hypoglycemia, and you can give it in the long term with better glycemic control. So metformin will not be excluded because this person looks thin, because in India we have visceral adiposity. So how about a person who has a BMI of 32, the same values, sugar is 155 fasting, A1C is 7.8, and his BMI is 32. So in that extreme, how do we go about managing this patient?
First, we have to try SGLT-R inhibitors, metformin, and DPP-4 inhibitors. If not, then GLP-1RA we can choose.
Okay.
Along with lifestyle modification.
Even in the patient with low BMI, if they are in the pre-hypertensive stage, it is imperative to start SGLT2 inhibitors because it works for both. Like along with metformin,
Hypertension.
A small dose of SGLT1 inhibitors also can be given in low BMI patients. In high BMI patients, as we discussed, metformin with SGLT inhibitors with DPP-4, all three play a major role. And if they are in the obese or in that range, GLP-1 can be given. And in these patients, we need to see for cardiac markers, cardiovascular disease and kidney disease. And if it is present, it is imperative that we start them on GLP-1 inhibitors. That's about.
Okay. As we were discussing, LADA is also there. A person who is thin, we have to think of a latent autoimmune diabetes. So GAD65 will tell us whether if the antibody is positive, then we know this person is a type 1 diabetic presenting later in life, in whom insulin will be coming in the topmost. If GAD antibody is negative, then we know he's a type 2 diabetes, but thin looking. In a person who is obese, when there is an atherosclerotic cardiovascular disease or hypertension, as Dr. Nandini was saying, even in a thin person, and SGLT2 inhibitor will take care of both sugars as well as the blood pressure. So how about using, instead of metformin, going for the newer GLP-1 agonist to reduce the weight as well as the diabetes? We are always focused on starting metformin. After lifestyle change, we always think of metformin. Why should we not think of the newer drugs a patient can afford? His BMI is 32. Why not put him on a GLP-1 agonist or dual GLP-1 GIP agonist?
Yeah, definitely it's a fantastic question. It depends upon purely depends upon the packet money and jacket money. So purely, so morbid obesity and the number one drug, actually here, you have to give the remission of the diabetes. If the patient is affordable, surgical management, if he is willing. But nowadays, there are a lot of robust evidence for the medical management, for the physicians. So number one drug, that is both GLP-1 and GIP, dual agonist actually, it reduces more than 15 kg weight loss, 60% remission of diabetes, if the patient is affordable. If she is not affordable for that particular cost, semaglutide oral or injectable can be advised. Or if not advisable, lifestyle therapy with a simple SGLT2 inhibitor, still gold standard to reduce the weight along with the lifestyle therapy. And you have to add, first drug should be, the third drug should be SGLT2 inhibitor along with metformin, lifestyle therapy, all the things, all other ABCD complication has to be addressed simultaneously. And present, so you have to rule out all macrosal complication, any target damage, it should be addressed simultaneously, then only the CRM complication will come down, morbidity moderately will come down.
So even though we consider the GLP-1 agonist, the background should be metformin, no sir? But with the background of metformin, we have to start the patient on GLP-1 or GAP and
The idea now is
the patient is
metformin.
having atherosclerotic cardiovascular complication, first drug should be this drug, after that only metformin, as per ESC guidelines.
Now the evidence is shifting, sir. Yeah, we can.
It should be considered in all atherosclerotic cardiovascular disease along with metformin. Unless the patient doesn't tolerate, we go directly to the other drugs.
ESC guidelines, class 1 indicator is SGLT2 all these.
Yes, sir. SGLT2 is.
In ACVD.
No, sir. SGLT is class 1 indication now, but it's not that metformin is.
Yes, sir, because the background problem is resistance, sir. The SGLT2 and GLP will not address the resistance. So,
Number 1 drug will be, number 2 you add metformin. This is my concept. 1A indication, after that only you have to add metformin.
No, sir. Metformin
sir,
is already
metformin
an
should be the base.
established class
Yes, sir.
1 indication, sir. Now, SGLT.
Recent evidence, first is SGLT.
There is any evidence of atherosclerotic vascular disease or any kidney disease or any evidence, then only I think the first drug of choice is SGLT or GLP. If there is any resistance, is there definitely metformin is the drug.
So type 2 diabetes per se is insulin resistance
Sir,
also.
this case, classically your BMI is
directly on
32.
SGLT2 or metformin plus SGLT2.
Ah, yes, that is what I am asking.
Sir was telling.
SGLT number 1, number 2 is
No, I am telling metformin number 1, SGLT
Yes,
number 2. Sir.
that should be
Yes,
there.
sir.
Unless there is a proven AACVD, SGLT2 will be number 2, while metformin will be the
Number
proven
one.
drug that is given.
Yes,
taken.
The
And
case-
even SGLT2 inhibitor versus GLP, if the patient can afford it, GLP-1 has more robust evidence of weight loss
Yes.
and mortality benefits. Because previously we didn't have any drugs that reduces mortality. We had so many drugs for diabetes, but none of them increase the quantity of life. All of them increase the quality of life. So now we have drugs that increases the quantity of life, SGLT2 inhibitors and GLP. So those we should be using more. So any of you are using GLP-1 receptor agonist, semaglutide oral, parenteral, how do you go about using it?
I don't have experience, sir.
I am using semaglutide.
Oral.
Oral.
How do you start, sir?
Actually, I used to start, that's 3.5, 3 milligram and 7 milligram, 14 milligram, all are available. All are same cost. So usually, if the patient is not affordable, I used to give 14 milligram on an alternative day. You can read it 14 milligram and divide into the off tablet, alternative day. It's a cost beneficial. All 3, 7, 14, all are same cost. So benefit also very good.
I beg to differ here, sir. Semaglutide has a specific thing that you should not break the tablet. If you break the tablet, it doesn't work. Semaglutide is a technological wonder. It is an amino acid that goes inside the body and acts. When an amino acid goes inside the stomach, it gets metabolized and broken down into all these small particles which cannot work. So they have a technology called SNAC technology. SNAC, what it does is, semaglutide is a wonderful, it comes as a brand name called Ribelsis. As Sir said, all of them are priced nearly the same, 3, 7, 14. All of them are around 250 rupees. It can give you a reduction of 15% body weight of the initial body weight. It has a technology called SNAC. What the SNAC does is, it inhibits the stomach acid and helps the semaglutide to get absorbed. There are some specific way we have to give it. It has to be taken in an empty stomach. It has to be taken with 100 ml of water. If you take 200 ml of water, it will reduce your sugar, but your weight will not change at all. Because the extra amount pushes the semaglutide into the duodenum, and the semaglutide doesn't work. It will reduce your sugar, but not your weight. So it has a specific way to give it. Ribelsis is a wonderful drug, but it's a bit expensive. It will cost around 10,000 rupees a month.
but that's going to give you a 15% weight loss. So 3 milligram, expect nausea, expect diarrhea for a few days. Once they get adapted to it, 2 weeks or 3 weeks later, go over to 7 and 14 and never break the tablet. We should specifically tell because 14 milligram is 280 rupees and 7 milligram is 240. If they break it, the snack doesn't work and semaglutide doesn't work. How about GLP-1 agonist injectables? Is anyone using it? Or like dulaglutide, the newer one, tirzepatide?
So one point about the oral semaglutide, when patient don't tolerate, initially for the first 10 days or so, you can ask them to take alternate days. By the time they develop compliance to the bloating and abdominal distension, that is also helpful.
Yes, yes, wonderful point.
With the injectables, the cost is almost the same as oral. Initially, we start at low dose 2.5 milligram and then increase to 5 milligram. Except for the injection thing, most of our diabetics are
How about the newer ones like dulaglutide and tirzepatide?
I don't have it.
Well, Madam is telling about tirzepatide, I think, sir. 2.5 milligram to start with, 5 milligram to escalate.
Tirzepatide.
Yes, sir.
Tirzepatide.
Yes,
Okay.
It is a combined GIP and GLP, sir.
Compared to oral semaglutide, injectables have the GI side effects. That's what we experienced previously. But the recent Wegovy and tirzepatide we have not yet used. Injectable semaglutide and tirzepatide we have not yet used. But previous experience, we had issues of GI side effects. But in oral semaglutide, we have not experienced much GI side effects. Majority of patients are tolerating the drug. They are adhering to the drug. We have seen wonderful weight reduction. So oral semaglutide at present in Indian patients, they are doing well, especially in BMI more than 35.
Okay.
And studies say that this newer drug, tirzepatide, is showing 26% weight reduction.
Right.
Yes.
So we have, Doctor, do you want to talk?
Sir, actually, in this case, as per criteria goes, the patient fits into obesity class 1. And discussing about GLP-1 RA for this patient, as sir rightly pointed out, based on patient's preference and economical background and other things. But metformin as an age-old product we have been using for ages and without serious side effects we are using, and it addresses the basic pathology of the diabetes insulin resistance. GLP-1 RA, we shouldn't go with the view that it is the latest product without any side effect. There are cautions to that and there are adverse effects specific to that. So we have to address all these things. We should be aware of all these things before instituting the drug.
Right. So, yes, sir.
What about the combination of insulin glargine with lexasunatide, which is being marketed these days? Any experience about that?
I have never used it.
Probably Novo is soon coming with once weekly insulin with dulaglutide.
I have used dulaglutide alone. It's a wonderful drug.
Somebody who is already on insulin, you don't have to add another injection.
No, the advantage of dulaglutide I see is whenever a person who requires a basal insulin, probably on a lower dose, we can try dulaglutide. One or three advantages we can say. One is it's weekly one injection, and it is an auto injector. You just press it, the whole dose goes, no drops, sticking out that you don't waste. And three, it costs around 10 to 12,000, while tirzepatide costs around 16 to 17,000. This comes as a 0.75 and 1.5 milligram. Only 2 doses are available in dulaglutide. Excellent weight loss. I saw a patient who lost a few kgs over a few days. I told him, it take 4 to 6 weeks for you to reduce weight. While he comes back 5 days later with his sugars down and not hypoglycemic, normal range, but at the same time he has lost weight. Main advantage is it's given weekly once. So any patient who we are considering in an obese person who needs a basal insulin, if he can afford, we can try dulaglutide or tirzepatide. Tirzepatide, the weight loss, the dose they are talking about is 15 milligram. But in India, we have only 2.5 milligram available. So 2.5 and 5 milligram available. And that itself costs around 16,000. If you see dulaglutide, the weight loss is around 15 to 20% of the basic starting body weight. If a person weighs 100 kgs, he starts with a dulaglutide, we can expect around 15 to 20 kgs, while with a tirzepatide, it is going to be 25 kgs. So if the affordability is an issue and we can convince him to take once a week an injection, I think dulaglutide will fit the picture.
And 2 patients we have experience with the semaglutide, 7 milligram, severe side effect, peripheral neuropathy, stopped for few months, 2 months. Again, if you start with 3 milligram, no side effect at all.
Okay. So
idiosyncratic reaction. So 7 milligram they are not tolerating. After stopping few months, 2 months, again they have started with 3 milligram, they are tolerating very well. One of the fantastic molecule, that's the GLP-1 receptor agonist, works out very well in India. It's a novel molecule. In few years, the cost will come to 10 rupees, 20 rupees also.
Two things to just add to Sadish sir's comments. One is dulaglutide plateaus much earlier than tirzepatide. That's what I have seen. And the persons who have already plateaued on dulaglutide, when you convert them to tirzepatide, they have better weight reduction. Yes. I have 2 patients like that. Another thing is, this semaglutide, when it comes to injectable, it will come as a once weekly injection.
What I usually tell the patients is, we'll start you on dulaglutide. When you start you on dulaglutide or tirzepatide, it's not like you are fixed to it for the life. Once you reduce the weight, if you can maintain a good lifestyle change, then you can maintain it. You don't do the lifestyle modification, but just take an injection, it's not going to work. So I suggest them, put weekly once weight. See how your weight reduction is with the dulaglutide. Once it starts plateauing and you still want more reduction of your body weight, you can switch over to maybe tirzepatide for a few months and then maybe come over to stop it or continue it, you can reconstruct. Okay, now the same patient, 32-year-old, the same 155, A1C is 7.8. This person now it's a lady. And I want to discuss about how to go about GDM, gestational diabetes. What are the cutoffs for gestation? When do we call a person a gestational diabetic? When do we screen for them? How do we screen for them? Shall we discuss about that?
Anybody? GDM. Yeah. GDM actually the diagnostic criteria, the detection, that is blood sugar of fasting more than 110, postprandial more than 140, in the more than 20 weeks of gravity uterus, 20 weeks of pregnancy, if it occurs, it's called gestational diabetes mellitus. And before that, yearly first trimester pregnancy, if it is there, it may be due to type 1 diabetes complicating pregnancy or type 2 diabetes complicating pregnancy. So it should be same like type 2 diabetes mellitus in non-pregnant women, except you have to continue with insulin and metformin. That is the clear-cut evidence. So you have to plan them for the presence of, in the early phase itself, the first visit itself, you have to do OGDT and A1C, and strict blood glucose control is very, very important, because first trimester pregnancy, hyperglycemia lead on to.
So when do you suggest OGDT, sir? I mean, what is the cutoff? I mean, when do you start them and 7 weeks, 18 weeks? When do you call a person a gestational diabetic? A person who is in first trimester comes.
Hyperglycemia in pregnancy is different, and gestational diabetes is different.
Yes. What is the cutoff?
It should be that's fasting should be less than 90. It should be the cutoff, that's value, and 1 hour PPG should be less than 120. 2 hours it should be less than 140. But target should be less than 90, less than 110, less than 120. After detecting,
yes, exactly.
That's the target. And A1C should be kept less than 6, not 6.5. And early pregnancy, if you don't control, definitely lot of congenital malformation very common. Macrosomia for the children is very common.
Gestational diabetes is pregnant woman becoming a diabetic who is not a diabetic previous.
Exactly.
That is very important. And hyperglycemia in diabetes, as sir already told, that might be a pre-existing diabetes complicating a pregnancy, or a patient in pre-diabetes becoming a over-diabetic during pregnancy, or a gestational diabetes. So in gestational diabetes, as per DIPSI guidelines, there is a single OGT test with a 75 gram, and the cutoff is if it is more than 140 after 2 hours, is diagnosed as GDM. As per the target goes, it is a prandial phenomena, and fasting should be less than 90, and postprandial should be less than 120. HbA1c target should be as low as possible, as feasible. So it is ideal to keep it around 6, so that it is advantageous to both for mother and also for the offspring, because the treatment of gestation diabetes is not only for the mother, it also has a good effect on the fetus. Actually, it runs through 3 generations.
So any patient, ideal condition for gestational diabetes is when it is diagnosed at the 20 weeks of pregnancy. So before that, if a person comes in the first trimester obese, you do an A1C, it is 7.8, it is probably that patient is already diabetic and she is presenting with a pregnancy. So this is not gestational diabetes, this is diabetes with the pregnancy. A person who has been not having sugar, having a normal blood sugar, at the 20th week you diagnose diabetes, then it is gestational diabetes. As doctor was saying, sir was saying, there are 2 ways we can go about. This is the only place where we can use oral glucose tolerance test. All the other patients in type 2 diabetes, and we don't use OGTT at all. This is the only place where oral glucose tolerance test is indicated. So we can go about it in 2 ways. As sir was saying, we can give it in a non-fasting state, 75 grams of glucose, check the sugar 2 hours later. If it is more than 140, a person comes to you pregnant, 23 weeks, 24 weeks, 75 grams glucose, irrespective of the fasting state, fasting 2 hours postprandial, 140, you have a GDM. Or if a person comes, this is what our criteria, DIPSI criteria, while the other criteria is the international criteria, where the Carpenter criteria, where patient comes in a fasting state, you do a 2 hours, half an hour control, 93 fasting, 180 postprandial 1 hour, and 153 2 hours. If any of the value is positive, more than 90, 180 and 153 at 1 hour and 2 hours, then we call it as a gestational diabetes. So to prevent macrosomia and the other injuries and the 3 generations of chance of diabetic, increasing the diabetic, we treat them with metformin and insulin. So what are the insulin that are indicated? Can we use any insulin, or is there any specific insulin we should go about, which are being approved for diabetes specifically?
Insulin is preferred, sir. Actually, regular insulin, other things are widely available and usually studied.
How about basal insulin, sir?
Basal insulin, the
NPH
one Detimer is
yes.
Detimer is approved.
Approved. And
U300 also in India it's approved. U300, routine human insulin, and Detimer only are approved.
Yes.
And before that, I want to differ one point. OGTT, it's a need of our, not only pregnant lady, non-pregnant, elder, younger, whatever it is. OGTT in my hospital routinely, the newly detected OGTT 730, 82.5 gram of glucose D with 200 ml of water. Fasting should be less than 90, half an hour PPG less than 165, 1 hour less than 155, 2 hours less than 140. Routinely, many patients we are detecting pre-diabetes. In that stage itself, lifestyle therapy, SGLT2 it's indicated, lot of robust achievement we can achieve.
Okay. So the only basal insulin that has been approved for diabetes is, we usually use Glargine for most of the things, the brand Lantus and Basalog, things like that. But it has not been specifically approved for pregnancy. Only Detimer is approved for pregnancy. But a person comes, all this approval is because of teratogenicity. If you see the basal insulins, the Detimer has been proven not to be teratogenic, while a person who is having Glargine does not have a lot of teratogenicity, but they don't have the classification. So if a person comes in the 3rd month of pregnancy, already on Glargine, we don't have to change them. If a person is planning to pregnancy and comes to me and says, I want to plan pregnancy and I want to control my sugar, then probably metformin and Detimer will be the ideal one, because through the pregnancy we will continue. Because if you start on Glargine, it will not be the ideal, and the patient has come to you for the best therapy. So, okay, the next level, we'll go to that. If a patient has this kind of patient, comes with a proteinuria, our nephrologist is there, how do we screen for diabetic nephropathy?
Sir, whenever any patient, we should screen for definitely for SPART microalbumin, what we are normally doing. But if it is a type 1 diabetes, we can wait up to 5 years. But if it is type 2 diabetes, we have to do the same same consultation itself. So routinely we advise the early morning sample. So normally the advisable, the gold standard is 24-hour protein or 24 albumin color. But since we are, this almost correlates with 90 to 92%. So we are going with that of the spot protein creatinine ratio or spot albumin creatinine ratio. Or what we are doing is the microalbumin, macroalbumin. So the previously the term, now the terminology has been changed. Microalbumin is moderately proteinuria, albuminuria, and whereas macroalbumin is severely albuminuria. So the normal is less than 30, and 30 to 300 is microalbuminuria, greater than 300 is macroalbuminuria. So whenever there is a microalbuminuria.
So what is the new name for this? Previously we used to talk about, microalbuminuria and macroalbuminuria. Now this minimal albuminuria.
That's A1, A2, A3. That is microalbuminuria is moderately increased proteinuria. Macroalbuminuria severely increased proteinuria. Right. The normal or mild increased proteinuria is otherwise known as A1. That is, we have already CKD staging 5. In addition, we are added A1, A2, A3 to know the prognosis. Because the A3 have poor prognosis compared to the A2 and compared to the A1. So the new terminology for microalbuminuria is moderately increased proteinuria, and macroalbuminuria is severely increased proteinuria.
So in a type 1 diabetic, we are immediately going to screen. We wait for 5 years. We can wait because that takes so much time for the kidney to get affected. For type 2 diabetic, we don't know when the person has been become a diabetic. So we start off immediately. So how do we go about managing them, sir?
So the normal thing, the important thing, even the obesity also, why we are regarding the obesity, because there is an increased progression of CKD with the obesity patient, because they are telling because of increased adiponectin, there is increased chance of all this RAS system. So the RAS system is the main thing which important in playing the prognosis, the progression of CKD. Because the increased RAS, whenever there is an increased angiotensin or the aldosterone, there is a increased vasoconstriction of the efferent arteriole that leads to the increased intraglomerular pressure that leads to more proteinuria. So the proteinuria itself leads to inflammatory condition and increased transforming growth factor beta that leads to the inflammation and increased IFTA, that is interstitial fibrosis and tubular atrophy. So that's the reason always the drug of choice is the ARB or AC inhibitors in the type 1 or type 2 diabetes. That is the drug of choice unless otherwise that is contraindicated. So the main mechanism of action is it's mainly cause efferent arteriolar dilatation, thereby it decreases the intraglomerular hypertension, thereby it decreases the proteinuria. That's the drug of choice. So even the obesity, the recent study they have shown that even semaglutide in the recent study, if you give, that will decreases the proteinuria because it decreases the RAS system in the body. Another thing is that now another drug which is recommended in the lot of studies after that of EMPARAG and all this Dyslipidemia, the SGLT. SGLT plays very important role, not only atherosclerotic cardiovascular, even with the proteinuria of the CKD, the drug of choice is that SGLT because it decreases the load, intraglomerular hypertension because of there is tubular glomerular feedback. Thereby, it decreases the inflammatory and also it is definitely decrease the prognosis. And the recent drug, the fentanyl, what is that drug? MR, non-steroidal mineralocorticoid receptor agonist. Previously it was aldosterone, now because the non-steroidal. So the only contraindication for the fentanyl is it can be used additional to that of ACRB, but you should be very careful with the potassium. So when it's the hyperkalemia, because both the things can cause hyperkalemia, so the dose it's available is 10 milligram and 20 milligram, and the cost come around 100 rupees per tablet. So we are using the 20 tablet as it can be that is splittable, so you can use the off tablet as a 20 milligram because of the cost. Once I think the cost we can come down, we can use routine. So these are the drugs which is the harmonium. One is the ACARB, then followed by SGLT inhibitor, and another thing is the fentanyl.
So all these patients, we are going to treat them for albuminuria. If there is any albuminuria, either it is mildly excreted, moderately excreted, or highly excreted, we are going to think of an AC inhibitor, ARB system, one of this. After that, the second line will be SGLT2 inhibitor, and probably the third line will be the Mendrinone. Is there any role for giving any of this prophylactically? Patient is a non-diabetic, patient does not have proteinuria. Can I start him on an ARB prophylactically?
No, sir. I said there is no clear guidelines because the thing, as you know, is the double-edged sword. Even the hypotension can cause the damage to the kidney. So the hypertension you should keep because of the auto-regulation you should keep unless there is no indication. If the patient is a normotensive, this is not recommended. If it is proteinuria, if you are not able to cause hypotension, you can try. At the minimal dose now,
ramipril 1.25 milligram, even telmisartan 20 milligram. But if there is hyperkalemia or hypotension, especially because we are using, it is advisable, we should be careful when you are using SGLT inhibitor with the that is ARBs. Nowadays we are, if the patient is at volume overload, we are using diuretic also. So these three things can worsen, especially if the patient take any NSAIDs for that, definitely they will land up with AKI.
How
So
about, because we know AC inhibitor reduces proteinuria, ARB reduces, why not combine both of them? Can we do that?
The recent study, previously it was there, the combination was Telma, R and all the thing. Now after the recent study, there's a more incidence of AKI and also hyperkalemia. So it's not advisable to give combination, you should go for the maximum dose of either the AC or ARB. So you can go maximum telmisartan even up to 80. If there is no side effect, you can go to 160 milligram also, even olmesartan 40 BD or even losartan 50 BD also. But you should watch whenever you introduce ACRB, you should repeat the serum creatinine and potassium after 5 days. If there is a hyperkalemia, or there is 30% increase from the baseline of the serum creatinine, you should be careful. You should see your prescription, there is any additional diuretic or NSAIDs, and you should, if the patient is a euvolemic, you should be careful. If it is hypovolemic, there is no problem if you give SGLT or diuretic along with that of AC inhibitors.
Is a AC inhibitor ARB, is it a class effect, or can we go on a specific drug?
As I told that, I think definitely we nephrologists, we prefer telmisartan because it is an additional effect over the lipid profile also. So normally, as I already told that, most of the nephrologist prescription contains telmisartan, cardiologist prescription contains olmesartan, and if you see the endocrine prescription, it contains losartan because of the hyperuricemia. So, but I think but we are always nephrologists, we are very comfortable with telmisartan compared with that of losartan. But if definitely hyperuricemia is there, the drug of choice is losartan.
Just a minute, sir. Because of lack of time, we will just go to the specific topics.
One important point, when nephrologist uses sartan, cardiologist uses the prils. Because cardioselective cardiac ACE will be inhibited only by prils, ramipril or ramipril.
Okay.
It's very important.
Now, since we are running short of time, I'm going to ask specific questions to specific specialists so that we can, other people can contribute after the person's talks. Dr. Nandini, who's the cardiologist, patient comes with an, diabetic, his or her ECG showing ischemia without symptoms. How do we go about that? Where do we use aspirin? Where do we use statins? How much?
Most of the diabetics, we start them on a low-dose statin at the time of presentation, depending on their age. When they present with ECG changes, we don't go by the symptoms. We evaluate them further, either by a TMT or by an echo. And if there are any regional wall motion abnormalities or inducible ischemia, then you start them on full dose of cardiovascular disease management, full dose statin with antiplatelet drug, aspirin or clopidogrel. But aspirin as a primary prevention is no longer given because of the bleeding risks and is no longer indicated. Only when there is evidence of an anginal equivalent or ischemic changes with other markers, then we start them on aspirin with high-dose statin. Otherwise, aspirin is not given.
So any patient over the age of 40, 70 to 70, without thinking of cholesterol, we can just start them on a moderate intensity statin. And aspirin will be only indicated if there is a primary indication for that. Previously, we used to think diabetes and CV equivalent, a patient equivalent to having an MI, and we used to start on aspirin. Now they have found out the benefit of aspirin is definitely there. Multiple trials, Aspire, all those things tell us there is benefit of aspirin, but the mortality goes up. They have a major GI bleed. So they don't die of myocardial infarction, but they die of a major GI bleed or an intracerebral bleed. So that equates with each other. So unless there is a primary indication for an aspirin, we don't use aspirin anymore. And aspirin is indicated only when there is an ischemic heart disease or a cerebrovascular disease or a peripheral vascular disease plus statin. So what's the statin dose we go on?
If the patient initial levels of lipids are normal, then we go about 20 milligram of atorvastatin or 10 milligram of rosuvastatin. But if the patient presents with an acute coronary syndrome, then it is always full dose, 40 milligram of rosuvastatin or 80 milligram of rosuvastatin. Another one regarding the previous question, what was the question? Inferior wall changes. I wanted to add that most of the time inferior wall changes may be false positive changes without ischemic changes, especially in women. So we need to rule out coronary artery disease, presence of coronary artery disease in these patients. But the presence of ischemic changes in an anterior wall is usually positive for coronary artery disease that we need to add.
Okay. In a person who
So
is...
the diagnosis of diabetes per se itself is an indication for statins.
Yes.
40 to 75 years
Right.
it is an indication for
Yes.
statin unless there is other contraindications. And any other age, if there is a ASCVD proven, it is also an indication
Yes.
for statins.
Previously, we used to start aspirin in that age group, diabetes, aspirin. Now diabetes plus statin. Aspirin only when indicated.
And that too moderate intensity statin.
Right.
Primary
so moderate
prevention
indication.
nowadays, not aspirin, it's a statin,
Statin.
for primary prevention.
So the moderate dose will be 10 to 10 milligram, 20 milligram of rosuvastatin. In more intense will be 40 milligram of rosuvastatin. So no use in giving 5 milligram of rosuvastatin or 10 milligram of atorvastatin as commonly available in doses. Go with a higher dose so that they get the full benefit. At least 10 mg of rosuvastatin or 20 milligram of atorvastatin in any diabetic, irrespective of lipid status, between the age of 40 and 70. After 70, we are not about thinking of statin because statin takes a longer time to work. And in those age, whether that statin is going to work and reduce mortality, we don't know. So 40 to 70, we use that.
So that means it should reduce 30 to 49% of the basal LDLs.
Right.
That is the ideal.
Yes. So moderate intensity statin reduces around 50% of the initial LDL, and high intensity reduces more than 50% of the initial statin. So if a person is already having a 190, we can expect around 90 milligrams of LDL reduction with a moderate intensity of statin. So if this patient is obese and he snores, his wife comes and tells, I cannot sleep with him because he is snoring. So how do we go about a person who we are thinking of as sleep apnea?
It's very common in obesity where the excess fat deposition in the upper airway, it leads to the snoring, and we have to evaluate for OSA, obstructive sleep apnea, and they usually have daytime sleepiness, fatigue, and nighttime sleep disturbance, frequent urination. All those things are possible. In such case, we have to go for the stop bank questionnaire. If it is positive, we can go for the sleep study. And if sleep study, if AHI, that is apnea score is more than 15, we can start CPAP. If it is less than, we can try anti-obese drugs. We can reduce the weight, and all those things can reduce the snoring, and sometimes they can reverse. We have seen in our clinical practice, those who are on CPAP with the anti-obese drugs, we have stopped the CPAP. So reducing weight is very crucial in OSA. Majority of OSA cases, around 90% OSA are obese patients. So this can lead to diabetes and hypertension, cardiovascular risk. So treating OSA is very crucial in obese patients.
So stop bang is a criteria we use, the questionnaire we use. Stop bang is a patient is snoring, feels tired in the morning, or has an observed apnea in the night, or patient has a blood pressure, STOP. Stop snoring, tired, observed apnea, and P is the patient is having blood pressure. Or bang is the BMI is more than 35, A is age is more than 50, and BMI, that is N is the obesity is more than 35 BMI, or neck circumference is more than 40, then we can, if any of this, each of them carries 1 point. If more than 5 is there, definitely we can suspect OSA. As doctor was telling, we can do a sleep study, find out if your AHA index is high, we can put them on either a BiPAP or a CPAP. When do we go for a BiPAP or when do we go for a CPAP in an obese person?
If in a mild to moderate case, we can go for CPAP. If it is failed, we can go for BiPAP patients, especially obese hyperventilation syndrome. We can go for BiPAP.
BiPAP is tolerated. Patient not tolerating CPAP also, we can go for BiPAP.
Yes, especially bypass has dual pressure, one in inspiration and one in expiration. Patient has retaining carbon dioxide, COPD, where we are going to think he is going to retain carbon dioxide, then CPAP, BiPAP will be useful. While a simple person who can tolerate it, CPAP is cheaper than BiPAP. Is there any other questions that you would like to discuss? We are running short of time. Multiple rings have been, bell rings have been given to warn us. So if you would like to give some clinical nuggets on how to go about diabetes, with your experience, These are the things I thought other people should know. Please do that.
Treat obesity, not only central and insulin resistance, fatty liver, reverse the, you find out the reversible causes, especially obesity is a reversible factor in type 2 diabetes. So target obesity rather than glucose level.
So in a borderline individual, it's ideal to rule out LADA as we already discussed. So yeah, screening of antibody profile is very important. And regarding drugs, there are weight neutral drugs, weight reducing drugs, and weight increasing drugs. So everybody, the PG should be particularly knowing about the weight increasing drugs like sulfonylurea and insulin to be avoided in high BMI patients. Weight neutral drugs like DPP-4 and alpha glucosidase inhibitors may be ideal for normal BMI patients, and who are having low weight or high weight, SGLT2 inhibitors will be, metformin will be ideal.
Most of our practice, we see an ECG and we leave them. But when we go into the history, most of them have an history of anginal equivalent. If picked up early, we can prevent sudden cardiac deaths in diabetic patients. Most of the severe triple vessel disease patients have a normal ECG. So it is better we advise them for a TMT every 2 years, or if they are not willing, at least we need to ask them for a history in our routine checkup when they come for a checkup.
In my diabetic clinic, actually, pre-diabetes or diabetes routine executive most health checkup that includes ECG, echo, and TMT. Because routinely TMT, many patients we are picking up positive TMT and submit, if positive, submit them for 256 multicell CT angio. More than 25% people, they are positive, 20%, 30%, 50%. So TMT is very important role. ABI also very important role. And LAE and left vertical remodeling, all the things we can able to pick it up. And usually less than 50, 50 to 150, 150 to 300, more than 300, A1, A2, A3 albumin. Many patients we are picking up. And many patients are associated pre-hypertensive, pre-diabetes, and pre-obesity. That is 23 to 25 itself you have to target. Then only, previously diabetes, if you know diabetes, you know medicine. Now if you know metabolics, that is diabetes with obesity, you have to address simultaneously. Then only these people also live to 100. Thank you.
Especially when the patient is obese, they are normally old age, they will take a lot of NSAIDs. So because with the obese patient, we advise for even whatever the walking and all, they will tell you it's very difficult because they are having joint pain because of the obesity. So my advice is whenever obesity patient is already on SGLT inhibitor or ARB, we should be careful because if they take NSAIDs, they will have volume overload. So whenever there is a volume overload, if you prescribe any diuretic, it should be SOS drug. We should clearly explain the patient. You should stop the diuretic if there is no swelling, only if there are evidence of volume overload. Because if you give 10 days or 15 days of diuretic, they will come back with you AKA. So you should be careful. The patient who are taking NSAIDs, patient who are already ACRB, SGLT and diabetes.
I think the responsibility lies both on doctors and the parents and also with the individuals. As we talk about remissions and giving advice, I think we should impress upon the teenagers who are going to become a future potential candidates for diabetic and cardiometabolic diseases. So they should understand the importance of the lifestyle changes should be what we should bring about. And we should spend more time in addressing this to the patient, and many reach out programs to address the school children and other individuals for the healthy habits, healthy eating habits, and then the physical activity, and also de-stress them. Even a stressor can be a potential trigger for that. So all these things should be addressed so that we can build up a future healthy population. Thank you.
The evaluation of uric acid and the evaluation for MASLD is very important in all diabetic patients, sir. Uric acid is a part of metabolic syndrome, and MASLD is very, very important. It's a silent killer, and it's going to be the leading cause of cirrhosis in future. So it's very important.
I thank all the panelists and the audience for the interactive session. We had a 1 hour session, but we had to cut it down because we are running short of time. All of us will be willing to more than talk and discuss with you off the floor. And as a part of organizing committee, I am going to honor the panelists.
May I request Dr. Palnippan to honor Dr. Satish? Certificate. sir. Now Dr. Satish Kumar will honor all the panelists. Dr. Venkatesh.
Dr. Dhananjay, sir. Dr. A.P. Nandakumar. Dr. Nandini, ma'am.
Dr. Palniappan, sir. Our deputy. Okay, thank you. May I request the chairpersons for the next session to come to the dais, Dr. Lavanya, Dr. Jayasudha, and Dr. Ramya. Now the speakers, Dr. Chandrasekhar from Warangal, Dr. B.K. Singh. Okay, yes, please. Yes, sir, please.
So Dr. B.K. Singh.
So good evening, Tamil Nadu, good evening, Vellore, and I thank organizing persons, particularly Dr. Palniappan, for giving me this opportunity to talk this evening, and I thank chairpersons too. Greetings from Telangana. So, speaking in the last session is very challenging, but we are running behind the schedule. We'll try to finish as quickly as possible. So now it is a postpartum care in either gestational diabetes mellitus or pregnancy-induced hypertension, which I am going to talk now. So we all know what is GDM. But thing is that prevalence is more than 30% and it is on rising trend. So 1 in 6 pregnancies is getting diagnosed with GDM, and Southeast Asians have high number, almost 23%. And this is the global scenario. So we are in the highest zone, prevalence-wise. So why this GDM is important? because it is 10 times risk of developing type 2 diabetes after the index pregnancy, and there is a linear risk of progression to the diabetes almost 10%, particularly in the first 5 years of delivery. So young women, these are the young women. So they have 2 times the risk of developing CVD and associated morbidity mortality, and they are also 2 times risk of developing non-alcoholic fatty liver disease. And it is not only the disease of the women, it is also disease of the children of the GDM women, because the children are macrosomic at birth and they have a propensity to develop the obesity and type 2 diabetes as well. And what is the interesting thing is the female babies of that GDM mother are likely to develop the GDM in their own pregnancies, as in the discussion said that it will spread in the generations. So this vicious cycle of intergenerational GDM will be perpetuating. So the first index pregnancy has to taken care, not only at the time of pregnancy, but even after the delivery. That is what the crux of thing. So close monitoring is very, very essential, and risk modifying interventions are very essential. But thing is that there is no currently available guidelines which can be very cost effective. So probably a DIPSI and other has to work on this lacuna in this thing. So we know that it is a cardiometabolic kidney spectrum. So it is, GDM is not different from same diabetes associated with metabolic complications. So in this area, there are challenges of testing, challenges of adherence, and challenge of implementing the interventions. So I'll go by one. Is the OGTT sufficient in stratifying the glycemic status of postpartum? Because 2 hours is a very cumbersome procedure. Using 1 hour instead of 2 hours, OGTT is as good as it predicts the diabetes as well as complications. And coming to the adherences, there are patient problems and provider problems also. Patient perspective and provider's perspective, they are not thinking about this thing, importance of testing frequently. And decision most often varies from country to country, high income countries and low middle income countries also. And these are the various guidelines from EDIPS, Endocrine Society, ADA, Canadian, American Association of Obstetrics, and the NICE guidelines from UK. All says that there are subtle differences are there, that postpartum, at least 6 to 12 weeks, you have to subject to 1 OGTT. Some says the 75 grams 2 hours, some says fasting alone or 75 grams of OGTT, and NICE guideline says only fasting blood sugar and HbA1c, either one. But there are controversies. So these are the patient factors and provider factors. Provider factors also lack of time to communicate with the pregnant woman after the delivery and at the time of discharge, and risk perception among the practitioners as well as the women is not that widely spread. And systemic factors are also there, and there are the process factors are also there. Out of all these challenges classified, we need to move forward to prevent the big silent epidemic of diabetes post-GDM. And management of GDM is aimed to reduce the glucose levels during the pregnancy, and only we are concentrating on the fetal microsomia. But I already told you, it is a lifelong CKM sequelae. So care of the woman in this area, in spite of all these things, it is very suboptimal, and there is a systemic problems I am telling you, So transition from the obstetric care to the physician care or diabetologist care is often less and non-existing also. So because of this, so what type of anti-diabetic medications can be given, particularly to engage, educate, empower high-risk women and women, that is very young mothers, are also in the productive years. Particularly women are working everywhere and they are the productive years, and they also contribute for the country's economy and apart from the family building. So we all know the first 6 months of delivery is very, very important, and usually 5 to 10% per annum there is a conversion of GDM into the over diabetes, and 17.1% of the women with GDM, even with the normal glucose tolerance at 3 months, also will develop diabetes, overt diabetes. And the surprising thing is that by the time of diagnosis, where the 2 hours OGTT is more than 140 milligrams, 40 to 50% of the beta cell loss is there. And beta cell loss is independent of adiposity or insulin sensitivity. And because of this, at 3 months postpartum OGTT is indicated, and it is not the absolute value, it is excursions. So in the previous discussions, Palniappan sir is telling pre-diabetes, pre-diabetic. So pre-diabetic or pre-diabetics or overt diabetes, what is the excursion of the glucose level is highly predicts what are the complications and what are the other things rather than insulogenic index and OMA-IR also. High fasting blood sugar is also strongly associated with development of type 2 diabetes. So where it is not possible, so simple fasting blood sugar also can be taken. And so variation you can utilize because the waiting is a very big issue. So instead of 2 hours, so 1 hour glucose also you can take it. And coming to the HbA1c, it is relatively easy to perform but not reliable in the first year of the postpartum because of the blood loss during the labor and persistence of high red cell turnover rate. But cutoff of 6.5 is also sometimes misclassified, 70% of the cases. So sometimes some professional bodies says that fasting sugar in combination with HbA1c can be predicting. Here also there are no clear-cut guidelines and there is a gray area. So despite the clinical relevance, uptake of the postpartum testing is very, very low universally. In the worldwide also, it is never crossing the 50%. But interestingly, this is less than a cervical cancer screening and antenatal GDM screening. So first time pregnancy you are going, first antenatal checkup is to rule out the GDM, but not at the postpartum. That is the clear point of discussion in my talk. But this is not impossible. From the same Tamil Nadu, I think Dr. Bhavatarani Madam, in the WINGS project, she have achieved this OGT testing in the postpartum 95%. So when Tamil Nadu achieving, why can't India and why can't the world? So dyslipidemia as a part of spectrum, so it is physiological also because of this high progesterone state and other decreased lipoprotein lipase activity during the pregnancy and after the delivery. So dyslipidemia is also present, particularly at the 12th week of gestation. Elevated triglycerides and low elevated LDL cholesterol and decreased HDL are seen. A 3 months postpartum dyslipidemia will never normalize even after 1 year of delivery. So that is the reason why even if the patient is not postpartum diabetic, postpartum dyslipidemia has to be taken very seriously. So here 1 in 6 women with abnormal glucose tolerance had an abnormal lipid profile postpartum, but 1 in 4 women, even without normal glucose tolerance had dyslipidemia. So 43% of the women had normoglycemia at 6 months of postpartum, but they have dyslipidemia. So even without diabetes, dyslipidemia itself is adding increased CVD events, 5.8 versus 2.5 who are not having GDM before. So the HDL itself is a high risk, but it is sometimes Asian Indian phenotype, 40%, but at least you can reduce the triglyceride to reduce the risk of CVD events to 12% by reducing triglycerides and 10% by reducing the LDL cholesterol. And there are so many studies like diabetes preventive programs postpartum. Best example is the Finnish study. So lifestyle interventions itself is a very effective. So, up to 58% they are reducing the risk of developing type 2 diabetes. And metformin and glitazones are the drugs of choice in this zone. And metformin and intensive lifestyle modification itself are reducing 50 to 55% of developing risk of diabetes. So DPP4 inhibitors or SGLT2 inhibitors are also studied, but very small in number. So there is what is called the previous GDM will last up to 5% of the weight reduction within the 24 months of dapagliflozin. So even the small is the number. Because of this weight reduction, so one has to think about adding the SGLT inhibitors, particularly dapagliflozin, and can be liraglutide 1 mg subcutaneously per day is also can be tried. So here, so there is one point, systemic barriers. So most of the things they think that GDM is only insignificant condition that disappears after the delivery. So, but that is not the case. We have to overcome that. So there are so many papers, best practices of managing postpartum care. So this is a very popular algorithm, but I'll just tell the importance approaches. Sorry, this is postpartum hypertension, PIH. Now I'll tell you about the PIH. So PIH is, so gestational diabetes will develop the postpartum hypertension. So obesity and insulin dysregulation, endothelial dysfunction and inflammatory status, all these are effective. So any new onset postpartum hypertension at more than 140/90 has to taken care as if it is normal hypertensive patient also. So hypertensive disorders are 10%, particularly during this thing, and risk of the chronic hypertension cardiovascular disease is very much seen in this set of people. And there are two types. One is the persistent or worsening hypertension or the de novo hypertension. They are not hypertensive during the pregnancy, but in the postpartum they may develop. So that is, and always look for any readmission because of the hypertension you have to take up. So the management, we all know the labetalol, nifedipine, enalapril, and all those things. So this is about the postpartum eclampsia guidelines also. Because of the time constraints, I'm skipping off these. So management for even eclampsia cases, postpartum eclampsia cases. So all these risk factors will be there. All these clinical manifestations of hypertension and preeclampsia are there. So here the paradigm shift has to be happen, particularly for the postpartum hypertension. So health delivery innovations and policy changes, because now that we have the remote testing the patients, the telemedicine and all, so definitely you have to track the persons who are presented with GDM earlier, and the best way is to make a registry of GDM patients and frequent follow-up should be there. So these are the summary of recent studies. I think I close here. Thank you very much for your patient hearing.
Thank you very much, sir. The next talk is going to be on metabolic phenotypes in obesity. Dr. Ramesh Agarwal, we are talking a lot of obesity, and Dr. Ramesh Agarwal is going to talk about different phenotypes in obesity. Thank you, sir.
Very good evening to all of you. Many thanks to the organizers of TAPICON for inviting me to this academic celebration, which is going to be there for the next 3 days, especially to Dr. Palinappan, who has called me all the way from Delhi. The topic here is metabolic phenotyping in obesity. Seems to be a very difficult and a complex topic, as you can see, but I am sure that under the roof of this prestigious medical college where I stand, I will be able to make justice with the topic. So in the next couple of few minutes, I will be discussing about the burden of the obesity, which already has been discussed elegantly by Dr. Panda, the definition and the measurement, the adipose tissue, what actually it is, the phenotypes, what are the phenotypes of the obesity, and briefly the management of obesity. So the inspiration for giving me this topic came from this recent article which was there in the Lancet in February this year. And this definition of the obesity which they have given will actually change the whole paradigm of obesity. Looking at the obesity, diagnosing obesity by the physicians and the endocrinologist. So just a brief overview of the obesity which already has been discussed. If you see in the year 2020, the prevalence of the obesity globally, if we take the BMI as more than 25, was about 38%, which is increased to 42%, and the projections are that it will certainly be double of what it was there a decade earlier. India is no far behind, as you can see that if we take the BMI as one of the criteria for measuring obesity, both the northern India, southern India, and most of parts of the other part of the India, the obesity is very much prevalent. But if we take central obesity as one of the criteria, which is on the right side of the map, so we can see that the obesity is prevalent throughout the India. So this is the scenario, we all are aware of it, nothing practically new in it. A very beautiful survey which is carried out in India, NFHS, which is the National Family Health Surveys, which have been there and which take the prevalence and the incidence of the non-communicable diseases. So if you see in year 2005-06, the prevalence of the obesity was 12.2, which has increased to about 23%. This is of the Indian data. And something again great happened in January this year when the Honorable Prime Minister said that to reduce the oil content by 10%. So very important statement from the leadership. And is it that only the oil which is going to, this 10% reduction will help us in combating the obesity? The message is that, yes, certainly the type of oil, the content of the oil is going to prevent the obesity, and the obesity definition needs to be defined. So something is going on that we need to be more aware of this particular problem, which till date we do not consider it as a disease. So obesity is characterized by excessive adiposity. So this is the newest definition which has come in, and we should understand that it is not the type and where it is deposited, it is that the fat has to be there in the body. So adiposity with or without abnormal distribution or the function of the adipose tissue is the definition of the obesity which Lancet has defined in February 2025. So what is fat, where it is, and how it is deposited? As you all know, the primary fat deposit is in the subcutaneous adipose tissue, under the skin, thighs, arms, abdomen. Visceral adipose tissue is there, which is under the abdomen, and it is all linked to insulin resistance. We have been discussing it since afternoon. Then there is ectopic fat deposition. When there is excessive of fat, the fat deposits at some ectopic places like liver, muscle, pancreas, heart, and kidneys. And we are aware that when the ectopic fat deposition is there, it is going to create problems. Brown adipose tissue, physiology, we all have learned it. Not of much significance, but there is a potential role of research. Probably if we increase the brown adipose tissue in the body, the thermogenesis will increase and probably it will lead to decrease in the obesity. So what is important here to learn is that fat is simply not a simple tissue or an organ. It is an endocrine organ, and being an endocrine organ, it releases many hormones, including adipokines, which has leptin, adiponectin, and many other hormones. And when these hormones are released in the body, so they are going to influence the basic metabolism of the body. So fat can be present in the muscle tissues, in the heart muscle, etc. So this is what I just told you. This is a brief summary of where the fat can be deposited. So can we measure this fat? So what is fat? Can we measure this fat? Yes, we can measure this fat. Probably most of us have been measuring. Dr. Palinappan must have been measuring it in his clinic. By DEXA scan, MRI scan, BI, bioimpedance analysis, these are practical measures by which we can measure the fat. And by definition, now probably it will be one of the criteria where you need to define the obesity. Bioimpedance analysis is a practical thing, which is a simple machine which you can find in your gyms or you can place in your clinics or in the research labs, and it helps you to give a good amount of knowledge about the fat content and the muscle mass in the body. DEXA scan, a costly machine, but it gives you the accurate quantity of the fat, which is fat and the muscle distribution in the body. This is a simple bioelectrical impedance machine which we are using in our hospital at Lady Harding and quantifying the fat and the muscle in the patients. So what is the cutoff for the obesity? So as the traditional cutoffs have been there, which have been discussed already, that BMI of more than 25 is labeled as obese, particularly in Asian population. And there are certain markers of obesity which are for waist circumference more than 90 centimeter or more than 80 centimeter, and their waist hip ratio, body fat percentage. So these all have been discussed, and probably we are all aware of this. But the fallacy of BMI, classifying BMI, is that it may underrate or overrate individuals who are obese, but they are not classified as obese, and who are not obese and they are classified as obese. For example, an athlete who has got a lot of muscles, he may be misclassified as obese based on his BMI, and someone who is lean and thin with a low BMI may not be classified as obese. So we all have been witnessing these type of problems based on the BMI, and so this is the latest definition of the obesity which has come in, and it requires the confirmation of the excess or the abnormal adiposity by one of the following methods. So this is important, that we need to measure the body fat, direct body fat measurement by the method which we have told, and requirement is that at least one anthropometric criteria in addition to the BMI. So earlier we were just classifying the obesity on the basis of the BMI. So now the classification will require at least one more additional anthropometric measurement, like waist circumference, waist to hip ratio, or waist to height ratio. Or if you want to avoid the BMI, then there should be at least two anthropometric criteria. So the clinical obesity definition will require, this is again something different which has come in this year, that some obesity is different than the clinical obesity. Clinical obesity requires you or us to define that there has to be an anthropometric measurement or the direct body fat measurement plus one of the following criteria, that it requires a clinical definition. Clinical definition means that now we are recognizing obesity as a disease. So as we recognize obesity as a disease, it should have some clinical manifestations also. So for the diagnosis, it requires that there should be some evidence of reduced organ or tissue function due to obesity, or significant age-adjusted limitations of day-to-day activities. So this is a new thing which has come in, that obesity needs to have a clinical definition just rather than just measuring the BMI or the waist circumference. A brief discussion about the obesity pathophysiology, that energy intake is all which counts to the obesity, and there are many genetic and environmental factors which contribute to obesity. There are obesogenic gene and environment interactions which lead to obesity. Amongst them is, of course, the increased availability of the palatable food, altered consumption of the patterns like something eating in the night time, decreased physical activity, alteration in the sleep patterns, and the previous speakers have already told you about the problems of the various social and the psychosomatic problems which also increase the obesity. There is also communication between the brain and the adipose tissue and the gut. So three things are there: the brain, the adipose tissue, and the gut, which talk amongst each other. And this is the beautiful diagram which probably explains us that how our gut, our brain, and the tissues interact with each other. Hormones are like leptin and the adiponectin, GLP-1, which the previous speakers have already talked about. The hormones like ghrelin and the distension of the abdomen or the stomach or the intestine, which contributes to our hunger or to satiety. Two hormones need to be emphasized here. One is leptin and one is the ghrelin. You can say one is the hunger hormone and one is the satiety hormone. So leptin suppresses the appetite and ghrelin stimulates the appetite. And these are probably responsible and where we can actually control our physiological needs of food. This is the main topic for which I have which I'm talking. Types of obesity are that there is a genetic obesity, secondary forms of obesity, and the primary obesity. This is a classification by cause. Then there is a phenotypic classification of the obesity, which is the metabolically healthy normal weight, which are the normal individuals, or there are metabolically unhealthy obesity. That means the usual obesity which we see where there may be some central deposition of the fat and also a subcomponent like the sarcopenic obesity. Then another component of the obesity is there, which the previous speaker has told, that there is a entity known as where the weight is normal, but the patient may still have obesity. So these are the metabolically unhealthy non-obese patients. Sarcopenic obesity is the coexistence of sarcopenia and obesity, particularly in diabetics, as you can see in this patient, that he seems to be thin, but he has got a pot belly, and this imposes him for the risk of obesity. This is a paper which we published recently on the sarcopenia in adults with type 2 diabetes, where we found that more than 40 to 50% of the diabetics had sarcopenia. This was done in Lady Harding under the supervision of Dr. Anupam Prakash sir. And do these phenotypes have a different risk in terms of chronic diseases? Yes, metabolically unhealthy obese, the obese which we usually see, they are at a higher risk than the metabolically unhealthy normal, and then those who are normal weight patients. But yes, this is a spectrum. The patients which we see that they are now lean and thin and they are metabolically unhealthy, they have a tendency to become obese in the near future. So it is the time that we need to screen these patients. We need to control the metabolic risk factors which these patients has, and to be more aware. Just to be brief about the interventions which we can do, a macronutrient approach or a dietary modification or the time, we can increase the time window when we eat. So reducing the portion size is one of the major thing which I will like to emphasize, that it is not certainly possible to say skip meals, but of course when we take the meal, then we can at least decrease the portion size of the meal, and it should be a balanced meal whenever possible. Of course, at this time of the day when good supper is waiting for us, it will be very not nice to say about this. And the energy restricted diets are there, where we can reduce 0.5 kilogram per week and around 2 kg per week if we reduce the calorie intake daily about 500 calories. But as already spoken, that the weight which we lose by restricting caloric diet, it may not stay for quite long, because there are compensatory mechanisms in the body which try to regain the weight. So it becomes very difficult. Similarly, high protein diet is one of the ways where it is particularly important in patients who do not have much weight, or in patients in which we want to reduce the weight, but at the same time we do not do it at the cost of reducing the muscle mass. But the problem with this is that the poor palatability of the proteins, it may not help in the high protein diet intake. Then there are low carbohydrate diets, low fat diets which are available, which I may not be able to tell you because of the paucity of the time. So just yoga, which is again important, and as we are celebrating the yoga day tomorrow, so it is one of the methods by which we can incorporate in our daily life and probably help in maintaining our weight and balance. And there have been many studies which have been done on this particular aspect, where they have advocated 3 times per week, or with increasing the heart rate to 65 to 70%, and doing it like the other aerobic exercise, and the results have been commendable. So pharmacotherapy I am not going to discuss over here. Coming to the key message which I should deliver, that we should understand now that obesity is the common root. We should recognize the obesity as a root cause of most non-communicable diseases, and obesity is not just a risk factor, but it is a disease in its own. We should think of something which is beyond BMI, supplement the body mass index with other tools, as the newer classification has said. The treatment has to be personalized. Someone requires more protein, someone requires less calories, and encourage the small portion sizes and the longer gaps between meals to support weight management. So thank you for your patience listening.
Thank you very much, sir.
Thank you.
May I call Dr. Soumya, CMC Vedu Internal Medicine, to talk on pregnancy with cardiovascular disease. Please, ma'am.
A very good evening to all. As a chairperson, it's a great honor to introduce Dr. Soumya, my colleague. She's from the Department of Medicine. She's the Human Resource Director for Christian Medical College, Vellore. She's got a lot of international and national publications in her name, and she has started the Department of Obstetric Medicine in our institution. Thank you, Dr. Soumya, and please go ahead with your talk.
Thank you, Dr. Ramya, and I'd like to thank the organizers of TAPICON for this privilege. I'm actually a physician, but we have a peculiar subspecialty called obstetric medicine. And a lot of people actually ask me, I'm an obstetrician, but actually I'm proud to be a physician, but looking after a certain subspecialty which is unusual but has given us great joy. I'm looking at an overview of pregnancy and cardiovascular disease. Already pregnancy and diabetes has been touched on, hypertension also, and we're looking at cardiovascular disease. The outline of my talk will look at trends in cardiovascular health in pregnant women, look at the burden of cardiovascular disease or CVD in pregnancy, just a brief overview of short-term impact and a long-term impact and the way forward. So CVD in pregnancy, is it an issue? Obviously it is, that's why we are talking about it. So very funnily, for a pregnant woman, it's like doing a stress test. You ask a pregnant woman to run constantly every day for the 9 months, and that's what she's doing, and the burden that it goes on the cardiovascular system. And as you can see in the diagram here, that over the trimesters, the output increases, the blood pressure decreases in between because of some vasodilatation increases again. Heart rate is up, and the vascular, systemic vascular resistance reduces. These are all a combination of factors to aid in delivery. But if a woman has already got a cardiovascular disease, then pregnancy will worsen this outcome. And there are trends in maternal morbidity and mortality to say that nowadays we are more worried about something called as indirect maternal deaths. And in the high-income countries, they found that indirect deaths are becoming more common, and cardiac disease in UK was the single largest cause. Of course, for middle and low-income countries, there is a shift of incidence from direct to indirect. We do have more nutritional and communicable diseases, but slowly it's moving to the same point where it is in the West, where indirect causes may become very much more common. So when you look at Indian data from 1997 to 2020, as you can see, it is still obstetric causes, different in different parts of the country, but you're getting hypertensive disorders, which is slowly creeping up over here, and the other indirect cause. If you add them both, it's going to contribute quite a lot to what will contribute to maternal morbidity and mortality. With changing trends in the way people are living lives, there's also the issue of shifting of childbearing. So before, where 20s used to be when children would be born, now a woman chooses to be pregnant in 30s or 40s based on their, going for work and other lifestyle issues. So this results in an increased number of pregnant women with chronic hypertension and coronary artery disease. Then there are women who are opting for in vitro fertilization even at an older age. And there's also an increase in number of patients with congenital heart disease, because these women have either been repaired in childhood or they're still being monitored and they're able to tolerate it because of increased levels of monitoring and interventions. So all this adds on to the burden of cardiovascular disease and pregnancy. So why should this be of an interest to a physician? So the main reason we went into this about 10 years ago within the medicine unit that I work is that when people looked at why do women die of indirect causes, direct causes are very common, obstetricians will know more than me. It's just as a lack of clarity as to who will take care of this patient. What if they have an organ system failure, who will take care? And the biggest question that we have to ask ourselves is, can physicians bridge this gap? Among other gaps also, which is I've already mentioned, but the gap of ownership. Who will take a woman who is pregnant but has a chronic medical disorder? So when we started many years ago, this is our own data, we realized that we had an impact on maternal mortality, which was quite significant. So the maternal mortality rate came down drastically after we started the service. I'm not taking only claim to that, but we did know that we had an impact when we started working closely with our obstetric colleagues. So let's look at the burden of CVD in pregnancy. When you look at Western data and look at the types of disease, there is congenital heart disease and valvular heart disease being almost equal. But if you look at the registry on pregnancy and cardiac disease, which was supported by the ESC,
They again said developed countries has 74% congenital heart disease, and almost equal at par, 72% was obviously in rheumatic heart disease from developing countries. And that's what we still see in India today. I'm just presenting some data from a group in Chennai, Dr. Justin Paul, who's a cardiologist, and his team looked at pregnancy outcomes in women with heart disease. They compared, and they also found that if you look at MPAC, which is what their study was called, 54% of them were with valvular heart disease, 33% with congenital, and 12% was others. And if you also look at which category they came according to the WHO classification, they were all a little more sick. And this is a group that I've been working with because they have involved CMC Velo also in their pregnancy registry. But the scary part is that what they found in the MPAC study here in Tamil Nadu is that the first diagnosis of heart disease was during pregnancy for 60% of the pregnant women. And there was a high maternal risk predictors. They also had a problem that they had also high maternal mortality and morbidity, rheumatic disease being more common. So the take-home message they said is we should have a multidisciplinary team approach, what they call as cardio-obstetric. And we are in a unique position as physicians to actually take this on. So now we are doing a national registry after the Madras, the MMC one. We are all involved in a national registry. So far in the last almost 10 to 11 months, we have had 51 patients with cardiac disease. And we are also seeing a large percentage of a combination of congenital and rheumatic heart disease. And this points to the fact that obviously people with congenital heart disease are either getting repairs or they're having procedures which helps them to get to this point. This is something about the outcomes in those mothers that we have seen, but I want to pause on this. Being a referral center, we can also see that if you go by the classification of WHO for maternal cardiac disease, we are getting patients across all. Majority of them are in WHO class 1, which is a lower class, but class 3 and 4 also has about 12 patients, as you noticed. And this is the primary composite outcomes. The study is still going on, but this is what we have till so far. And you can see, despite us having all the resources, we have 10 out of the 51 patients actually went into new onset heart failure or worsening heart failure or a sustained cardiac arrhythmia. And 3 of the patients also needed urgent cardiac intervention. So best case scenario, they come to you pregnant, they are found to be having a cardiac disease during pregnancy, but how much ever you do, there is a danger that you may lose this life. So recognizing heart disease and risk, there's a unique dilemma in the Indian context. Patient is unaware or aware and they don't want to tell you, or they don't want to tell the family. The doctor may be unaware of the disease, consequences of disease and drug. And as mentioned earlier, late pregnancies increase the incidences of acquired diseases like hypertension, cardiomyopathy, and coronary artery disease. So when you look at the short-term impact, what can we do to help these women? You really don't want a young woman in their 25 or 20s or even 30s die of a physiological process. We call pregnancy physiology, but when they have a pathology, they're going to die. So who does the preconception counseling? Actually, anybody can do it. And as physicians, when we see them prior to them being married, I think it's a good time to say, hey, when you go ahead and you marry and by culture you will be pregnant, you have to take care of yourselves. And maybe we can think about it earlier. So anybody in this group can do preconception counseling. So the main advice during preconception counseling would be optimize medical status, adjust the medicines to be safe in pregnancy, and also do a risk assessment. So what do the cardiac risk assessment tools need? Clinical information, which everybody also has stressed on saying being most important. Do an echo, look at the cardiac lesion, and then look at what level of hospital can take care of this and when do you refer. Risk assessments, we have the known score, which is the maternal WHO scoring, the modified WHO scoring. But there are 2 other risk scores that can be used. One is the CARPREG-2, where increasing scores show worsening outcomes in pregnancy. And they're looking at a combination of diseases. The Zahara score is actually for congenital heart disease, same increasing risk with increasing score. But what we use commonly, I'm sorry for the small handwriting, is actually the modified WHO class, where with increasing class, even with class 4, you may have to actually tell the patient that they can't be pregnant. But inevitably, people come pregnant past the date that we can even advise a medical termination, and they will be in class 4. So that's the burden that we deal with. Medications, of course, all of you all know the medications that are safe, but we are looking at pregnancy and lactation. Mostly are safe other than for ACE inhibitors, but in lactation ACE inhibitors can be given, but ARBs are not safe. Diuretics, we have had people on 4 antihypertensives. It's been a combination, it's been difficult. Other medications include antiplatelet agents, both of which can be given. Anticoagulants, there's no information on NOACs, but you have to remember that in a pregnant lady, you can't actually do a study on them. You can only take anecdotal data and go backwards. But warfarin less than 5 mg is less associated with embryopathy, only more than 5 mg. And also when you counsel, with certain diseases in the mother, the child can also have a risk of that disease, and that has to be told. So along with preconception advice, what else can we do? It's a team-based approach, and we are proud to say that we've been able to work with the obstetricians, the cardiologists, the neonatologists, and the anesthetists, and I think it's easier for us, obviously, because we are a tertiary care center. We look at the type of delivery. The obstetrician colleagues will come in with what is possible. Postpartum, we of course monitor them closely. If they have a decompensation, they go into a ICU setup. And the 4th trimester, which is becoming important, a lot of my other colleagues today have spoken about postpartum air times, where you really have to advise a contraception. And long term, they will be at risk for adverse pregnancy outcomes. And so CVD risk screening has to continue. Just to look at the long-term impact, as much as one choice is for us to deliver the baby, somehow keep the mother safe through the pregnancy, what happens to these women once they have run the race of a stress test with cardiac disease and pregnancy? This is just one study that I'm going to start on, looking at the long-term cardiovascular outcomes after pregnancy in women with heart disease. So there was a primary outcome in these 298 women, which was 25.3 events versus 1.1 events in women who were not having a cardiac disease and had got pregnant. So that's a huge statistic. So if you just look at this graph, you can just see, if you look at that time to event scores, it's really, really scary, where it's just shooting up 20.1% at 10 years and 33 at 20 years for women who had heart disease and became pregnant, versus there's just a 2.1 little line over here in red for those who were not pregnant and had cardiac disease. I mean, women who got pregnant but without cardiac disease. So when you look at each of these outcomes, you can see at 20 years, heart failure, atrial fibrillation, therapeutic cardiac procedures, new onset hypertension, diabetes, all much more in women who became pregnant when they had an underlying cardiovascular disease versus women who were pregnant without the same. So the clinical implications is that we have to survey and modify them, have risk factor modification even beyond pregnancy. But in this study, they use the same tools, the WHO score, to predict future risk. I'm showing in green what we do as a checklist for care protocol. We should start in the schools. This is about at adolescent health. We should do health information for unmarried women in cardiology and general medicine OPDs. We should do risk assessment of pregnant women coming to obstetric OPD. Now we do everything in green. That is the evaluation of clinical status, investigation, optimization of drug medications, form MDTs. We do that. But the long-term follow-up, we also have to say, we're sorry, we are not yet at that point, and we should actually do it. As I'm speaking about it, I'm conscious of it. So I'd just like to thank you and thank my team. As we said, we are a team of obstetricians, physicians, and many other people. I'd like to thank the organizing committee, and truly, as we see with TAPICON, it's a team effort, and my work is also a team effort. Thank you for this. Thank you for this opportunity.
Thank you, madam. Shall I call Dr. B.K. Singh, the next speaker, to talk on the important talk, ADA 2025, what is new? Please.
So Dr. B.K. Singh.
Thank you, chairpersons. And first of all, I want to
At the outset, I want to thank Dr. Palaniappan and his team for giving me opportunity to speak on this platform of TAPICON.
Sir, can I introduce you, sir?
Yes,
I'm
please.
introducing Dr. B.K. Singh. He's a past chairperson of API Bihar chapter and past chairperson of RSSDI, chairperson of CCDSI Bihar and Jharkhand chapter, and he's been the chairman of Indian Association of Clinical Medicine, the Bihar chapter. He's a governing body member of National API and regional and national faculty. He's got multiple publications and papers in index journals and of national and international repute. We welcome you to give your talk, sir.
Thank you. Thank you once again, Chairperson. And good evening to all of you. It is not moving. Yes, now moving. My topic is the ADA 2025 standard of care. What's new? You all know the field of diabetes care is rapidly changing. And American Diabetic Association has long been a leader in producing guidelines since 1989. The 2025 standard of care in diabetes has continued to incorporate person first and inclusive language. Many society has endorsed different sections like the Bone and Health by the American Society of Bone and Mineral Research, Obesity and Weight Management in Section 8 by the Obesity Society, the Cardiovascular Risk and Risk Management by the American College of Cardiology, and Older Adults Section 13 by the American Geriatric Society. I will go one section by section because this is my perception that what are the most important part of the ADA updates. In section 1, the improving care and promoting health in population. This first, the recommendation was expanded to include not only the diabetic population, but the people at risk of diabetes is also included in the improving care and the promoting health section. The recommendation 1.2 was revised to include, in addition to the chronic care model, other evidence-based care delivery model like patient-centered medical home model and other home model should be advised. And the interprofessional team for supporting sustainable and scalable process changes that improve quality care and health outcome. In the section 2 of diagnosis and classification of diabetes, there is one table 2.3 was added to provide consideration related to the use and interpretation of laboratory management of glucose and A1C, and how, in what condition you can use this glucose measurement, or in what condition you will use A1C. In the type 1 diabetes subsection, recommendation 2.7 was added to emphasize the importance of antibody-based screening for pre-symptomatic type 1 diabetes individual with a family history of type 1 diabetes or otherwise known elevated genetic risks. And the classification section have updated to provide a pragmatic approach to management of individuals who have feature of both type 1 and type 2 diabetes, that is the double diabetes. In prevention or delay of the diabetes-associated comorbidity, the lifestyle behavior change for the type 2 diabetes prevention subsection, sleep health is in relation to the risk of type 2 diabetes was added. Means the sleep is a central component in the management of pre-diabetes and diabetes, placing it other form of the lifestyle modification like the diet, exercise, and socioeconomic burden. The recommended 315 were added selected individual aged 8 years or more with stage 2 type 1 diabetes about the role of teplimumab infusion to delay the onset of symptomatic type 1 diabetes mellitus. In section 4, the comprehensive medical evaluation and assessment of comorbidity, a new subsection of dental care was added. The diabetes diabetics should be preferred to a dental examination at least for once per year. A new subsection of female sexual dysfunction was added. Healthcare professionals should inquire about the sexual health, particularly in women who experience depression and or anxiety and those with recurrent UTI, maybe with this SGLT2 inhibitor. The NAFLD and NIS was updated to metabolic dysfunction associated steatotic liver disease and metabolic dysfunction associated steatohepatitis respectively, means the nomenclature was changed. And the recommendation was 4.3 was added, amended to state that the adult with type 2 diabetes or prediabetes and a FIB score is more than 1.3 should have additional risk stratification performed. The recommendation 4.2 was added to state that the treatment with thyroid hormone receptor B agonist in adult with type 2 diabetes or prediabetes with MASLD and with moderate or advanced liver fibrosis may be considered. In section 5, the felicitating positive health behavior and well-being to improve health outcome, the diabetic self-management education supported subsection 5.1 was updated to emphasize that all people with diabetes should be advised to participate in diabetes self-management education and support rather than just being incorporated. Means all diabetic patient or diabetic patient should be advised for this DSMES participation. The recommendation 5.3 states that the IDF and Ramadan International Alliance comprehensive pre-fasting risk assessment for the people of the diabetes prior to engaging in religious fasting. And the new recommendation 5.4 added to advise people with type 1 diabetes and those with other form of diabetes a risk for diabetic ketoacidosis or not to use recreational cannabis in any form due to the risk of cannabis hyperemesis syndrome. The glycemic goal and hyperglycemia, a new subsection entitled that the hyperglycemic crisis diagnosis and management and prevention was added, and the new recommendation on routine assessment of history of DKA and HHS and providing structured prevention education in the outpatient setting was added. In diabetes technology, which is very important part in section 7, the consideration of continuous glucose monitoring used for adult with type 2 diabetes on glucose-lowering agent and other than insulin. Even in the CGM can be applied the patient who are not using insulin or using the oral anti-hyperglycemic agents. The recommended 7.1 added to consider the use of the RT-CGM and the intermittent scanned CGM in adult with type 2 diabetes on glucose-lowering agent other than insulin, and the recommendation 7.1 was modified to align with 7.15 the management of diabetes in pregnancy and reflects an update of CGM benefit in type 1 diabetes with pregnancy and other type of diabetes in pregnancy, means that the CGM can be applied in the pregnant patient with diabetes. The obesity and weight management for the prevention and treatment of type 2 diabetes, the guideline address the weight management pharmacotherapy beyond the goal of simply lowering blood sugar and emphasizing the importance of addressing the other aspect of the metabolic health. So other recommendation added to command the continued weight management pharmacotherapy and avoid weight gain and worsening of the cardiometabolic abnormality that often result from the sudden discontinuation of weight management pharmacotherapy. So sudden discontinuation should be avoided in this case. So, section 9, the pharmacological approach to the glycemic treatment. The beyond blood weight loss GLP-1 receptor agonists are now recognized for their benefit in heart and the kidney health. And recommendation 9.12 was added to recommend the use of GLP-1 receptor agonist with demonstrated benefit in the individual with type 2 diabetes, symptomatic heart failure with preserved erection dysfunction, and the obesity. And this 9.13 revised to recommend use of either SGLT2 inhibitors or GLP-1 receptor agonist with demonstrable benefit in the individual with type 2 diabetes and CKD. The recommendation 9.15 and 9.1c were added to recommend treatment of the individual with type 2 diabetes mellitus and MASLD and MAS with GLP-1 receptor agonist or the dual GIP and GLP-1 receptor agonist or pioglitazone or combination of GLP-1 and pioglitazone based in staging of the liver disease with risk and need for weight management. Cardiovascular risk management, which is added to recommend that most cases lipid-lowering agents should be discontinued prior to the conception and avoided in sexually active individual of childbearing potential not using reliable contraception. So unless the benefit may outweigh the risk, means that the pregnant patient or the childbearing age patient, this should be lipid-lowering agents should be carefully used. In chronic kidney disease and risk management, one section was updated to state that the people with type 2 diabetes and CKD, a GLP-1 receptor agonist with demonstrable benefit in the population should be used to reduce cardiovascular risk and kidney disease progression. And also in recommendation 1 added that the potentially harmful antihypertensive medication in pregnancy should be avoided in sexually active individuals of childbearing potential not using reliable contraception or to switch to option considered safe to the conception or during pregnancy. The retinopathy, neuropathy and food section that the patient should be sent to the ophthalmologist once in a year if, or frequently if the retinopathy is progressing. And in neuropathies, an Ipswich test should be an optional for neurological element because it is of no cost. In older adult, the 4M framework, the age-friendly health system, as it applies to the diabetes and older was introduced, and and recommendation was modified to include the time in and time below range in addition to A1 treatment goal for older adults who are otherwise healthy with few and stable chronic condition and intact cognitive function status. The children and adolescent, the recommendation was changed to state that the insulin pump should be offered to anyone with type 1 diabetes who can use the device safely. And the other terminology has changed that the hyperglycemic hyperosmolar non-ketotic syndrome to the hyperglycemic hyperosmolar state and include the intravenous fluid management as the initial step to treat severe hyperglycemia once the diagnosis is confirmed. Management of diabetes in pregnancy, the management of gestational diabetes mellitus, and management of pre-existing type 1 diabetes and type 2 diabetes in pregnancy were merged in a one subsection titled Management of Diabetes in Pregnancy, which includes all aspects of management of all type of diabetes. The CGM may be used in conjunction with blood glucose monitoring to achieve glycemic control during the pregnancy state. So CGM can be applied. And in diabetes care in the hospital, the recommendation 16 was updated to state that the glycemic goal is 140 to 180 milligram per DL is recommended for most critically ill individual, but more stringent individual glycemic goal may be appropriate if they are achieved without significant hypoglycemia. The recommendation was updated to recommend that the glycemic goal of 100 to 180 for most non-critically ill individual, or it can be achieved without significant hypoglycemia. There is a subsection, last section, the diabetic advocacy, the subsection diabetic care in school setting, which is very important. The school-going children should be educated of the metabolic diseases, and that is the point where we can achieve targets. And the diabetes and driving are updated, and the subsection of diabetes management dietitian detention facility was added with information from recently published advocacy. This is all about the updated ADA guidelines, which have been published in the December 2024. Thank you very much. If anyone can add to the other portion of ADA guidelines, they are welcome.
Thank you so
Thank
much.
you.
Thank you so much, sir. That was a very quick update you gave on the entire document. Thank you so much. And you covered the very key highlight points. Thank you.
Thank you.
Thank you, sir.
Please, all the speakers, please get into the dais to receive the memento. Dr. Ramya madam to give to Dr. Soumya, please. Dr. Lavanya to give to Dr. Chandrasekhar. Dr. Jayasudha, please to Dr. Ramesh Agarwal. So may I request Dr. Palniappan to give a memento to Dr. C.K. Singh? B.K. Singh. May I request Dr. Palniappan to give memento to the chairpersons, please? Dr. Lavanya. Memento to Dr. Ramya madam. Madam, Ramya.
So good evening to one and all, my dear doctors. Actually, it's been a great pleasure to host our TAPICON first time at Vellore. So it's been very happy to see so many faces from travel long way from all over Tamil Nadu and actively participating this academic feast. Hope you all enjoying. So now I'm going to announce the TAPICON 2025 preliminary round quiz. How many of you PGs can you raise your hand? Okay. Are you eager to get to know your results? How many of you participated in quiz? Yeah, okay, that's good. Nice to see. Actually, more than 1 or 2 people participated in the preliminary round quiz. So we need to give a big applause for that, for your enthusiasm showing to attend this quiz. Now I'm going to announce top 6 teams out of 52 teams. Okay. So from 6th team, okay, any guesses from which college? No? So actually the 6th team from Coimbatore Medical College and Stanley Medical College by Dr. Karthik from Stanley Medical College and Dr. Sailendra Prasad from Coimbatore Medical College. You have big hands. So next we move to the 5th team from SKS Hospital Salem and Stanley Medical College Chennai. Okay, so Nikila from SKS Hospital and Snehitya from Stanley Medical College. Your big hands. And 4th position from Madras Medical College, Preeti and Bakshay Kumar. And next is the 3rd position again, Madras Medical College from Prasanna and Dinesh Kumar. 2nd position from Government Mohan Kumaramangala Medical College, Salem. Any of you here? Yeah, good. So Vignesh Iyer and Jacob. And 1st place, any idea? So I'll tell the name. Vignesh and Madhumita here from Kaveri Hospital, Chennai. I think no one here. Okay, please we'll share this information to the PG groups, and this top 6 candidates go for the final round quiz tomorrow at Pokers Hall at 10:30 to 12 p.m. Okay, at Pokers Hall. Get ready for the final round, and thank you.